we have appreciated that to achieve the 6 pillars of the health system, human resources for health is indeed going to be very key. And when we talk of human resources for health, we certainly include skills such as our good community pharmacists. We've also appreciated that achieving universal health coverage without strong involvement of the private sector will delay the results that we wish to see. And this team, this gathering, enforces that, enforces the involvement of the community and the private sectors. As I lead the strategic health information, we've appreciated the challenges of making policy decisions, trying to generate the evidence when we are only basing this evidence on public health sector data. How about the private sector data? In all our pharmacies, we have the government policy of the integrated HMIs. However, we know the level of contribution of the private sector in the HMIs. And this has somehow flawed the decisions that we've been wanting to make. So it is our appeal, indeed, that working with associations such as ACPN, we get to have a holistic picture of this good country we call home. With those few remarks, I would like to begin by inviting the first speaker, Professor Wilson, who will share with us a little more about this topic of community pharmacist involvement in the primary healthcare services in Nigeria, a call for sustainable policy direction. So, Professor, you're most welcome.
Yeah. Yes, I will be looking at, good morning, fellows of the Pharmaceutical Society of Nigeria, fellows of the Nigeria Academy of Pharmacy, fellows of the West African Postgraduate College of Pharmacists, and distinguished colleagues. I want to recognize the opportunity that was given by the ACPN National Chairman to be here, and I want to appreciate the ACPN for giving me this opportunity. I'm going to be looking at this topic from the perspective of promoting community pharmacists' involvement in primary healthcare activities in Nigeria. I believe that what we need now is evidence-based approach in our interactions. Of course, the components, the basic elements of primary healthcare, we do know. I'm not going to bog us down with that. But suffice to say that from my own interactions, it's come to be clear to me that community pharmacists have a role to play and are ready to get involved in immunization activities, including COVID-19 testing and educational services. Why do I say so? We interacted with the ACPN, and we got thinking and talking when this COVID pandemic was coming into our own nation, and we thought that community pharmacists should begin to get prepared in terms of having to do testing and all that. So we got into this relationship, which was partly sponsored by ACPN, and 3 of us undertook the project basically, including the national chairman of ACPN, Samuel Adekola. And the essence was to we know as the background that the NCDC announced the need to scale up access to COVID-19 testing between May and September 2020. We are now in December. And of course, this was in anticipation of the spread that was going to be taking place. And we felt that community pharmacists can be mobilized to be part of meeting this goal, since they are closest and the most accessible healthcare practitioners in the communities. The aim of the investigation was to assess the community pharmacists' knowledge, preparedness, and willingness to get involved in COVID-19 testing. I'm just taking a few excerpts from that study. In terms of some of the social demographic data, the pharmacists we studied, we have years of practice. We had about 359 of them who were part of this study. That is the distribution in terms of years of practice. In terms of educational qualification, that is the distribution. In terms of the spread across the various zones, southwest right down to northwest, that is the distribution. And then we wanted to know, in terms of clinical pharmacy practices that are carried out in the community pharmacies, we took them, classified them as filling and refilling of prescriptions, consultation with patients, point of care testing, be it blood pressure or diabetes, blood sugar screening, or comprehensive lab services, and then immunization services. I just want to highlight the fact that the major deficiency we see here in terms of all of these activities has to do with immunization services. And you see that for that, you just have about 82.7% of the community pharmacies were not involved in any form of immunization service. And we now try to see how many of these community pharmacies actually are involved in clinical services in terms of number. And majority, about 65.2% of these are actually involved in at least 4 of those 6 components we identified. How prepared are community pharmacies for COVID-19 testing? We looked at the various criteria. Do they have a ventilated isolation room? Do they have hand washing apparatus? And all of those features that are indicated. But I want to highlight the fact that for hand washing apparatus, it was indicated that about 6.4% of those that participated in this study did not even have any hand washing apparatus. That is more important to us than the 93.6% that are in the positive. And also, in terms of sanitizers stationed at the entrance of the pharmacy, 7.2% of these actually did not have that. That number to us is even more important than the 92.8%. And then talking about foot-operated pedal waste bins in the pharmacy, about 72% of them also do not have something like that. And we thought that some of these things are necessary when you are going to have to be involved in COVID-19 testing. We tried to assess the knowledge of pharmacists, the participating pharmacists on COVID-19 and its testing. And surprisingly, one of the responses was that COVID-19 is a viral disease. That is true. But surprisingly, 3 of the pharmacists got that wrong. And of course, you have the other things that we also looked at. Willingness to get involved in COVID-19 testing. Will you be willing to be trained on how to use the test kit for COVID-19 testing? Yes. 90.5% said yes. Will you be willing to be involved in COVID-19 testing? 83% said yes. Will you be willing to allow your pharmacy to be used as COVID-19 testing center? 66% said yes. And will you be willing to allow your pharmacy to be used for COVID-19 testing center with the test conducted by other medical personnel? 51% said yes. We also, another study that we carried out led us to say that community pharmacists are actually capable and ready and willing to get involved in HIV/AIDS testing, as well as ARV medication management therapy. If somebody has said that without the involvement of community pharmacists, it will be difficult for 90% of the Nigerian population knowing their status in the very near future. The 90-90-90 treatment target to help end AIDS epidemic is expected that by 2020, 90% of all people living with HIV/AIDS, living with HIV, will know their HIV status. By 2020, the year we are in December, 90% of all people with diagnosed HIV infection will receive sustained antiretroviral therapy. It's expected that this same year before it ends, 90% of all people receiving antiretroviral therapy will have viral suppression. But the reality is that we are very far from this. And so we looked at promoting community pharmacists' involvement in HIV services through educational intervention in Nigeria. My PhD student, Yejide Oseni, she would have finished, but for the ASU issues. This work we presented at the virtual 80th FIP World Congress, the last FIP Congress, virtually. And this particular presentation was selected by the FIP to promote 2020 World Pharmacy Week on the FIP social media channels. And we found, in terms of just taking excerpts from that study, screening tests undertaken by pharmacy clients. We tried to ask the clients that visit pharmacy, have they ever carried out any screening test in any pharmacy that they visited? About 4,075 clients were interacted with. And then for blood pressure, 60.4% said they have done that in community pharmacy. Blood sugar test, 38.9% said they've done that. Malaria parasite test, 48.2% said they have done that. And then, of course, the HIV test services, only 22% said they have done that. So we have opportunity to be able to scale up this. And then in terms of willingness, we ask the clients, willingness to participate in HIV screening in the community pharmacy. Will you be willing to participate in this? If this service is rendered in the community pharmacy, 77.4% of these said they were willing to patronize community pharmacies for that particular service. Our conclusions from this study is that community pharmacists were involved in the provision of screening services and also indicated favorable attitude towards providing HIV/AIDS services. Pharmacy clients were willing to receive HIV testing services in community pharmacies to increase the knowledge of their HIV status. And HIV/AIDS services provided by community pharmacies significantly increased after their training. We actually did a training, and as we talk, the study actually had a lot of things revealed, which will be very useful in terms of incorporating community pharmacy in the scale-up of HIV/AIDS interventions. And training we found to have an impact in the provision of services and will help community pharmacists to also develop the skills required for their extended role. What is the way forward for us in terms of recommendation? Community pharmacists in primary healthcare services. We need to employ or train more hands to assist community pharmacists in handling other activities. There needs to be some form of task shifting, no question about this, so that more time will be made available for patient counseling and other specialized services. We need to also restructure pharmacies in order to create adequate space conducive for services in public health issues. We need to be able to collaborate more with other healthcare professionals so that patients' data could be accessed. We need to create public awareness, a role of community and in terms of the role of community pharmacists as primary healthcare practitioners. And of course, there's a need for continuous training of community pharmacists to bridge knowledge gaps. Collaborative practice amongst community pharmacists, we need to keep encouraging this. And there's a need for more political advocacy for inclusion of pharmacists in health sector governance. We need to develop uniform framework for documentation of customer interactions at the community pharmacy level. And there needs to be a legislation to clearly empower community pharmacists to administer vaccines. And finally, there should be a greater community pharmacy involvement in health education and health promotion activities. You may want to look at some of these other studies that we've done. We've just talked about the COVID-19, we've talked about HIV/AIDS. We have also looked at the issue of strengths, weaknesses, and opportunities and threats of providing professional services in community pharmacy. We looked at public health issues and also the issue of technology, and then documentation, malaria, sexually transmitted diseases, and then partnership patterns in community pharmacy, as well as family planning. This is just a tip of the things that we thought we should share with you at this time. Again, I want to appreciate you for your kind attention and patience. Thank you.
Thank you. Very kind of you. A big round of applause for the erudite professor. We missed out a very important person during the course, and it has to do with my poor handwriting. One of the key presenters for today is pharmacist Emeka Okafor of SFH. He is being represented here today by a woman of substance, a program manager from the biggest city in Nigeria, Lagos City, who is a program manager with Integrate E. It's a great honor to call on pharmacist Bolaji Oladejo to please take a seat on the I. This is not the I table, this is the I seat or something like that. Okay, in the front seat. A big round of applause for her. Thank you. That's it. Thank you. Thank you so much, Professor Aaron. We will capture some of the bullet points. We capture it at the end. It's time for us to listen to another 10 minutes presentation by another erudite woman, a woman of substance, a very practical community pharmacist who have been a great mentor to me for several years, Mrs. Folasha Dilawa.
Let me
Good morning, distinguished fellows and colleagues. I want to appreciate ACPN executive for this opportunity they have given me. My duty today is to run us through services that we do in community pharmacies. And I have a lot of slides, so I will try to rush because I'm told I have just 10 minutes. So we look at, well, a lot has been said about primary health care, so we'll just rush through. We'll talk briefly about roles, our involvement in primary health care, and then we'll look at a case study and decide on a way forward and conclude. So as we all know, health is wealth. And primary health care, comprehensive primary health care is basically about health promotion and prevention, palliative care, rehabilitation, treatment, care, and management. And we as community pharmacists are positioned in all of this. So health promotion, we are there. Treatments, we are there, offering different kinds of services, MUR, pharmacovigilance, prescription servicing, pharmaceutical care, patient education. Then in rehabilitation too, we are there. We are offering medication therapy. We are offering pain management. We are relating with the caregivers, educating them, and educating the patients. Palliative care, we are also there. We do medication review, and we are also involved in pain management. So briefly, the benefits of community pharmacists' contribution to PHC is cost saving, there's reduction in morbidity and mortality, and we are inevitable to the achievements of SDG 3. We generate data, a lot of data in the community pharmacies. These data may be lying unused, but we have a lot of data in community pharmacies because we do a lot of things. Through community pharmacies, we can know disease patterns. We can change the story of Nigeria from no statistics to there is statistics because there is statistics. So we are usually the first point of care. We all know that we are highly trained. We are easily accessible. We are trusted in every aspect of the world. We are involved in disease prevention. And there are so many diseases that can be prevented through community pharmacies. Disease prevention in community pharmacies can also be achieved through promotion of healthy lifestyles, immunization, promotion of hygiene practices. And then there are so many tools too that we use, especially now that COVID has brought in a new normal. Many of us have gone virtual, and we are using a lot of virtual fora to reach our patients. So let's run through. We do extemporaneous preparations. Some of us are into vaccination. I have a vaccination unit. It's just that I had to engage a doctor to run that unit, and we have to register it now as a clinic because there's nothing backing it up. Then we do a lot of screening. We do different kinds of screening, including screening for breast cancer at the peripheral level, and then we refer as appropriate. We do health education, different forms of health education. We empower patients. We have what we call this medical diary that we give our patients to track their medical records by themselves. And then we do home delivery services, which is very key, not just delivering drugs. We go to homes to care for our patients, to do medication use review in their homes for them, and medication therapy management. I have a case here that I will not be able to look at because of time. Then we respond to symptoms of minor ailments in community pharmacies. We have a referral unit system that allows us to collaborate with other healthcare professionals because, as we all know, healthcare is multidisciplinary and collaboration is key. We follow up our patients. We don't let them run away. Now, this is one of the collaborations that we did, a group of pharmacists here and cardiologists, to position community pharmacies in primary care as people that can assess CVD risk. And we know that if we can assess CVD risk and intervene at that level, we're likely to change the statistics on CVD for the better. So we did this research in two formats. We first looked at attitudes, knowledge. We assessed that of pharmacists, and then we went further to do opportunistic screening of cardiovascular disease risk factors in community pharmacies in Nigeria. This document has been published, and I have a few copies to give to the people on the AI table. So these are some of the interventions we do as well. On this slide, we have two posters. One is talking about malaria. We looked at rapid diagnosis tests vis-a-vis malaria, and we found out that quite a number of people who claim to have malaria, by the time we run the test, actually do not have malaria. Now, we're able to do this because of a device called DecuReader. That DecuReader automatically records all the proceedings. It does the documentation, and we just go online to assess it. And then it also reads the disk. So we need to have more of things like this so that community pharmacists can be properly or maximally, optimally used to change the health story in Nigeria. There are some of these studies here that we can use to advocate for community pharmacies as primary health care providers. We do documentation. These are some graphical representations of reports that we did. We compared BP measurements in community pharmacy. In my pharmacy for 3 months, we looked at BPH assessments using IPSS score for some months. And then this is a very interesting story. This is a vaccine record called out from the software that we use. If we look at this record, I'm sure you cannot see, but I can read through it. From January to October we looked at quantity of vaccines that came out. And interestingly, the lockdown did not stop vaccines from being administered, because during the lockdown, what we did was to have training for the nurse that was there to empower her to be able to continue that service without exposing ourselves unnecessarily, taking all the necessary precautions. And people that were afraid to go to public sector came over to have their vaccinations done. So you will see there that we still had vaccine uptake every month throughout the year. We have MTM documentation formats, and then there are veterinary services. I don't do that in my pharmacy, but I know there's a colleague, Vanguard Pharmacy, that does a lot of that. Then in view, we are looking forward to being able to do COVID-19 rapid diagnosis tests in community pharmacies. Thank you, Professor Aaron, for considering that for us, and I know that you will champion it. So I brought here a case study of what we did recently for the World Diabetes Day. Because of COVID, we didn't gather people in the pharmacy, but we did everything virtually except for the test. What we did was we inaugurated a Victory Diabetes Club on WhatsApp, and it was interesting. We had a number of consultants coming, consultants from different angles, pharmacy, podiatrists, dietitian, they talked to them, ophthalmologists. And then what we did after that, we had about 5 days of screening. And what we did was to provide formats online and gave everybody slots. We asked them to go in there and take a slot. So we allocated like 20 minutes to each patient. You booked your slot, and then you would come in later on your slot to have the test done. Our aim was to identify people who are diabetic but did not know. We wanted to also look out for pre-diabetic patients. I wanted to also look out for patients whose diabetes was not well controlled. So our plan was to refer those with high blood sugar to GPs for further screening and diagnosis, work with the pre-diabetic patients to prevent them from going to diabetes as much as we can, help the diabetic patients with poor blood sugar control to identify why their blood sugar was poorly controlled. Please permit me to take us through this so that you will have a nitty-gritty of what we do. This is just a case study. So our target audience was adults 20 plus, and we planned to screen 150 people in 2 locations for that period. We ended up screening 143, and I think that was a fair outcome. So what we did, we chose a theme. How sweet are you? That was our theme. And then we came up with an SOP for those that were going to run the test. And then we also had forms for the patients to fill, for them to commit to further investigations if needed. For example, those who are diabetic and had not done their A1C for a while, we offer them A1C, we offer them lipid profile, because we run all of these rapid diagnostic tests in the pharmacy. And it solves a lot of problems, because there are so many people that are hospital phobic, and they will not go to the hospital, and they will be having a lot of issues. So we fish them out in the community pharmacy and refer them appropriately. So what happened? At the end of our exercise, we were able to get 6 people who had very high values that suggested they were diabetic and did not know. Then we had diabetics with high blood sugar values, they were 10. Then we had 11 that had blood sugar range within the pre-diabetic range. And out of them, 9 of them signed up for A1C. They came and did their A1C, lipid profile. We ran a cost of 52,700 naira. And then we got a support from one of our suppliers in kind, but it translated to 37,820. We had other supports like Lacena water, Alfred's water, which we gave them as takeaway. Now, this is what we did for the online platform. We had these questions for them to sign up, and then we also evaluated what we did. We wanted to know how we performed, and well, by this, about 80% of them said they learned a lot about diabetes. 20 said they didn't learn anything new. Any other comments? We asked for other comments, and some of them said, well organized. Vitri Drugs Management is doing a marvelous job for the society. I'm satisfied. I thank the Vitri Drugs team. God bless you all. It was indeed great. Lectures and screening made me to have a more knowledge of how to prevent diabetes. And then we had this interesting case for follow-up. Among them, I just brought one. Our random blood sugar was 250 milligrams per DL, and we asked her to do A1C. A1C was fine, 5.6. So something was definitely in the offing. And so we took her through the 360-degree view, and unfortunately, it's not so clear. I don't know how clear it is. But if we look at this document, it showed that she was already on metformin, 1 gram after breakfast, insulin, 28 IU in the morning. So she had problem with her money, and all the spikes, the highest values were after breakfast. So something was definitely wrong with whatever she was taking in the mornings. And she could not fathom it, neither could we fish it out for her. So what we did was to connect her to a dietitian. Now, our online platform that we set up, we have dietitians, podiatrists, they're all willing to work with us and help our patients. So we referred her to the dietitian, and they should still be managed by the dietitian. Now, challenges. We have a lot of challenges. We will not dwell on the challenges, but we need to look at those challenges so that we can chart a way forward. We are fully recognized for all of these things that we do. There are so many things that we do that I cannot stand here to say because I have just 10 minutes to do this and I'm trying to rush. We don't have legal backing, and that makes things more difficult. Imagine having to engage a doctor to run the vaccine unit that I can run. No policy in place. There's lack of structured primary care involving community pharmacists. There's insufficient drive by community pharmacists for recognition. I think probably the lockdown, the COVID, is now driving us to be more aggressive about it. We need to make that move because in other climes, the moves came from the pharmacists. I had the privilege 2015 to be in the UK for Commonwealth, and we were taking through some of their processes. And we found out that they went through what we are going through, but the pharmacists proved their worth. They had researches, they convinced the government that they would reduce their costs for them, and they did. So we need to come out of our shell. I believe that this event will not end here. We need to come out and show the world the stuff that we are made of, because we are made of that stuff. Paucity of evidence-based interventions, that's another challenge. We do a lot of interventions, but nobody knows about it. And so we're not known, we're not recognized for what we do. Suboptimal documentation, too, is another thing. And it's difficult. It's difficult, documentation is difficult because there's so many processes, there's so many procedures, the pharmacist has to attend to that, the pharmacist has to see the patient at the same time. So if we can have a platform, a software that will capture all of our documentations, and then we just press buttons and things are happening, you can always go back to look at it. It was just yesterday night I sent a message to them to send me that vaccine profile that they sent to me. A click of the button and we got the information that we want. We need that in community pharmacy. There is grossly inadequate number of community pharmacies in Nigeria. That is not debatable. Then there's rather poor distribution of the few available community pharmacies among the urban and rural areas. There's suboptimal intra- and interprofessional collaborations. Academic pharmacists, hospital pharmacists, community pharmacists have to work together to come up with systems that will promote all of us and help the nation. We need to prove our worth, and the way we can do it is for all of us to unite together and get things done. Then we need to break barriers. We need to penetrate other professionals and bring them on board, and it's achievable. I have about 40-something healthcare professionals on my network that we work together. It's been interesting. When the lockdown came and I could not easily reach my patients, I set up a group called Victory 50 Plus WhatsApp group. And what I did was every week, a consultant came there to talk to them about their health. Since March to today, we've not missed one Sunday, and they keep coming. Where are they coming? I don't pay anything. It's relationship. We can get there, and we need to get there. There's also poor remuneration, definitely. We cannot be doing all of this as charity because it's about health and it's about compassion. The patient makes you feel guilty when you want to ask for money or you want them to pay for your services. And we cannot blame them. Things are hard. In a country where about 80% of the people do out-of-pocket expenses on their health, what do we expect? So we need to look at that from the policy angle. We need people to help us so that we can be recognized service providers in health insurance scheme. Now, this is distribution of pharmacies by states, and these two major lines, expectedly, Lagos and Abuja. The other lines, some of them are even inexistent. So, our challenge is, what's the way forward? We need to take a very big leap forward and surmount our challenges. Let me conclude by saying that there's no gainsaying the fact that there can be no universal health coverage without empowering the community pharmacies to contribute its invaluable quota to primary health care. And I give God Almighty glory. You see, one thing about God, He wants everybody to be healthy. So, as far as God is concerned, we owe a duty to make sure that we play our roles. We are pharmacists. We pharmacists, remember our song, drug dispensing, we are there. Retailing, we are there. Primary health care, I think we need to add that to that song. Primary health care, we are there. Thank you all, and God bless you.
Thank you so much. Another round of applause for her. May we call on the next pharmacist, a very great woman who in the last 14 years have worked significantly. Collecting data, documentation is one of the key things that we have been talking about, but based on foresight and farsight. About 14 years ago, she started extensive work along with the Harvard University Global Initiatives Group. And so may I call on Dr. Mrs. Dorothy Okwa, a fellow of the Pharmaceutical Society of Nigeria, who is the country director for Harvard University Global Initiatives Nigeria, to make her presentation. Another 10 minutes presentation. Thank you. Thank you.
Good morning, colleagues. Yes, sorry. Yes. Howard University has been working in Nigeria since 2001. Starting with a survey to look at what community pharmacists do in Nigeria with regards to reproductive health, family planning. We came back in 2004 under the platform of the GAIN project with funding from USAID for HIV. And we've used that platform to strengthen pharmacy systems in Nigeria and pharmacy services. I was very happy to see what the last presenter talked about. So our next presentation will be more or less a synopsis of the work we have done with community pharmacists over the last few years, last 2001 to date. And I'm going to call, currently we have about 118 pharmacists working with us across the country. And I'm going to call on one of us, who is a community pharmacist, like all of us here. I am not a community pharmacist, but he is. And it's part of the team that have been ensuring that we follow this process through. Our vision has been preparing pharmacists today for tomorrow's world. And I'm going to call on Dr. Ome Onuche Iduku to give the presentation. Thank you.
Good morning, professional colleagues. I'm standing on all existing protocols. It's a great pleasure for me to stand in your midst this morning and make this presentation on behalf of my country director. That Howard University PACE Center, PACE Pharmaceutical Care and Continuing Education Center, has a mission statement, preparing today's pharmacists for tomorrow's world. So I'm going to make a short presentation on about 20 years of work. Look at the screen, we'll see the various collaborative works that community pharmacists and Howard University did together. Presently, 2019 to date, we are involved in HIV self-testing and PrEP, that is prevention, pre-exposure prophylaxis for HIV. Then viral load monitoring and EAC for unsuppressed clients. I listened to the presentation by Professor Eru and by our pharmacist par excellence, pharmacist Fola Shade Lawal, and to me, they were telling the whole story of what Howard has as a vision and the work that we've been doing for about 20 years now. Interestingly, pharmacist Fola Shade is one of our community pharmacists refill pharmacists, and besides that, we had a case of a client that was taking medication and tenofovir specifically and had renal failure. She was the person that identified that. And working with the doctors involved in ART management, eventually able to stabilize that client, and that client is still alive and on. We worked on adolescent refill program, and this is a self-sponsored project in Lagos State by ARCS. They gather some of our adolescent clients that are not willing to come and mix with the other population in the facility to take their medication, and on their own will, at their expense, they gather to provide refill to them who are working with them on that. They will have the community pharmacists here, quite a number of states in the country, and the HIV testing services that was started since 2011 up to 2019, when the project stopped providing HIV test kits to community pharmacies. We are currently, community pharmacies using the HIV self-test kits are also providing index case testing. The clients that are devolved to their community pharmacies, they try and find out from the linkage of the clients, partners, husband, children, to find out if those clients also have gotten the infection, and their work has been very exemplary. We also worked at, under the State House project still, community TB care, where we work with the community pharmacies to look at the clients that are coming to their pharmacies and to screen them and to find out those that have symptoms of TB, and they link those clients to the TB diagnostic centers, and a number of those clients were found to be positive. We also work on the WHO-funded TB challenge project, the FIP, between 2011 to 2012. HIV, AIDS, STI, tuberculosis, called HAS under the GAME project. We work with community pharmacists in Lagos, we work with community pharmacists in Cross River, we work with community pharmacists in Kano also. We were to do the work also in Taraba, eventually we couldn't do that. So we also work with them. Skill certification in palliative care for the community pharmacists to provide quality care to the clients that are HIV infected and other clients that are coming to their pharmacy to ensure that they have quality life. We also worked with them between 2006 and 2007. The whole of our work actually started with a survey that Howard University did with Nigeria and some Anglophone countries, Anglophone West African countries, called EWAP project. And it was to find out the involvement of community pharmacies in clinical care. For instance, the STI, what is their role in it? It was that project of 2001 that gave birth to the involvement of Howard University in the GAIN project, the only project in the country as at then that was focused on developing the capacity of the pharmacists and developing the system of pharmacy in a manner that allows the pharmacists to be able to provide pharmaceutical care to the clients. This is a rundown of some of the projects that I've done. I will maybe speak a bit concerning what we do specifically in some of the projects. The Community Pharmacy ART Refill Program is a platform that allows the community pharmacies to receive clients. It's noted that pharmacists have always complained that they do not receive prescriptions in their pharmacy. But this program allows us to be able to devolve clients that are in the hospital, they are stable, we send them to the community pharmacies to provide service to them. And Pharmacist Fund actually said something about fee for service. The facility, community development, and the community ART refill that we run ensures that clients pay for their medication. If tomorrow the funder is no longer around, the community pharmacists who are working with will still continue to go to the community pharmacies, and they are going to pay for the service the pharmacists provide beside the product that they may buy from the pharmacy. So as at March 2019, we had about 16,307 clients already devolved to the community pharmacists we are working with. 136,772 refill services were provided. I'm not going to dwell so much on this because of time limitation. Then what was the rationale for our going to the community pharmacy ART refill program? We recognize that donor funding will not continue forever. We recognize that facilities are overloaded, and the contact time that the pharmacist in the facility has to make interaction with the client and be able to do the assessment and be able to provide care was so short. And because of that, even though they were trained to provide service, it was a difficult task for them. So when we saw that, it became necessary that we should find out our colleagues that are in the community, pharmacists as well, who could be trained and be able to provide the pharmaceutical care. And that caused us to move into a community pharmacy ART refill program as of 2016. Look, the map shows the places where we are already providing that. Where we have the red star is speaking to those that we are working with currently. We have Cross River, we have Akwa Ibom, we have Lagos, we have Edo, and we have Bayelsa. These are the places that we are working with. But if you look at, on the right side, you see that we work with 232 pharmacies, community pharmacies in Lagos, Edo 16, Anambra 11, and the whole numbers that we have there. Some of the things that we're able to accomplish working with the community pharmacies, you can look at the chart here. This chart is between 2016 and 2020. And the number of the clients that were devolved ever to the community pharmacies as at that time was 19,022 clients. Lagos was 6,055. If you look at the chart on the right, it's talking about the number of community pharmacies that were working with in CPAP, and there were cumulatively 570 community pharmacies in the country as at 2020. For HIV self-testing kit, it's a new entrant into the HIV world, and we are working with community pharmacies to ensure that those clients that are unwilling to go to public facilities to assess HIV test, they have an opportunity to be able to still achieve that. And as at October 2020, 851 test kits have been distributed in Lagos, in Akwa Ibom and Cross River alone. Lagos is not included here. And 311 results were received with 34 of those clients positive. 29 of those clients are already on ART by virtue of the work that the community pharmacists are doing. With respect to HIV testing services that we had before it was stopped, we were able to conduct, the community pharmacists were able to conduct 21,985 clients and receive their results. 463 of those clients, as at October 2014, were positive. Key finding is that community pharmacists are very enthusiastic to provide this HIV testing service. And all around, we've been able to understand that community pharmacists, clinically trained, disease-oriented, patient-oriented, are always raring to go out and provide service to the client. The picture on the right is of Olu of Ishaga Palace, that one of the community pharmacists were partnering with took the picture when he went to conduct HIV testing service there. Community TB care, we ran that in Cross River, in Lagos, and in Kano. And during the period, we were able to have 4,241 clients referred from community pharmacies and PMVs to TB lab and diagnostic center. Of this population, 642 eventually were found to be sputum positive, giving us 15.4% positivity rate. And 458 of these clients were supported by community pharmacies in their medication. Skill certification in palliative care was one of the work that Howard University did with community pharmacies to be able to provide palliative care services to clients that they were attending to. 194 CPs were trained on the skill certification training in HIV and AIDS, opportunistic infections, STI. The WHO-funded TB Challenge project was also implemented by the community pharmacies in conjunction with the Howard University. 37 pharmacies were trained to provide this service in the Calabar municipality. 15 moderate to severe adverse drug reactions were reported from 325 clients that were screened. And the HIV, STI, TB, and malaria, the HAS project, also by the implementation of the community pharmacies, we had achievement of 139 CPs trained to provide the services. Key finding from that project was collaboration between public facilities and private pharmacies can lead to better quality of care for the population. These are some of the pictures that we had concerning the training for the HAS project. And currently, one of the challenges that we observe with respect to the community pharmacy ART refill program is the documentation load. There are so many documentation that has to be done. And we feel that if you are providing clinical care, as Pharmacist Folashade mentioned, documentation is very, very necessary because you need to be able to publish the work you do, not on the drugs you are dispensing to people, but on the human beings that you serve. The world needs to know about that and be able to, when they want to run an intervention, find out who has experience, who has competence in this area. The documentation, the publication that you do put you in the outer space and invites you to do more work. So currently, because of the challenge we're having in documentation, the project has been able to develop what we call the CPAP LAMIS. It's a software that enables the documentation to be taking place at the community pharmacy level, and as the pharmacy is providing services and is already making input to them, immediately those clients that were developed from the facility, the data is synchronizing with the software that we have in the facility. This is a picture of the collaborative work that we did. More of the work that we did, we have the community ART refill club, where clients that are unable to go to the community pharmacy to get their medication and pay the 1,000 naira service charge. Some of them come together and form a club, and they pay less money, and we are able to get a community pharmacist that go to that group and is able to provide refill for them again. The Howard University Volunteer Scheme, we evolved that with the community pharmacies mainly to provide HR to support to public facilities that has HR limitation. And we also had a preceptor program where a community pharmacist is detailed to take care, provide technical support to PHCs, at most 4 PHCs per community pharmacist, to strengthen their quality of care and their documentation. The community ART club was one of the interventions that we enter into with community pharmacies, and community pharmacies donated drugs worth over 7 million naira to support the outreach to community to do case finding and putting people on treatment. One of the achievements that we say Howard University was able to accomplish in Nigeria is this work with the Pharmacists Council of Nigeria and ACPN to come up with what we call the COPA assessment and accreditation system, where community pharmacies that enroll onto the program are assessed based on a criteria and assessment tool that was fashioned after the FIP. I feel very happy to say again that our erudite pharmacist, Pharmacist Folashade, is a COPA 3 award winner and has been so recognized by Pharmacists Council of Nigeria. So the program has what we call the Star 1 of pharmacies, the Star 2 pharmacies with Star 3 pharmacies, and the Star 3 pharmacies is the highest that a pharmacist is able to use. The accreditation, the assessment materials are there, but there's a graduation as you move from Star 1. The things that will be assessed before you can qualify for Star 2 are different, and you must score 100% for you to be able to go to the next tier. What recommendations do we have, especially as we are looking at the nation Nigeria and the challenges that we have? Well, we have limited HR problem in the country. Some of the recommendations we have are, number one, currently community pharmacies are recognized as partners in continuum of care for stable ART clients in the National HIV/AIDS Treatment Guideline. We feel that is the work that has been done by all of us that are sitting down here as community pharmacists that allow the government of Nigeria to say we want to review the HIV national guideline, community pharmacists must be there. We want to advise that we should not allow that visibility that we've gotten to go dim. The Sustainable Community Pharmacists ART Review Program is listed among the PEPFAR best practices. If you access PEPFAR solution platform right now, you're going to see the work that community pharmacists in Nigeria did. And it's set globally as the best practice for pharmacists all over the world. Currently, we have about 8 countries that are already working with the Nigerian team to find out how did you do it? How did you bridge the gap between the public and the private sector? How were you able to accomplish that? So we want to ask again that we should not allow those nations that learn from us to have a better result in the end. We want our community pharmacists to continue to be involved in the community pharmacists ART review program, and who always advocate that it must be a fee-for-service provision. It should not be something that is based on the community pharmacists provide a service and the funder pay the community pharmacists. That has no sustainability in it. Again, the city preceptorship program that was started with Cross River State, the government eventually took it up and got some of the community pharmacists, put them on its payroll. As the former worker of the government of Cross River State is getting his allowance for his salary, that community pharmacist is also getting his allowance for his salary. And we're asking that other states could borrow from this and ensure that if you have community pharmacy and he has free time, those free time he has is a time for making money. So if they link the one community pharmacist to about 4 PHCs, he goes there to provide service. Eventually, he also is getting some income from that. Finally, we want to recommend very strongly that the COPA assessment and accreditation system should be scaled up. We stop at 27 that were assessed, and we want every community pharmacist in Nigeria, there should be a structure that will assess you and say, because of the range of service you have and the depth of the service you provide, we'll put you on this pedestal. We want to acknowledge very greatly our work with the Pharmaceutical Society of Nigeria, Association of Community Pharmacists of Nigeria, Association of Lady Pharmacists of Nigeria, Association of the Hospital and Administrative Pharmacists of Nigeria. Without them, we couldn't have accomplished anything. We wouldn't have been able to do anything in Nigeria. And we're praying that we'll still have opportunity to continue to collaborate with them and be able to prepare today's pharmacists for the tomorrow's world. Thank you very much.
Thank you so much. Very disciplined with time. I appreciate it. Yeah. We have a very special guest in our midst who came all the way from US. We will take him now. We've taken about 2 different ladies, so it's nice to mix it with a man. It's a great honor to invite the CEO, Managing Director of Total Care Pharmacy. His flight is just few hours from now. He's going back to US. So we just have to allow him to make presentation to us now. He's the Managing Director of Total Care Pharmacy, who has been in practice for over 3 decades as a community pharmacist. He has also been involved in collaboration with other community pharmacists, with over 200 of them in a group, involved in bulk purchase and all the activities that have been shared earlier today. They are also involved in monitoring, in documentation, and using the critical mass of collaboratomics to achieve economy of scale and to be able to achieve some of the things that we are discussing today about vaccination, about primary health care. It's a great honor to therefore allow Dr. Kunle Tomechi, who is the Managing Director of Total Care Pharmacy, based in Irving, in Texas, to actually make his presentation in the next few minutes as well. Thank you.
Good morning, everyone, and I thank you for the opportunity. I think over here we say I stand on existing protocol. Firstly, I bring you greetings from the president of my association, Nigerian Association of Pharmacists and Pharmaceutical Scientists in the Americas, NAPSA. I'm a rep of diaspora pharmacists at the National Executive Council of the PSN. I also bring you greetings from Dr. Teresa Pounds, who is my president-elect, I am rather surprised that my alma mater, Howard University, from where I picked up my doctorate, is very involved here in Nigeria. Also, I cannot fail to pay respects to my dean at the Great Ife, Dr. Wilson Eun. What I am today as a pharmacist, a proud independent pharmacist, I've also been a pharmacist manager, and today I practice as a clinical pharmacist, but I do practice that in my retail shop, just like Mrs. Lawal. All of this were possible because I had someone who led me at a young age when I practiced here in Nigeria, in Port Harcourt. Is Dr. UNO Uwaga is here. And I thank you, sir. I've never said that public, but please accept my thanks. He also gave me a wife. I married his sister. So I'm going to spend 5 minutes to just run through these slides because most of what is in here has already been discussed by the presenters before. It's going to be optimizing primary healthcare services delivery in Nigeria. More importantly, we're going to talk about community pharmacists' untapped potentials. We are also going to, as in this presentation, we'll try to define primary healthcare. I'm sure they've done good justice to that. We'll look at goals of primary healthcare. We'll look at pharmaceutical care, and then we'll try and bring them together and discuss case studies of what pharmacists can do. Primary health care refers to essential health care that is based on scientifically sound and socially acceptable methods and technology. It allows for full participation of community members in implementation and decision making. It includes all areas that play a role in health, such as access to health, environment, and lifestyle. When taken together, you can see that there's a role for pharmacists in primary health care. Yesterday, I think the chairman talked about universal health care. He said it is health care for all, that is accessible, that is cheap, that is available for everyone. So the goals of primary health care ultimately is the attainment of better services for all, reducing exclusion and social disparity in health coverage. It also integrates health into all sectors, public policy reforms. I think someone was, the presenters earlier talked about the need in help from government. Advocacy is a very, very big part of primary health care. It involves also a lot of stakeholders, all sorts of practitioners in the primary health care field. We have physicians, pharmacists. We have a growing role in primary health care. Approaches to primary health care, there's a selective primary approach. Sometimes a particular disease state or a particular section of the health need of a community is carved aside, and that's where they spend all their time in trying to provide health care for the people. Sometimes it could be broader. There's GOBI and there's GOBI FFF, which talks about growth monitoring. We can see that in children. We also see that in adults. When there's an opportunity for stunted growth in children, maybe because of iodine lack or because of nutrients, pharmacists can play a role in that. There's oral rehydration therapy. I think I was in Nigeria when we're promoting that a long time ago. I don't even remember the formula now because those things are now commercially available. There's also breastfeeding, there's immunization. Immunization is a very, very important part where pharmacists are the frontline participants, frontline executioners of this project in the advanced world. Of course, there's family planning. I think I was here when SFH was just coming into the country. They've done a lot of work on educating people around family planning, child spacing, and a whole lot of tools that they have. And then there's also female education. We all know about food supplementation, and we know about the care for women during pregnancy. There's also population aging. During this population aging studies and care, this is when we talk about chronic health conditions. There's a massive, massive, massive role in collaborative practice, and this is where pharmacists can really, really play a very, very big role. It is because of the role that we play here in trying to improve the health, showing the outcomes and showing the results that we can achieve, that actually buys us a lot of respect in the healthcare community. There's also mental health. There's a big problem here, not just here in Nigeria. We have that in the Appalachians, in Kentucky, and the rest of them. And it is now that a lot of the Caucasians are into drug abuse, that in fact the government is now spending a lot of money and trying to combat or opioid overdose and opioid and drug misuse. We have that here too. Because of the drug abuse and drug misuse that's prevalent in this country, that's why we have also, we can correlate that to a lot of insecurity, because everybody here that is a miscreant is using or misusing drugs. You have kidnappers with robbers, because nobody really want to do harm with what we call clear eye. They all have to be under some kind of influence. So we can play a role to help control drug misuse, especially in mental health condition. We're able as pharmacists to be able to show our own importance. And then, of course, we all know pharmaceutical care, direct and responsible provision of medication-related care for the purpose of achieving definite outcomes that improve a patient's quality of life. Now we go to the roles of pharmacists. Pharmacists participate in primary care services in a variety of ways. There's the acute setting, okay, that is the inpatient. I had some internship at one of the hospitals in Dallas, Texas, and during that time was when COVID-19 came. And of course, one of the things we had to concentrate a whole lot in the pharmacy was designing what we call the COVID set. It's the patient comes in, what are the products that we have to give, at what dose, and more importantly, as a pharmacist manager, I was more concerned about the cost to the hospital, how we're saving money. Those are some of the roles in which pharmacists play in inpatient. And of course, we have the pharmacy, which is the outpatient. Pharmacists play a very, very large role in ambulatory care, where we continue to help patients get better by monitoring their conditions and providing appropriate therapy to assure that they have very good outcome. There's over there we have what we call long-term and long-term home assisted living. People when they grow old, when family members are not able to cater for them, they take them to places where there is professionals who can help cater for them and improve their quality of life, leading towards the end of life entirely. And this is where pharmacists play a lot of role in terms of medication therapy management, in terms of collaborating with physicians and helping to make sure that we look out for drug interactions, we look out for adverse drug reactions, so that patients can get the full benefit of what they should be taking. A growing number of acute care hospitals have pharmacists participating in patient care activities in ambulatory care clinics and hospital-based home health care services. Part of the major thing we do in my pharmacy is delivery, and we deliver all around DFW. I have 3 drivers that do that. So we take medicines to people in their homes so that they continue to stay on their medicine, because these chronic conditions, they're never going to go away, but we can manage them in a manner that allow the patient to live a good quality of life. Roles of pharmacists, we've talked about this in public health. Because of our training nowadays, when I went to IFE, mostly what you were trained on was the basic sciences, which is chemistry, pharmacology. But nowadays, in pharmacy school, you do a ton of pathophysiology. Pathophysiology, even as much, if not more, than they do in medical schools. You do a ton of therapeutics. The reason why we can practice with so much knowledge nowadays is because we have so much knowledge of pathophysiology. We understand the disease state, we understand the origin, we understand what are the factors that will help improve that disease state in a patient, and we know that pharmacists are so embedded in that whole value chain that if you take the pharmacist out, that really the outcome for the patient is really going to be dire. In every hospital, every clinic setting in America, a pharmacist is always one of the members of that team. Even when President had to go to the hospital for COVID, amongst the medical practitioners that were lined up during the conference was a clinical pharmacist attached to them. We also saw in the COVID instance when Boris Johnson had that issue out in the UK, he actually singled out pharmacists to recognize and praise them for the services that they do. There's also expanded functions, and the expanded functions include things like immunization. Sometimes we do some clocking. If you come to my pharmacy, just like Mrs. Lawal, we have records of the things that we do just to show that we can produce results. And this has helped us even in getting funding for some of the things we do from the government. An example is we're contracted with the state of Texas that they bring vaccines to us, and we immunize children, and they pay us for our services for just immunizing those children. In such things, we call it consignment inventory. They bring those vaccines to us at no charge. All we do is, like the previous gentleman say, it's fee for service. We administer those things, and they pay us, I think it's $5 per vaccine that we administer. Okay, so let's begin to look at opportunities for pharmacists. Vaccines. Vaccines have been one of the best discoveries after antibiotics in the science world that has impacted the human race a whole lot. We know that vaccines have prevented diseases and deaths. It's about 2.5 million people worldwide, and it's actually getting higher as we continue to see more pandemic. It looks now like it's every 10 years there's a major pandemic that comes. And because of this timeline and the way these things come so quickly, we have a whole lot of countries that have dedicated departments now that try to get ahead of these diseases. And if you look through very, very well, most of those countries have pharmacists embedded into those groups. So pharmacists are so knowledgeable now that we're so very important in the primary health care. And in my practice, we decided about 3 years ago to change how we earn income and how we solidify our earnings as I'm in my 50s now, looking towards when I'm not able to work so hard in a store, stay 12 hours, and see how we can protect how we earn income. And one of the areas we taught about how we earn money in the pharmacy is not just based on remuneration from insurance by dispensing medicines. Most retail pharmacies in America just do that. What we've decided to do is to improve our earnings in other non-dispensing activities in our pharmacy. And vaccinations is one of the key areas we're looking at. Right now, vaccine, I think about 3 years ago, we were probably at about 2% of our income comes from vaccination. Our goal over the next 5 years, we're in the third year now, is to increase that earning to about 25%, because the money we earn in administering vaccinations to people is not counted by the insurance company. So we advise all our people here, if you're not participating in administering vaccination, please, you might need to do some continuing education, get some certification. But I know that vaccines are coming into Nigeria, and the participation of the pharmacists, because of our access in the community, because of our positions wherever we are in our locations, we seem to be the first people that patients go to. We know that the COVID vaccines are coming. Most of our pharmacies are positioned, ready to be the vectors and the administrators of these vaccines when they come. And we are looking at a great opportunity to earn income just vaccinating people. We're not buying the vaccines. The government are supplying it. We're just out there to be able to administer that stuff. It's an easy way, a better way for us to earn income for our practice. There are categories of pharmacist immunizing services. There are those who administer vaccines. There are those who conduct immunization screening and studies. There are those, when we administer a vaccine to a patient, we always hold them for about 10-15 minutes because it's a novel product we are giving into their body. So we want to study them, that there are no anaphylactic reaction. We want to study them, that there are no side effect that would affect the patient and inhibit or impede their function. So patient counseling, documentation, public education is very important if you're administering vaccines. There are a lot of preventable diseases that we've been able to counter because we administer vaccinations. They're listed here. We have the adults, we have children, and we have those that are even minor. Now, there are strategies to increase vaccination rate. You ask me, why am I saying that? Even in advanced climates like America, like in the UK, you had the president of the FIP mention this yesterday. We still have problems with people that are not wanting to take vaccinations. There are people that are anti-vax, and they tell you all sorts of stories. The vaccinations cause children to underdevelop, they cause children to have so many diseases. So we have challenges in administering vaccinations too. So these are some of the things, if you're administering vaccines, some of the things you can do to improve vaccination rate. We need to reduce missed opportunity to vaccines. The COVID vaccine is coming. I would think by now we should start that marketing activity to educate our populace, to collaborate with the government so that when the vaccines are actually here, we're ready to run and do our own bit in administering those things. There's also patient reminders and recall messages. Pharmacist Lawal, he has mentioned and shown us slides, records about vaccination in our firm. And for those people who are supposed to get repeat vaccine, who are supposed to get second dose, we must make sure that we're following up with them, we're calling them and reminding them so that they don't drop off our radar and our vaccination rates will drop. We also have to practice recommendation and reinforcement, and we need to keep records and assess rates at provider level. The next big thing is point-of-care testing. Pharmacists provide an excellent opportunity, point-of-care testing provide excellent opportunity for community pharmacists to enhance revenue by expanding patient care services. Point-of-care testing itself involves performing a diagnostic test outside of a laboratory that produces a rapid and reliable result. I think in the year 2030, it has been estimated that point-of-care testing would actually account for almost 25% of the revenue stream of a pharmacy. Right now, vaccinations is taking a lead on this, but for us in my practice, we're actually looking at making point-of-care testing about 50% of our revenue earning stream. Because if you're doing point-of-care testing, the benefits are immense. Some of the reasons why it is important that you get involved in point-of-care testing, there's always a dearth of availability of physicians. And most of this testing that are being done in the doctor's office or in doctor's offices, we can actually execute those testings in our pharmacies as long as we meet the standards that are required for those testings. The challenge now is for us to get more training to be able to interpret these results when they come. You see, doctors in America, they're very ready and more than happy to give and pass over the testing capabilities to us because really you get paid just a small amount of money for the testing. The main The real money in these testing programs is the ability to be able to interpret those results. So some of us are training right now to be able to get into that play so that we can be involved in the whole 9 yards of the remuneration that's in there. Because there's a shortage of physicians, there will be an overwhelming need for pharmacists to become involved in this point of care testing. We know that pharmacists are the most accessible healthcare providers, and we enjoy a strong level of trust in the community. Now, in order for you to be able to establish a point of care testing facility in your practice, these are some of the things you probably have to, some of the steps you probably have to take. Number one is education. If you don't know it, you can't manage it well. So you have to get training, you have to get skilled, again, like I said earlier, on the process as well as the interpretation. Then you have to think logistics. Mrs. Lawal earlier said she hired a doctor to manage a vaccination unit. Yes, you have to think about a business plan. You have to think about what are your competitors doing. Are you the only one in that community? If you're the only one, knowing that the government is typically the biggest payer, you probably should be thinking about aligning with them now. What is your target market? Are you thinking about, I was talking to one of my sisters over there because I grew up in Kaduna, and now there's Hamatan. So you see a ton of people with pharyngitis, strep throat. Typically, you will go to a doctor's office to get that test. Sometimes you have to wait 4 or 5 hours waiting to be tested for something you can test and get a result within 10 to 15 minutes. These things we can administer and do in a pharmacy now. And if you can have collaborative practice with physicians around your practice, certainly in Nigeria, I think a pharmacist can test and treat as well. A patient can actually come to the pharmacy, get tested, get the result, and then they can be treated right away, and everybody gets better. Even in that strep testing, for instance, it is only about 10 to 15% of those things that come positive, but you will find out that almost everybody is prescribed an antibiotic. Now, one of the services we as pharmacists can do in the community so that we can gain more respect is to participate and lead in things like antimicrobial stewardship. If we're conducting those tests in our pharmacies and we're seeing only 10 to 15% of people that are positive for strep test, and then we can safely treat those people, we can prevent the misuse and over-prescribing of antibiotics. We've talked about this. Again, simple things like, do you have enough space in your pharmacy? Do you have the resources to help you activate these things? How best do you deploy ancillary staff? These are questions that you have to answer. It's typically a business plan. You should have numbers, dollars and cents to this for you to determine, are you going to be able to execute this or not? The next thing you think, how do you get paid? A whole lot of our payment overseas is handled by insurance companies. So you have to get credentialed, have a contract with those insurance companies, and list these as part of your services before you get paid for the testing. In this climate, it's different. You cannot be in a very low income area where they can't even afford to buy what you call a sachet of cefuroxime tablet, and you want to be offering all this testing. You're not really going to last too much in those environments. But if you are in a viable environment where people are looking for top-class health provision, you can offer these services. And then the other thing is you have to follow up even with the care. Some of the testing that we do might be for chronic diseases, like A1C, like INR, and we have to follow up with these patients and with their providers as well to be sure that we're maximizing our collaborative practice agreement. We talked about roles of pharmacists in health screenings. About 75% of the people that come in with diabetes actually do not know that they have diabetes. So if we're practicing and if we're administering this test in our clinic, somebody comes to you all the time, they say, you know what, I feel thirst all the time. All the time, I feel tired. It behooves us, if we have these skills and we have this, we can administer this and see if at all they have these disease conditions, and if we can manage them, we direct them to the specialists that can. Also, things like cholesterol testing, we can do those easily. Another example is asthma. You can't run through the flight of stairs, can't walk through the flight of stairs without panting. We can help administer this testing, and then we can help them in their drug regimen. There's also family planning services. Most states in America now allow the pharmacist to prescribe birth control pills to the patient without necessarily having to see the doctor or get a prescription. And initially, they would tell us that cervical cancer testing and one or two other testing are required, necessary before a patient is placed on birth control, but studies have shown that those things are not necessary anymore. So a pharmacist is now empowered to prescribe these medicines. For us, it is a great opportunity because that is regular income, especially if you practice briefly reminders for patients. You can actually have them do every month. You can get in a 13th one at the end of the year, and that in itself is about 8% more income for you in that category of your business. Sorry, sometimes I always bring this thing down to dollars and cents because I'm a businessman first and foremost before I am a pharmacist. So that is the slide. So let's try and since we're pharmacists here, see if we can talk about some case studies or talk about some of the things we've discussed here, but try and bring it home. One of the things I do in my practice, I'm a compounding pharmacy. I have a sterile lab, I have a non-sterile lab where I make preparations from scratch. I have collaborative practice with physicians, with podiatrists, where when they are needing an orphan drug, that's a drug that's no longer made, we can actually compound it for them. Or sometimes they run into a situation where they don't want to use a commercially available product. At the strength that is available, they come to us and we create those medicines for them. Sometimes it might be an alternative dosage route that they want. We are readily available. If you are a compounding pharmacy in your neighborhood, you have a lot of role to play in primary health care. It might be that you have a OBGYN, obstetric gynecologist around your area that sees a lot of pregnant women. And these women experience a lot of nausea. They don't want to take any more tablet. You can actually, as a pharmacist, collaborate with that practice, and you are able to provide service for things like that. You can make promethazine, you can deliver it many ways. You can make it in a gel. It's actually very simple to do. You might have people that come in that have anal fissure. You can make nifedipine 2%. You can make all these things, and all of a sudden you've cornered all that market in that neighborhood because you're involved in your community. In primary health care, with the COVID environment now, one of the things that became a challenge for everybody is personal protective equipment, PPE. All of us here are wearing masks today. I'm sure when this thing started in May, it was such a scramble to try and get PPEs. I think about 10% of our income throughout this year was because we got ahead of the game and were able to get PPE in large quantities in our pharmacy, and everybody knew, look, if you want a face mask, if you want the infrared thermometers, just come to Total Pharmacy. Even if we don't have it, because I trained Onga Oga here, I'll say we can get it for you. And we actually always do get it. Another one is point of care testing. We talk about strep. We talk about collaborative practice. If you have an asthma clinic around you, or you have patients that have asthma, and you see that all the time, this patient, they get a prescription for, say, albuterol. I think you call that here salbutamol, which is Ventolin inhaler. Typically, it has 200 doses in it. Even if you give that at the maximum dose of 2 puffs every 4 to 6 hours, you will get a 17-day supply, or at the very least, you get a 25-day supply. and you have this patient always coming to you every 15 days, every 10 days, wanting a refill, they want to buy a new one. It is our duty as pharmacists to bring in our experience and our knowledge to ask the patient, why are you using this very often? It is our duty to look at the patient prescription history. I've had a few of those in which I'd had to intervene. And I have to call the physician and say, hey, you have this patient on a rescue inhaler. Do you have them on any oral corticosteroid therapy? And this is when we bring things like, I think when I was in Nigeria, we used to sell that thing, it's called Becotide, beclomethasone, but you have to get them with oral inhaled steroid. And because you do that, you actually reduce how often they use their rescue inhaler. We talked about mental health earlier. We talked about the importance of the pharmacist intervention. If you are close to a mental health hospital, you can also bring your expertise to play. You have people that are very depressed, and they also complain about idiopathic pain. Because of your knowledge, you can work with the psychiatrist and help them choose the right product to help with these things, and not for them to just be treating one disease state and not treat the other. And this is where I think my clinical knowledge has become so very valuable for me. I'll go back to vaccination because that is important in primary health care. If you have a patient that is elderly, right now we're advising all elderly patients to make sure they're getting their pneumonia vaccine. We're advising all patients that are elderly if they can get another round of MMR vaccine. MMR vaccine has now been shown to be very effective and helpful in preventing the COVID situation. You might be thinking about fertility products and birth control. You have a newly married young girl. She's 23. She's a childbearing age, and she's a smoker. She comes to you needing birth control. Certainly, you're not going to be thinking about prescribing her ones with estradiol because you know smoking is going to inhibit is going to accelerate the metabolism of the estrogen product. It's then that you think about recommending other products that are not those. So pharmacists have a great role in participating in a public health service. I hope I've been able to share some light on clinical relevance in the practice of pharmacy in the primary health care. And I thank you very much.
Thank you so much. And we wish you a very, very safe journey. On this note, we would like to call on one of the directors of, I think, SFH, Pharmacist Emeka Okafor, who is going to be ably represented here by the program manager for Integrate E, Pharmacist Bolaji Oladejo, to please come and make a presentation. It's another short 10 minutes presentation. Because immediately after that, we will sign the documentation and the declaration. So we really need. Thank you.
Thank you.
Just tell me your slide here. Which of them? Start your
Good morning, professional colleagues. I bring greetings from the management of Site for Family Health and Integrity Consortium. I want to especially recognize my teacher and my advisor in Obafemi Awolowo University, Professor Wilson Aaron. Thank you very much. It's a great honor to be having a presentation together here. I'm going to be talking about Integrate E projects, what we have done, and I'm going to be building on the foundation that has been laid down by these erudite scholars and men and women of honor in this room today. Integrate E projects is a family planning project that is being implemented by Society for Family Health. It's a consortium of 6 organizations being led by Society for Family Health. And what we're doing is to integrate family planning and primary health care services among community pharmacies and PPMVs in Nigeria. It's a proof of concept project that started about 3 years ago, and is to prove that community pharmacies are able to do much more than they are authorized to do right now if they are trained and they are supervised and there's an enabling environment for them to function. So we've been able to do this over 3 years. So I'll be running us through what we have done. Like I said, it's a proof of concept that community pharmacies and PPMs have the capacity to provide a wider range of family planning and primary health care services than they are currently authorized by law to provide. It's a 4-year project being co-funded by Bill and Melinda Gates Foundation and MSD for Mothers. It's implemented by a 6-member consortium being led by Society for Family Health. We have other partners that are Farm Access, DKT, Maristopes, Pop Council, and PPFN. Our key partners, the Pharmacists Council of Nigeria, Federal Ministry of Health, and State Ministry of Health. And I'm going to say a few words about this. We've talked about what we do in community pharmacies, how we don't have legal backing and all that. But what we're trying to do is to actually build a foundation. It's a proof of concept, and to also ensure that we create enabling environment so that these services can be sustained beyond the lifetime of the project. So we work with the Federal Ministry of Health to get approval for community pharmacists and PPMVs. We also work with State Ministry of Health because we all know that health is on concurrent list. And I'm going to be looking at the 2 states where we are, how we get our approval for community pharmacists to be able to provide these services. Our goal is to improve the quality of family planning and primary health care services being provided by community pharmacies and PPMVs, and to support the creation of an enabling environment that will sustain these services. Our key achievements, what we did 3 years ago when we got to the States, was to conduct GIS mapping of all the community pharmacies and PPMVs in Lagos and Kaduna states, and we presented the directory to the state. So whoever is coming to the state, if any partner is coming to work with community pharmacies and PPMVs in any state, in any of these 2 states, we have a directory that shows where you are, the address, the name of the community pharmacist, and of course, what you do there. We also got a grant from a Bill and Melinda Gates Foundation to extend this to about 11 other states, which we have done, and we're open to scale up to some of these states by next year. We also obtained waiver, like we know that community pharmacists were not a primary FP provider, so there was actually a need for us to avoid embarrassment or harassment from other security agents or other health monitoring agencies in the states. So we got a waiver from the Pharmacists Council of Nigeria to train community pharmacists on expanded family planning services. And we also obtained a concurrent approval in the 2 states. For Lagos State, the approval that we got actually came in batches, because what the project is training pharmacists on is on injectables, then provision of implants, such that in your community pharmacies, you can actually insert an implant for your clients within the community pharmacy, where you are trained, you go through competency assessments, and you are given certificate of competency to be able to provide these services. So we needed to get the approval from the state. So in Lagos State, I had a lot of issue initially that, oh no, community pharmacists, they want to turn to surgeon and all that. So they gave us the first approval to do injectables. So I spoke with the donor, and they were like, go ahead, you have something to work with. And we gathered some evidence, some data evidence to prove to them that community pharmacists have been able to do injectables. After about a year plus, I got a call from the commissioner from one of the directors, the commissioner has given all the directors query because of me. And I said, why? He said, because they saw that community pharmacists are doing well, and they felt that Lagos State directors were not cooperating with us. So they spoke with donors from the data they got from Integrity. They saw that community pharmacists can actually do this, because in Kaduna, CHOOS are doing it, and there has been no incident. And what about community pharmacists that are professionals? And we got an approval that community pharmacists can start doing implants in Lagos State. Thank you. We've actually conducted assessment of community pharmacists for selection of training, and I have to give this to Pharmacists Council of Nigeria, the ACPN in Lagos State. From day one in 2017, they've been very supportive. In various zones, we went with some of their executives to identify community pharmacists that will actually do this. We have trained 313 community pharmacists in Lagos and 106 community pharmacists in Kaduna State on long-acting reversible contraceptives. The integrated project has experienced good relationship with community pharmacists across both states, that's Kaduna and Lagos, and this has led to continuous provision of services from inception of the project in 2017. Across the years, CPs have contributed to achieving about 40,000 of clients cancelled, and from all clients reached, community pharmacists have provided FP services to over 36,000 women across both states, from which 24% were women who have never used a family planning method. These are the new users. We had about 9,844, and 25% were adolescent and young persons aged 10 to 24 who are sexually active. Community pharmacists have also contributed to providing injectables and long-acting reversible contraceptive services to nearly 5,000 women. The data is there on the table. The integrated project has continued to support community pharmacists trained on the project with mentoring support. Remember what we told the government was that this is a proof of concept, and we said we're going to train community pharmacists, we're going to support them to be able to provide these services. As much as we want to reach more women, we do not want to compromise quality because we're talking about lives of women in the community. So we continue to mentor community pharmacists, we continue to support them. We've also done training on the mobile reporting, and we have trained them on finance and supportive supervisory visits. We know that we are businessmen. I love what Dr. Tomari said, that he's a businessman first before a pharmacist. We know that we're business people because it's because our business is running. That's where projects can come and implement in your premises. So we've trained them on finance and supportive supervisory visits. The project has given a total of 303 mobile phones to community pharmacists across both Lagos. In Lagos, we have 250, and in Kaduna State, we have 53. So as we provide these services, this is something very important, and I'm going to be laying emphasis on this as we go on in this presentation. We have said so much about inclusion of community pharmacists in primary health care services in Nigeria. But I must say that if we are going to be recognized at all, we need to live to our responsibility. If there is no data for it, it is not done. And this is where we are having challenges. We have said so much about what we can do as community pharmacists. But it's not just by words of the mouth. The policymakers, the stakeholders need to see the evidence that we can do this, or this is what we have done in the past. And we lay our evidence to them and prove that if we are able to, if we are recognized, if we are mainstreamed into the formal health sector, we'll be able to do much more. So we need this data. So what we did was to train them on service provision, train them on documentation, and also train them on DHIS mobile reporting, and provide Android phones to all pharmacists trained so that you can also transmit your data to the DHIS. Let me also say that initially, what we got from the Federal Ministry of Health was that they're going to put the CPs and PPMVs data on staging server, and just for them to be able to test the reliability and validity of our data, because they feel that we've not been doing this in the past. And recently, we approached them that if we have our data on the staging server, in fact, Lagos State, they were actually doing data review, and they saw that in local governments where we have where integrated project is being implemented, where we have community pharmacies and PPMVs, they had more services, more uptake in those local governments. So they are advocating for more CPs and PPMVs to be trained in Lagos State. And so we said, if we don't have our data on the national grid, we won't be able to prove anything to the federal that this is the contribution that is coming from community pharmacies and PPMV. So we got an approval recently from our donor, the Bill and Melinda Gates Foundation, to actually expand the bandwidth of the server, DHIS server of the Federal Ministry of Health, so that community pharmacists and PPMV's data can be accommodated there. So any project, any partner that is coming to Nigeria now to work with community pharmacists and PPMV, as long as that data is being reported on DHIS, we will be getting it at the national level. So our impact will be felt. Now, we've actually also done supportive supervision to over 120 community pharmacists across both states, but with only 57% meeting a minimum quality standard of 75%. And this actually happened in Kaduna State. Lagos State had high standard, but in Kaduna, we are still having some challenges with community pharmacists that we train. So we need to up our game. so that we don't say that quality is compromised. One of the things I was told in Lagos State was that, what if a community pharmacist insert an implant and it migrates to the heart and all these myths and all that? And I said, they told me to bring my license so that in case anything happens. And I said, if the #1 pharmacist in Nigeria has given a waiver, I said my license I don't need to put down my license, but I can assure you that there's going to be supportive supervision to ensure that we don't have any incidents. And I'm bold to say that since we started in 2017, of all these services that we have provided, we have not had a single incident from a community pharmacist. We've enrolled 308 community pharmacists in a knowledge retention study. As we train community pharmacists, at the onset of the project, we actually do, at baseline, we do what we call a knowledge retention study, and we follow them up after 9 months to actually know how much of this knowledge we've been able to retain. Then 9 months after, again, that's about 18 months, we still follow them up to be able to ascertain that community pharmacists can retain a high level of knowledge and provide quality family planning services. What some of the lessons learned and best practices? Involvement of ACPN leadership at the state and zonal levels has helped in coordination of community pharmacies, especially for trainings. Some zones have provided review meetings venue for us at little or no cost to show ownership of the project. One of the things that we'll do is to ensure that we have a data review meeting. And like we said, it's not just about this project now. It's about sustaining this project beyond the life of the project. Because before the project came, community pharmacists have been in existence. And once you get the knowledge, you get your certificate of competence. These are services that you still be providing even when the project closes down. So we actually had some of these community pharmacists providing various zones, providing a venue for us for a review meeting. And we hope that this is able to also translate to part of what they will be doing on a monthly basis. We have about 40 community pharmacists that have completed their competency training on LAC in about 3 local governments in Lagos. One of the things they told us that the standard practice, rather, is that after the training, it's usually 6 days training, full 6 days training. You don't get certified after a 6 days training that you can start inserting implants for a client. So what we do is they are supposed to have like a 3 months post-training supportive supervision where they go to primary health care centers under the supervision of master trainers and integrated service providers to ensure that you attain a minimum number of insertions. For Lagos State, they set it at about 12 to 15 insertions and 3 removals. So you must be able to insert 12 implants, at least 12, and remove at least 3 before you can be certified competent. We have over 40 CPs that have completed their competency training at the various primary health care centers in Lagos State. We've also engaged some people that we call the interpersonal communication agents. Like I rightly said, we are not the primary FP providers. So there's a need for us to actually go to the community to enlighten them, to let them know that these services can be obtained from community pharmacies. So we engage those that we call interpersonal community agents that go into the interiors, they engage women, they engage men group, they ensure there is male involvement and drive traffic to community pharmacies so that women that actually signify interest or adolescents that signify interest in taking up family planning methods can actually be directed to trained community pharmacies in the communities. We've also had integrated outreaches conducted at community pharmacies, and this has actually increased visibility for community pharmacies in their communities. We saw that if we are able to conduct integrated outreaches, like we go to some pharmacies tell us that they're going to open new branches or they just want to conduct outreach. So we bring our team to their premises. We conduct cervical cancer screening, breast cancer screening, family planning services, just to ensure that there is visibility for our community pharmacies in their communities. All these that we have achieved are not without challenges, and I'm going to be talking about some of these challenges. Despite the overall contributions of community pharmacists to the family planning achievements in Kaduna and Lagos states, the numbers that we have only is a fraction of the reality of impact of CPs and that we're having. We are doing so much more, but our documentation is poor. Remember I said earlier, if it is not documented, it is not done. And this is due to lack of reporting from majority of CPs, and I have to say majority of CPs across both states are not documenting. Reporting rates analysis shows that only about 30% of community pharmacists report consistently to the database since the inception of the project. Look at the figures that we have projected here today. If we only have this from 30% of community pharmacists trained, how much more impact do you think we have if we have 100% of all trained reporting to that that server? Result shows that less than 50% of CPs report to the database, even after adjusting our analysis to include all those that report data at least once in each quarter. So we said, let's not even look at on a monthly basis. Let's look at on a quarterly basis. How many of them report at least once in a quarter? And we still have about 50%, less than 50% of all the community pharmacists trained. Now, to put the figures into context, 60% of PPMV trained report consistently to database since the inception of the project. And I have to say, sometimes we say there's no basis for comparison, but I have to say that we work in hard-to-reach areas. And we've seen figures today, data that shows us today that we don't have distribution of community pharmacists in both urban and regional area of the country. We have these PPMVs in hard-to-reach areas where we don't have pharmacists. There's a saying, when there is no doctor, people will get one for themselves. And the same thing with pharmacists. When there are no pharmacists, people will get one for themselves. So we have these PPMVs in hard-to-reach areas. And we saw that about 60% of them are being trained are reporting consistently. That's like double those of pharmacists trained on the project. So this is a challenge, the call to us as pharmacists to stand up to our responsibility and take this profession to the heights that we desire. Result also shows that nearly 7 of every 10 medicine vendors, that's 72%, at least they report once to the project database in a quarter. At least 72% they report once in a quarter. And for accountability to the donor and federal government, we have a total average of 46% reporting consistently to the database and 60% reporting at least once every quarter. The donor actually want to see they want to see the result of their investment. And what they are asking for is the number of lives of women touched in the community. And we can only get this when we have data of services that we have rendered to these community members. Hence, I need to say that integrative project is doing poorly on reporting. We're doing a great job. Community pharmacists are doing excellently when it comes to service delivery. But in reporting, we're doing poorly. And it shows that we're doing poorly on reporting, largely due to the lack of reports from majority of CPs trained. Our way forward, we feel that there's a need for a change in attitude of community pharmacists towards documentation and reporting. And our training should not also be seen as burdensome, as expansion of service is for professional enrichment. We have 6 days training, 6 full days training. We do 4 days in class, then you go to health centers, 2 days for hands-on practical on live clients. And after that, we have supportive supervision, post-training assessment, competency assessment at the primary health care center so that you can be certified competent. Sometimes, most CPs feel that this is burdensome. And I'm like, don't let us be complacent. We are not traders. We are professionals. We are service providers. And a lot of primary health care services will be coming to us. In the next grant, when we're looking at scaling up to 9 additional states, we're looking at other primary health care services that will be added to community pharmacists. And we need to brace up for this. The recognition of community pharmacists as professional healthcare provider that comes with primary healthcare service delivery should be prioritized over financial gain. Sometimes people ask me, I'm supposed to sterilize, to do this. How much are they going to pay me for these services? I think it's too burdensome. You know, how much I get from these services I'm providing is nothing to compare to what I put into it. And I tell them, there are clients that will come into you, and you will tell them 5,000 naira. They will say, no, that's too cheap. They are ready to pay as much as 10,000. There are some clients that will tell them 2,000 naira. they can't pay. These are our target group, the poor and the vulnerable. But you will still have those that will come and pay for these services. And in the long run, there's going to be professional enrichment for us. And I tell women, we don't want to do it for yourself now. We need to do this for the sake of the future of this profession. Conclusion. Community pharmacists are better positioned to provide a wider spectrum of family planning and other primary health care services as a result of their education and presence at the community level. Like we all know, we are the first point of call in the community. Hence, for us to be integrated into the formal health sector, there's a need for us to improve in data reporting and documentation, as what is not documented is not done. I'm going to be showing us pictures of a group of community pharmacists during our long-acting reversible contraceptive training. You can see a CP inserting Jadel during training. And we also see some CPs during the competency training. There's a CP there counseling the client using the necessary national tool, the balanced counseling strategy card and MEC wheel. There's something we call medical eligibility criteria wheel that that has to be used before you can choose a method before a client can choose a method. You can see pharmacists inserting implants in his premises. This pharmacy was just supported sometimes last week in Agege local government because they wanted to start a new premises. And we saw that integrity team, they were there to support, provide the necessary support. And the demand generation IPCAs were also there to ensure that they drive traffic to the premises. Thank you for listening.
Thank you so much, Pharmacist Oladejo, for a very wonderful presentation. You are so passionate about your presentation, and you are very down to heart. I was wondering why you were presenting some things on patent medicine dealers in a community of pharmacists. I didn't want to hear anything about PPM, but when you now made the comparative analysis, I knew you were making a scientific presentation, so that is acceptable. All right. On this note, we are going to take just 5 minutes. Before we call on, please, Professor Sifu, just give us a few minutes. In 5 minutes, we will sign some documentation. We've had a lot of presentation from 5 major speakers. We just have about 5 minutes to sign a commitment to action on primary health care. Like you understand that all that we have been sharing the last 3 days will come to naught unless action is taken. It's on this note we would like to call on critical stakeholders to come and make a strong commitment and sign this document because some of them are traveling with... Somebody is calling me? Okay, sorry. So some of them are traveling at about 1 o'clock. So we need to call on the chairman of ACPN to just call the critical stakeholders. They'll quickly sign in 5 minutes, and we are gone. Thank you.
Thank you very much. Let me formally recognize and acknowledge the chairman of this occasion, persons of Dr. Walter Colombo's WHO country representative, ably represented again by Dr. Namro Godfrey. You're welcome, sir. I also want to appreciate another pharmacist from the WHO, a very solid resource person, colleague of ours, who did justice to the presentation of Frederico yesterday, and that is the person of pharmacist Samson Omotayo. You are highly welcome of WHO. Thank you. Welcoming also, thank you. Welcoming also is another very supportive pharmacist, and that is in person of a very strong name in the arena of all this type of work we're talking about, primary care, partners work. There's one name that you hardly can mention anywhere, and they will tell you, who is this person? And I was glad when I get to know that he's a pharmacist. Both doctor, anybody in that arena will respect him. He's a man that has widely traveled, and the day we track him down to start this discourse, from the pool of his experience and knowledge, I was highly encouraged. I'm talking of pharmacist Kilani, currently a technical staff in CHI, that's Clinton Head Assets Initiative. I hope you see very much around. Dr. Killan, please stand up for recognition, please. Thank you very much. Another wonderful person I'd like to recognize, who is been with us since yesterday, is in person of pharmacist Emmanuel of the USAID. Farm Emmanuel, please stand up for recognition again. Thank you very much. Those three gentlemen sitting together are the brain behind this session. And they have given a lot of commitment in terms of moving whatever we're doing here today forward to the next level. So I want to thank you for your commitment to serve pharmacy and to support the community pharmacy practitioners. I'm also aware that we have, those who have spoken to us from organs, from Society for Family Health, and hopefully, I don't know if UNICEF is around. Anybody from UNICEF? Okay. I think there are about 2 other partners we invited. UNFP, if we have anybody from there. All right, no problem. What we want to do right now, it is something that is very strategic, and they said if you come to church, if you don't remember anything church today, remember this one. That's the way Pastor used to say it, because I'm also one. Let me say that if you come to this conference and you don't remember anything, please don't forget this one. You know what I mean? It is strategic. Sincerely yours, this is one event that the 5th president promised to lead us to do. But for the virtual contact, that is not possible. But I have his assurance to go ahead, because we have planned, we know that we are starting, is a kickoff. And that is why I want to believe everybody have a copy of this. We have presented it to the minister yesterday. Our plan would have been that the minister will also sign. But unfortunately, the board, was not ready. If you don't have a copy, please pick a copy, because we want to read it together. We want, as I read from here, you want to look at it. It's a commitment on our part. We are not putting anybody under pressure. We are not forcing government on anything. It's a commitment by pharmacists to this responsibility of primary health care. Therefore, it's like a pledge by us. So it's not about government or by any agency or by any person. But for our colleagues that are here, we are glad that they are here to see, to witness that we are showing commitment as a pharmacist. We're starting a process. And I congratulate you that you are part of this process we're starting today. Because this will never happen anymore. It is happening now. So for you that are here, I want to encourage our ushers. Please tell any pharmacy that is outside there to come. Because if you are not part of this, then you have missed a whole lot. So please, I encourage you to come forward. This is the Abuja commitment to actions on primary health care by community pharmacists. We have the commitment of the FIP. It's a document of FIP. It's not just our document. And as a council member of FIP, I have signed this. I'm sure you will have seen pictures where I was signing and I was being televised at the FIP level. So all of us who are members of Council of FIP have signed this. And all pharmacists that were present at Astana when this was first signed, all signed it. The second place where this declaration was signed was on the 23rd of October last year in Ankara for the European region. And I was also glad to be there to sign on your behalf and on behalf of the African region. So, today, we want to also pledge our commitment to this. Our colleagues up there are committed to this, and they are following it. We are going to pursue all agenda on this. Critically speaking, after this conference, we're going to have a working team that is going to involve different stakeholders to take the message we are doing here to the next level. And that's something I can assure you of is that I don't know the day, I don't know the week or month, but I assure you that in the shortest time possible, Nigeria will give endorsement to community pharmacies' declaration as a primary health care facility. Changes, nobody will give you change. It is yourself that will initiate change, and you pursue it. I'm glad that people are here to witness this. They are just witnessing. They are not the one commanding it. So it is we that want to give ourselves all this decree, so to say. It's a commitment on our part. One, I hope it can be projected, but if not, you have a copy with you. Support Declaration of Astana on primary health care for achieving universal health coverage through high-quality, safe, comprehensive, integrated, accessible, available, and affordable health care for everyone, everywhere. Do you agree with me? All right. Provide better primary health care services by transforming our pharmacy workforce and strengthening our practice and science. Did you agree to that? Transform and scale up pharmacy education by ensuring high quality and fit for purpose education and training for primary health care provision, and to provide the foundations for workforce development, professional and scientific advancement. Do we agree to that? Continue to address the growing burden of non-communicable diseases by empowering our profession to provide services in health promotion, disease prevention, screening, referral, disease management, and treatment optimization in people with non-communicable diseases. Do we all agree? Working with all healthcare professionals to deliver collaborative practice in primary health care and build solid and strong interprofessional healthcare team. Do we agree to that? Shape primary health care delivery by adopting innovative approaches and adapting our workforce alongside the fast changing digital health technologies. Do we agree? Be an accessible, reliable, credible source of medical information for our communities and patients, empowering them to make healthier and more informed choices. Is that our agreement? Play an essential public health role by providing evidence-based information about immunization, eliminating public misconception about vaccines, supporting national immunization strategies, and expanding vaccination coverage. Do we all agree to do this? Thank you. Encourage our pharmacy workforce to deliver primary health care effectively through the supply of quality medicine, improving medication adherence and patient safety, ensuring the rational use of medicine, and tackling the challenges of antimicrobial resistance by promoting antimicrobial stewardship strategy in our nation, Nigeria. Do we agree to that? Generate evidence on the impact of pharmacists in improving health outcome in primary health care system through sustainable professional services and ensuring broad access to these services. Is it our agreement? Continue to support our current and future pharmacy workforce in order to meet the required competencies for the delivery of primary health care and to close the gap between pharmacy education and practice. Do we all agree to this? Continue to engage our stakeholders and partners, empower our regional and national health leaders, and support enabling pharmaceutical policies to strengthen primary health care, bringing community, countries, and organizations together to grow and support this movement. Is that our agreement? Be regional health care ambassadors in attainment of the United Nations Sustainable Development Goals through provisions of essential patient care and safe, effective, quality, affordable, essentials, medicines, and vaccine for all. Is that our agreement? Together, we will achieve universal health coverage, good health, and well-being for all, leaving no one behind. Is that our agreement? Let us clap for ourselves. Now, I want to invite BOT chairman and all the leaders to come and sign this. Please. To the center. Everybody in the front will sign. So, you see, the process is this. Everybody in the front will sign. But later, we will expect you to come and sign and take a photograph of yourself while you are signing this and have it in your pharmacy so that you keep it there as a token of this conference. Thank you very much. Thank you, sir. Thank you. Thank you. Thank you. Please, everybody on the front row. All right. Thank you, sir. Thank you. Can sign anywhere on it. It must be full with signature. We will go and deliver it to Buhari after it's full. Everybody, sign. You support pharmacy to provide. Thank you very much. Thank you. Thank you. Thank you. Thank you. Thank you. I appreciate it. Thank you. Thank you. Pharmacist Killan, please. Pharmacist Emmanuel, thank you. Please, take the photographs. It's a monument. We can do it one after the other so that your face is seen. Thank you. Thank you, Professor. Yes. We are going to collaborate with trade pharmacists, community pharmacies. Thank you. Society for Family Health. Thank you. Thank you. Thank you. This is Dr. Rahman O. Kilani. Is Director PAC and Vaccines of Clinton Health Access Initiative. That's the man signing. That's the man I told you about. A strong and tall man in the arena of primary care in Nigeria. Thank you very much. Sir, please go and have an handshake with my BOT chairman. Mr. Kenyan, please. You are this gentleman you're looking at that's working on assuming, sorry, is a strong man that cannot be chief. No. I want him to, chief, sir. Yes, I want you to meet the young man. Is this okay? He's a strong man. This is the man that. He's the guru in primary care. So, he supported us so much for this conference. Come now.
Remove that your mask now. You don't want to greet me well. You know you're greeting now for sitting down. No. We're together. Oh, thank you very much. Thank you. You said they heap so much this and that means that you're a guru. Thank you. This man. Ima, thank you. He's coming. Ima is coming. Please, you have to meet Ima, sir. Yes, that's the thought. We try. Come on. This one is now homage. Now bring homage to my. Please. No, guys. Please. We don't watch that. Thank you, sir. These are the guys that supported me here. Thank you. Three guys that did this. Thank you very much. And they have told me they have assured the committee you are talking about yesterday. Yes, they are there. Okay. No, very important. If this kind of people are there, they will know that we shall see them.
He's doing a lot of work and trying to galvanize pharmacists. And that's what PSN should do. Pharmacists in various positions that can influence a lot of people.
I want Professor Cyril to take his. Yes. Please move it to the side. Hello. We would like to move this signing to the side. Just give us 1 minute. Okay, hello. Hello, madam. Hello, just give us a minute. We want to move it to the side.
Sorry.
Can I call Professor Sifo?
Yes. Yeah. Okay, maybe after that, because we are going to introduce you formally on the transgeneration.
Okay, let me call
let us do that.
No,
guys,
hello.
We will call him. While the signing of the commitment is going on, let me give this announcement to us. This commitment we are signing is going to be anchored by the bringing it to fruition. Everything that we do with making this to work will be anchored by the foundation that community pharmacists of Nigeria have registered. We now have a foundation which is registered, and I am glad to inform you that the man that is behind this foundation, that is sitting directly on top of it, is our home professor. I am sure you have not been seeing Professor Larry Bale in our conferences like this before. They are usually like a guest. They will come in one day and run away. But you knew from last year in Kano, he was in Kano with us for a whole week. And now he has been with us since Sunday in this conference. And that is because of the role he has taken up among us. So for the Transgenerational Community Pharmacy Development Foundation, which we have registered, Professor Larry Bale is the chairman of the Board of Trustees. And I know we have some of our board members here in the house, the like of pharmacist Ike Ugu, if he's around, can just wave. Pharmacist Olufunke Lawan, if he's in the house, can still wave. She is a member of the board. Pharmacist Benga Olubowale is a member of the board. If he's in the house, you can wave your hand. Pharmacist Ajayi Daniel, wave your hand. And your chief servant is also a member of that board. That is pharmacist Dr. Sam Adekola. Colleague, this is the foundation that is going to be acting as a catalyst to bring to fruition all this vision that we have come to write very bold today. So I call on Professor Larry Bale to come and take charge of this, continue to take charge of the event. Thank you very much.
Thank you, my chairman. We would like to quickly call on Professor Osifo. He was going to give us a goodwill yesterday. Professor Osifo, thank you. We just give us a few minutes goodwill, and then we'll quickly put this session into close. Thank you, sir.
2 minutes have been done. Thank you.
My professional colleagues and particularly the chairman of the occasion, I bring you good tidings from NAPA, from our chairman, Professor Ibezim. He has asked me to remind us that we are professionals, and we pharmacists, especially community pharmacists, are the most trusted members of the healthcare profession. And indeed, the eye of pharmacy, the image people see, they actually do that through the community pharmacy. And so we expect that you will be role models in pharmacy practice. The need for unity among pharmacists cannot be overemphasized. And as we reflect on the theme, optimizing healthcare delivery in Nigeria, there are many untapped potentials, and I believe we'll be able to do that. I want to gladly say that from what our chairman read out to us, particularly number 8, I realized that, number 7, that community pharmacies are accessible, you are reliable, and you are a credible source of medical information to our communities and patients, empowering them to make healthier and more informed choices. I want to say that community pharmacists are trailblazers, and we want to collaborate with you, and we pray that you collaborate with other technical groups, even as we look at number 11 part of it, which says continue to support current and future pharmacy workforce in order to meet the required competencies for the delivery of primary health care and close the gap between primary pharmacy education and practice. I would therefore invite you to collaborate with us, and like I want to quickly say, my wonderful sister Lawa, we have had some discussions where she has generated a lot of data, and I did challenge her that this data have to be put in places where people can read and can get informed decisions. And I know she started publishing, and this information has been quite useful to us. So I want to engage you, and I want to plead with you to engage pharmacists in academia so that we can publish some of the beautiful data that you have. On this note, I wish you a wonderful and a rewarding and successful conference. Thank you very much.
God bless you. You're very kind. Wow. Okay. Please, with the permission of the chairman, we want the signature to stop, You will continue after this session. There's going to be a recess of about 15 minutes during that period. So those who are there can sign. Those who are there can sign. But once you sign, we don't want new people to join you. So, thank you. During this, thanks for all the presenters. We're going to have a Q&A. But before we have the Q&A, I just want to let you know that we actually listened to the various presenters, and we wanted to be in a position to quickly summarize what had been presented today. We had my erudite professor, a great mentor of many years, a very deeply spiritual professor, and a founder of a spiritual group, Professor Wilson Aaron, who spoke extensively about the role of pharmacists, not just in filling prescription, but the fact that about 82% of us are not in community pharmacies are not involved in immunization. He spoke about the preparation for COVID-19 testing, that about 93% of CPs or community pharmacists are ready for COVID-19 testing. Majority are ready and willing to test for COVID-19. And he believed that pharmacists have played a very key role in ensuring the 19-19-90 in HIV services. That is, they wanted about 90% of the people who have HIV to be aware, 90% of those who are aware to be placed on treatment, 90% of those who are in treatment to be adequately managed. And he believed that, he identified from his evidence-based work, the majority of the CPs, community pharmacists, they do screening on blood pressure, sugar, malaria, pregnancy, but they identified that even the percentage that may not be involved in some of these things may look minor, some as low as 7%. But that 7% is critical, considering the fact that we want every community pharmacist to be involved in screening, and he believed that training is essential to bridge the knowledge gap. He also saw a need for policy to be in place, legislation to be in place, to allow community pharmacists to handle a number of things, including vaccination. He came to the full conclusion that documentation is key. He's coming from the academic angle, and you know that the major thing that is critical for academic growth is documentation. No matter how brilliant you are, no matter how intelligent you are in academics, if you do not document the things that you are achieving through peer-reviewed journals and co, you can't move up. So it's critical that pharmacists must recognize that documentation is key. And you see the value of documentation in the other presenter. We also have Mrs. Folashade Lawal of Victory Drugs, who, to me, had been practicing as community pharmacist. But since I knew her, she had always been an academician in the community pharmacy space. She may not be a professor, but I can tell you in community pharmacy, she's a professor. So, and she had been extremely diligent in documenting things. And I remember when I used to work for Pfizer, when we needed a pharmacist to speak in any product launch, we call on her. And I spent a few years in Pfizer, just 25 years, and I knew that she was very instrumental to the success of a number of products. She represented everything that I wanted a community pharmacist to represent. So she spoke extensively. And she's one of the very few community pharmacists who attend major product launches. I've seen community pharmacists who don't show up in product launches. And I'll tell you my experience in 1992. We launched Zitromax. And some pharmacies did not show up at the launch. And it was the first antibiotic to be used for 3 days. And they started to receive prescription the following morning. And a pharmacist returned the prescription and said, where did this doctor train? Antibiotic for 3 days. Where do you get? Because she was not there. They sent an internee. And it was after she was thoroughly educated that she started to recognize that an antibiotic can be used for 3 days, like Zithromax. So I'm sorry to digress, but I wish when I come back as a pharmacist, I want to be like you, ma. So she spoke about health promotion. She spoke on meditation therapy management, about rehabilitation, palliative care, cost reduction, disease prevention, immunization, the extemporaneous preparation. Don't worry about what I have my certificate with PCN, don't worry. Vaccination. Then screening. She spoke about screening for breast cancer, chronic diseases, including cardiovascular diseases, patient empowerment, whereby you give them paper, you look for ways for them to self-monitor themselves for some things, home delivery service, using medication therapy management system, rapid diagnostic test on malaria, use of online softwares for proper documentation. I'm so happy because another speaker there after another woman, Ms. Olade, just spoke about the need that we are doing a lot of the things, but we are not documenting. What separates her from a lot of community pharmacies is because she kept on documenting. Even when she had no access to online, she was documenting on paper for many years. So she spoke about the other pack software for vaccination, and she pulled it up. She spoke about veterinary pharmacy services. She spoke about rapid diagnostic tests in COVID-19, and she was able to set up diabetes club, whereby the diabetes club is made up of patients and professionals like diabetologists, dietitians, ophthalmologists, pharmacists, and so on and so forth. And it doesn't cost us anything to set something like that up, particularly under this season, when we do not even have to have physical contact. All we need is just to set up like a webinar, a Zoom, a WhatsApp group, and you can achieve a lot of the things. I will expect community pharmacists to pick one or two things from her and quickly go and set up this non-expensive or something that doesn't cost anything in order to be able to drive more patients into our community pharmacy side. She spoke about the challenges of recognizing pharmacists, particularly community pharmacists, in the activities that we are already involved in. And I will explain some things. It's very hurting, HURTING, to see a pharmacist, the only professional in the world that scores less than 0 in any exam. There's no other course in the world that you score less than 0, except in pharmacy. In dispensing, you can score minus 60 all over 60, which means not only have you scored 0, you are also going to get a deduction of 60 from future earnings. And to have other professionals recognize school cert holders as CHUs, community health workers, and pharmacists are not duly recognized for political reasons. It hurts me as a person. We are the only people who attend, when I was in school, we are the only people who go to class on Saturdays, Monday to Saturdays. We run practicals every day. We are the only one with white lab coat in the dining. Every other person, they eat for 1 full hour. We eat for like 15 to 20 minutes, you are gone. And so, if what we require at this stage is just documentation, please, let's go into documentation. Coincidentally, the integrate e-people have already provided software that can now be made available online. We don't even need to provide those with Android phone. We already have phone. We access it. I mean, everybody has phone now. Everybody has smartphone. So let's assess it at every community. So raise the awareness of the website for documentation and everything, and let us do that. So she spoke about the need for policy for legal backing, for drive for documentation. She spoke about the small number of pharmacists that we have, community pharmacists that we have. Remuneration can be improved. Because the more we get ourselves involved with all these primary healthcare activities, the more resources, the more revenue we are able to generate. She spoke about urban-rural split, which some of the PPMVs are feeling, particularly in the rural areas. But as we also spread to the rural areas, we should take advantage. She spoke about intra and interprofessional collaboration. The need for us to work together within our profession. That's why we have set up the transgenerational what is the need for transgenerational pharmacy group? It's because of intra-professional. There's no president or chairman of a technical group that can spend more than 3 years. That is 3 terms. Am I correct? What do we achieve in 3 terms? Vision. Action. If anybody is building on this, then there will be continuity. But if there is no continuity by the next chairman of ACPN, then some of the ideas that has come up in the last 2 years will be dead. It is for this reason that there's a need to have a system in place that continues some vision. So when you see a CEO who has transformed his organization, it's because most CEOs are on seat for not less than 6 to 10 years. So they are able to actually put into practice some of the vision or take action on some of their vision. Transformation is not an easy thing. So transforming pharmacies from traditional methodology of doing business to a new way of life cannot happen overnight. And 3 years is too short. This is the reason why we need to raise the consciousness of pharmacists from generation of chairmen to generation of chairmen until we're able to achieve what we really wanted. It's for this reason that there's a need for intra-professional collaboration, and remuneration, if we may look poor for community pharmacists now, will improve as we add up all the other things. I have a pharmacist who practice in Nigeria. I know it's now working in Los Angeles. He's the son of Temidayo Pharmacy, late Chief of Palike, Jide. Jide did his internship with me in Pfizer. He worked as community pharmacist briefly before he left for UK, and is now in US. The major thing he does is compounding. They make more money compounding than practicing traditional community pharmacy. Because the people that they are selling to, they are the people in the Silicon Valley who actually bring tablets. Please, I'm not joking. They bring tablets to the pharmacy, scored tablets, scored. And say, can you please help me split it? And they pay $100 for it. That is part of the work that he's doing in compounding. Apart from preparing specific dosage form for them, for their needs. He therefore advised that we should therefore do everything possible to improve on our documentation. My sister, Dr. Mrs. Dorothy Okwa, who had great foresight for many years, recognized where pharmacy needs to go in Nigeria. And so in preparation for the next generation, has been working for years with the Howard University. She was able to speak about the collaborative works with community pharmacies, very good records that were shown on HIV testing and treatment data, tuberculosis screening, palliative care, skill development, and she spoke about the fact that they've been working currently with about 570 CPs. And when you add that to about over 400 community pharmacies from the Integrity E, we're already talking of over 1,000. And there are about 5,000 to 6,000 community pharmacies in Nigeria. So if we scale up from the Howard side, Integrity E scales up, we replicate the likes of Victory Drugs. What will happen over the next 2 to 3 years is that the majority of community pharmacies will have already keyed into this documentation process, and we have more than enough document to present to government and to the legislators. She spoke about the preceptorship program in Cross River State, which has been very successful on primary health care. And they are already producing a system of accreditation. Coincidentally, Mrs. Lawal has already become a 3-star general under the accreditation system. We think, when you look at Mrs. Lawal after today, because she's going to still step it up, I think we should make more provision for more stars, because she's looking forward to a 6-star general. So, and for some of us who are not yet to have a single star, we key into it. They kept on working with WHO, USAID, PCN, and government to achieve their objectives. So we already have a route for us, for those who are afraid about the concept of legal recognition. We already have a route for accreditation. And remember that when we actually become fully accredited as PHC, then our role in insurance will go beyond the one where a doctor will be reimbursing us. It will not be a case of we will enjoy capitation like a primary health caregiver. And like you see in some of the states where they have had this accreditation, like in Cross River State, government is already liaising with them and is already playing some role in providing. Dr. Kunle Tometi came up on the primary health care goal. It's actually a better service for her. She spoke about growth monitoring, spoke about the role they play in rural rehydration therapy, breastfeeding, immunization, vaccination, family planning, and because she's currently practicing in the US. They have such enriched program like mental health, control of drug misuse, pharmaceutical care, home health care delivery services. I recollect when I go to visit them in the US, and my friend and I, every evening after closing the shop about 6, 7, we go all the way for another 2 to 3 hours, traveling to various old people's homes, delivering medications, explaining to them what they need to do. And these are the things I think we can start to do. She spoke about point of care testing, and that 25% of revenue comes from point of care testing. And he said education is key. The word key there for me is keep educating yourself. You'll be exactly what you are when you graduated from the school of Warsaw, with the exception of more education. She spoke about the need for us to do business analysis and planning as a first step. So she encouraged us to keep on doing health screening, sugar test, sugar level test, arthritis, asthma, BP, cholesterol, nutrition, family birth control pills, and that we should go into compounding pharmacy. We should try to take advantage of supply, of even production of PPEs, and that we should look at fertility as an area, management as an area we could also have an increased revenue. My great new mentor, pharmacist Bolaji Oladejo of Integrate E. I've been working with Integrate E for the past 2 years on some other program. I'm glad to meet you today. I will put it in my diary, and I will celebrate the day I met you by next year. Thank you. She's spoke to us about the fact that they have started a proof of concept for improved services of CPs. And because of the fear of people that some people are explaining, oh, we are not legally certified. So no, they have gotten some waivers from government at federal level, and they have gone to each of the states. They already have programs in about 11 states. About 313 are already trained in Lagos. Over 92 trained in Kaduna State. So that's over 400, about 400 already. And he said documentation is very key on DHIS. Am I correct? You should call it DHIS. So, and there's something that I think I picked up from all the presenter. And she emphasized it, and I cannot overemphasize it. We cannot go to government or go to National Assembly and say, we want you to do this for us, unless we have data, evidence-based argument. It is the data that is critical. And can you imagine? She said, no documentation means it is not done. I worked as a rep in Pfizer. You can imagine I made calls, maybe not about 70 to 80 healthcare practitioners during the week. But on Monday morning, I could not submit my report to my area manager. And I'm telling my area manager that I worked last week. I didn't work. There must be a report. There must be evidence to show I worked. And so it's critical that, and it's very painful to me, that while about 72% of proprietary patent vendor medicine services people, they report once per quarter. Less than 50% of pharmacists under the same program reported once per quarter. So we're actually killing ourselves. The first time I heard about what Bill Gates and co were doing in the country, and how they were trying to liaise with PPMVs, I just didn't want to be involved with any program like that, because why should you be relating to PPMV when they are pharmacists? But if you take all the pharmacists, 5,000 community pharmacists, and less than 50% of them are reporting, and you take only 10% of PPMVs, 100,000, and 10,000 of them are reporting, even if it's only 10% of them that are reporting, it means double our number. So when you look at statistics, it means they are far much more relevant in providing primary health care services than pharmacists. But if we're able to get all the 5,000 people to comply, then we start to make some difference. And then we start to make a real documentation. We now start to make a real big difference in our presentation. She therefore called for change in attitude in reporting. I plead with everybody that there should be change. Thereafter, the chairman of ACPN actually had cause to get us to sign the Abuja Commitment on Action on HC, and Professor Sipfo also spoke to us about the desire. If there's one thing, when we were preparing the Vision 2050, about when we completed the Vision 2050 for PSN about 2 years ago, is the need to bridge the gap between academia and the practical practitioners. Like, academia are also practical practitioners, Professor Ero, but you know what I mean. We wanted to bridge the gap so that we can get more work done. Can you imagine Mrs. Lawal working with academia and publishing a copy of the work that she's done with professors in the university as a co-author, as a lead author, over a period of time? She herself will be ready to be considered for professorship. Am I correct, sir? It's the truth. I don't know the methodology for Nigerian universities, but I've had several publications. I'm not a PhD holder, and I don't have a honorary professor. There's no honorary professor in the university. And the truth is, but it has to be documented, everything that you are doing. So what I do is that I take a big thing that has been done for oil and gas services, I look at the pharma industry, I look at the industry for which I'm good enough on, and I write about them. When I work in the telecom industry, I wrote about the telecom industry, about some of the things that I know about cultural transformation. When I worked in the pharma industry, I wrote about cultural transformation. When I provided services to the financial institutions, I wrote about cultural transformation in banking and financial institutions. And within a very short period, I was already becoming a guru in organizational transformation based on cultural transformation. So it's simple. And the reality of it is that we must never forget where we are coming from. Our academic experience was very rigorous. We should not therefore come down to level 0 in terms of documentation when it comes to this. Ladies and gentlemen, I shared all this summary of what I've recorded, first, to let the presenters know that I was not sleeping and that I was busy. And two, for those who came in late, who are not here at the beginning, to let them have a good grasp of what we have shared today. You know that I'm only excited today because knowledge was shared. I'm a perpetual learner. I don't know much, but I'm a perpetual learner. And I always love to attend sessions like this. I'm not a sociable person when it comes to parties, dinner, and the rest of them. It is on that note that I would like to take a few questions before the chairman will make his closing remark, because there's another session coming up. So I'm going to take 3 questions. Can you please raise up your hand quickly so that I can give you number 1, number 2? I have preference for women generally. Any question? If there are no questions, it means you didn't listen to anything. Nothing was learned. Any question to any of the? If there are no questions, so that's number 1. No, number 2, number 3. Thank you. You are number 1. You are number 2. Somebody here, number 2, and then number 3. Number 1, please don't need to thank any speaker. Just ask the question. The speaker, we will thank the speakers later. Yes, thank you. No,
thank you, sir. I listened properly, but to let you know that I listened, that's why I want to contribute. I'm so scared of tests. I'm a pharmacist. I've been practicing for close to 50 years. To the extent that when the HIV test came, I sent my wife for the test. I didn't go. Thank you.
Number 2, thank you. Number 2 person.
Thank you, sir. My question is just to the SFH lady. Thank you very much. The pharmacists that didn't report, I wanted to know, is it that they didn't provide services or they provided services and it was not reported? Thank you.
All right. I'm coming back to you. So, number three, let the person speak. Yeah. So, we will take all the questions together in case they are.
Thank you. I'm not still comfortable with PPMVL to be with pharmacists. I oppose it. If it is that, I will not go. So I want to ask her, what's the separation of us and they? Because they cannot stay with us now. I will not agree. Thank you.
Thank you. Okay, so most of the questions are to the SFH person. Thank you.
All right, thank you. Let me say that these services are being provided, but they are not reported. It's not just injectables or implant services. People who walk in, they want to, sorry, allow me to pull this down. They just want to get oral contraceptive, even if it's refill. Some come for emergency contraception. It's still part of the data that we're getting. So it's not just about injectables or implants. All of them are talking about contraceptive services. So people actually provide these services. You know how many people walk in on a daily basis to get emergency contraception. Even if we do this, it also helps us to see that, to be able to gather data to say, okay, there are a lot of people that are taking emergency contraception, which are not supposed to be taking more than twice a month, and see how we can move them to take up a long-acting method rather than taking emergency contraception that also has effect on their hormonal profile and all that. So it's not just that. It's not that the services are not being provided. They are provided but are not reported. The second questions, the community pharmacies are PPMVs are never put together. We won't do that. So we have trainings for community pharmacies separately, and we have for PPMVs separately. So, madam, I hope that's clear.
That's good.
Yes, they are not put together. They are not compared together. Like I said, we have the Pharmacist Council of Nigeria, who is a regulator, regulates pharmaceutical services, all the pharmacists and other practitioners or operators. So they are there, they exist, and they are in underserved areas. And look at what we're trying to achieve here is universal health coverage. I tell people, in my village, we don't have a pharmacy in my village. But somebody was there refilling my grandmother's prescription until she died at 102. So these people are there. So we really need to, we need to serve people in the community. We need to have universal health coverage. So if we want to key into the government strategy, we need to work with them. But like we said, we need to position ourselves to be able to provide these services, especially in the rural, in the urban area. And we're also being encouraged now to move to the rural area. If we are there everywhere, we will need to engage PPMVs. That's the truth. Thank you.
Thank you so much. On that note, I would like to call on a representative of one of the biggest institutions in the world that has played a very key role in the gradual support and advancement of pharmacy practice. Because it's important for you to know where we are coming from. First, as an integral part of the work of a medical doctor, who normally will do compounding, will write prescription, and will also do dispensing. And eventually we were separated from being to have dispensers separate from medicine practitioner. And gradually, our role started to become much more enriched. And today, our role has gone beyond just mere dispensing to providing primary healthcare services. An organization that has stood behind us like a solid wall for several decades is WHO. It is for this reason that the chairmanship for this particular session was deliberately reserved for a WHO representative. And we notice that we have in our midst one who is very strategic. Indeed, is actually the team lead for strategic health information. So you can therefore understand the value of documentation. And as you spoke about documentation, he is very, very happy to say, whatever support you need, we will give to you. but it must be evidence-based. On this note, we would like to quickly say thank you to all the critical speakers, Mrs. Oladejo, and indeed for my friend, Emeka Okafor, Dr. Mrs. Dorothy Okoa, and our colleague. I didn't put your name here, I'm sorry. Pharmacist, Mrs. Fodasha Dilawa, our professor, Professor Wilson Hero. And on this note, we'd like to call on Dr. Nama Geoffrey, the team lead for SHI for WHO Nigeria, to give his closing remarks and to share his observations so far on the way we have gone during this session. Thank you so much, sir.
Thank you very much. Chairman Sam, you couldn't have chosen a better moderator. Thank you very much. We've had excellent presentations from 5 of our distinguished speakers. And indeed, key issues came up with regard to engagement of community pharmacists in supporting universal health coverage through primary health care provision. As WHO, we are indeed thrilled to see associations such as ACPN appreciate the need for involvement in supporting government in achievement of universal health coverage. 3 key areas as I wind up. I realize time is not on our side. One, as we go through this scientific conference, we've appreciated the frontline role that community pharmacists do play. You see these patients even before they are seen by the other colleagues. You dispense these medicines. The world is currently going through tough times, particularly with the emergence of antimicrobial resistance. What role do you play as the frontline practitioners? How are we curbing irrational use of these medicines? Malaria community is right now very worried that their only regimen is facing resistance. But when we go to the communities out there, the level of irrational use of antimalarials is beginning to be worrying. At a point when there is widespread resistance, what are we going to do when we don't have any other plan B, say, for malaria? So it is our plea that you support the efforts in controlling irrational use of these medicines. To access to care and equitable access to care remains a key challenge in achieving universal health coverage. We've seen presentations where the distribution of this special skill is only in the urban centers. How do we scale it up to the rural areas? Government has adopted the Basic Healthcare Provision Fund, which is meant to increase access to services even at the PHC levels that we are striving to be recognized as. How do we attain that as well? How do we have these services accessible in the rural areas? Third and second last, I couldn't thank you, my colleague, on the issue of information. We are going through a challenge currently where providing these services requires the evidence. And this evidence is currently public sector evidence. Yet when we do the demographic and health surveys, we find out that a significant proportion, over 50% of febrile cases are actually first going to these pharmacies. But when you look at the routine data, it's only 10% of the data that's from the private sector pharmacies. How do we bridge that gap? And it is indeed our plea that through associations such as ACPN, we engage government more. WHO remains committed to support such efforts, to see how you provide the evidence of the wonderful work that you're doing. As she rightly said, if the evidence is not there, then we are bound to be seen as not offering the service. Last but not least, COVID-19 has put to fore the issue of global health security. I'd like to remind us that this is indeed going to become a key issue going forward. And as frontline healthcare workers, how do we support disease surveillance, case detection, advanced events monitoring? They come to you, you're the frontline people to pick up these rare pathogens. How do you support the role of improving health security in this country? So a reminder and appeal again that we have a role to play in protecting our communities against these epidemics or these pandemics. Finally, I want to thank the leadership of ACPN, the commitments that we've seen, very well thought through 13 commitments. It is our plea and hope that the next scientific conference, the committee will put in place a monitoring mechanism that will enable us to assess how far, what progress we've managed to make on each of these commitments that we all called or that we all committed to. With those few words, I want to thank you for the invitation. I want to reiterate WHO's commitment to supporting the efforts of achieving universal health coverage in this country. With those few words, thank you very much.
In order to do justice to the thank you that I've done, I just realized that I could not even read my own handwriting. So I missed out Dr. Kunle Tumeti to say thank you to him. But I'm not fit enough to say thank you to the WHO representative here. I'm too small, too small in height, too small in age, too small in knowledge. So I'll call on the ACPN chairman to please come and handle the thank you. So, thank you. And then make the announcement as well.
Okay, thank you. Thank you very much. Our two big professor. When I grow old, I will continue to pray to be like you, so that I can enjoy the kind of privileges that you are enjoying. Thank you very much, sir. Well, on behalf of the ACPN, we want to say a big thank you to WHO Nigeria. They have been part of this scientific conference from the start, and this is very unique. I'm sure we have never had it this way, that an organization like WHO will be part of the conference from the start to the finishing. Sincerely yours. When I received the letter directly from the country director that he will be physically present, that he will be with me, be with us, I was highly excited. And I'm happy that even when events could not allow that to happen, the personnel that has been sent to represent him are not people of less status. So I thank you for what contribution you have added to this conference. We have this message. Since we started with our press conference, it is clear and now bold that WHO supports this initiative of ours. And that's the message. Anywhere we go to, we'll say it. So we are working as your obedient servant And I'm happy that you have also endorsed us. You have supported us. It's not, we don't take it for granted. We so much appreciate it. And I wish you communicate this to the office and to even the international community, that indeed, community pharmacists in Nigeria are come to, we bought into the vision of WHO to have the world achieve the universal health coverage. So on this note, I would like you to step forward to receive this token on behalf of Dr. Kasadi Molumbos Waters for the support of the organization to this conference and to community pharmacists in Nigeria. And I did mention the committee, the next phase of this process is that we're putting up a very strong steering committee, which, of course, will be coming through the Transgenerational Community Foundation. And I'm glad that your representative is one of members of that committee. And I believe you are going to grant him all the necessary support to make our vision come true. Thank you very much. Please step forward to receive the. So I think we want us to, we just have about, the next session is not a long one, so perhaps I call the Vice Chairman to make the announcement.
Good afternoon, senior colleagues here, the chairman, our erudite professors, and the fellow of the profession. My name is Nelson Benjamin. I will quickly do a brief introduction to the second plenary section for today.
Sorry, let all the panelists for this session that we just concluded to come forward for a photograph. Sorry. For the mission, all the panelists. USAID. Okay. BOT chairman.
Thank you very much. So quickly, we'll be going to the next session for the plenary this afternoon. It's quite important to know that we are still based on the theme of the conference to optimize the primary health care delivery. The community, we are exploring the potentials in the community pharmacists, the pharmacists and the pharmacy as a key component in primary health care. That is what the theme of this conference is centered on. And of course, the WHO said in 1994 that the pharmacist is the most assessed or accessible healthcare professional in the world. And this fact is based on the way in which the community pharmacy is structured. That is, talking about the common workplace where we do our businesses. As we all know, a five-star community pharmacist, he or she is a businessman, is a pharmacist, is a caregiver, is a lifesaver, and of course, he or she goes a long way to balance all these areas of division of interest. And the plenary session is critically centered on the common workplace, talking about the community pharmacy premises, and how we can attend to emergencies in the community now that we are positioning our premises as a place of primary health care. So the plenary session will go in straight away. Yeah, thank you very much. We're sorry for that break in transmission. Ladies and gentlemen, we have been here for quite some hours now. So I'm directed to inform us to quickly stretch our legs because body no be firewood. So quickly stretch our leg for like 2 or 3 minutes while we convene for the second plenary session. Please, let's quickly stretch our legs for just about 2 or 3 minutes.
Hello? Hello? Yeah, it's not quite healthy for us to be sitting for so long, right? Are we there? Yes, let's take a position. Can we stand akimbo? Thank God for social distancing. All right, are we there? Okay, we can swing left. We can swing right. You can swing left again. You can swing right. All right? Good. Can we do something? Can we attempt to bend down? Yes, bend. Rise. Can you bend again? Rise again. Bend again. Rise again. Now, one exercise, right? If you're on this side of the hall, can you just take a walk to the other side? Even if you have, just call it aimless walk, all right? Just walk to the other side, and the ones this way, walk to this other side. Just do that very briefly. Yes. We need it to enhance circulation. Good. Good. All right. Thank you. Thank you. Thank you. Now, are we back to position? Not yet. Okay, madam, we're waiting for you. We're waiting for you. Well, it can't be. Oh. ACPN 2020. In that flash. You want to pick from my laptop? Oh, sorry. Hello? Okay, just let me finish. Okay, can we throw a few punches? Just be mindful of the person in front of you. All right? Few punches.
We are here for peace, not for war. Make sure you don't hit any target. All right, thank you very much. God bless.
Distinguished pharmacists, please, can we move back to our respective seats for the immediate commencement of the second plenary session? Attention, please. Please, let's get seated. We are starting the second plenary session in a jiffy. Please, let's get seated. The second plenary session is about to start. Distinguished pharmacists, please, let's get seated. Thank you very much. As we get seated for this conference, just a quick recap. Of provision of primary care for our patients, which, of course, as community pharmacists, we have been doing for long. The first session saw the need for a policy direction, and of course, that is what gave birth to the Abuja Declaration, which we have partners all over the world, both local and international, that, of course, signed the Abuja Declaration. That took place some minutes back. So now we have policy direction for the inclusion of community pharmacy as a point of primary health care. Having done this, there's also a need to set up the community pharmacy to be able to provide primary care for our patients. That is, the common workplace to attend to patients' emergencies and other cares which make up the primary care center. Beyond the setup of the premises, there's a need also for knowledge impartation. As a community pharmacist, the premises go beyond the physical structure. We're talking about human resources, the knowledge for the community pharmacist to be able to provide adequate primary care for patients. And this is the background for the second plenary session this afternoon with sub-theme, Common Workplace and Community Emergencies, Improving Pharmacists' Knowledge for Better Roles. That is the topic for the second plenary section this afternoon, ladies and gentlemen. I can see that we are all agreeing to listen to it. We have so many erudite scholars, speakers, that will do justice to these topics. Permit me to quickly introduce the chairman for this second plenary session. He is a fellow of the Pharmaceutical Professional Society of Nigeria. He is the immediate past national chairman of Association of Community Pharmacists of Nigeria, IPNC, and of course, the current ex-officio of PSN. He is also the MD of Medisa Pharmacy, talking about the very distinguished Dr. Albert Kelong. Please, a round of applause. of course, that is the chairman of the second plenary session. As we all know, the second topics involve balancing the workplace as a point of primary health care, and of course, imparting the adequate knowledge for the community pharmacists to be able to discharge his or her duty. This is a very, very deep topic that involves very, very, very good speaker to do with it. And that is why we have lined up a very cerebral speaker. He is a professor of toxicology. He is a pharmacologist. And of course, permit me to introduce to you a man with over 20 years of research, both in academic and beyond. I have the singular privilege to invite, of course, to introduce to you the speaker for this second plenary session, Professor Ray Ozolua. Thank you very much. So, Mr. Chairman,
distinguished delegates, fellows of the society, this session I'll be sharing will have as a speaker an erudite scholar. Honestly, he has been a keynote address speaker in our conference, and I'm sure anybody that was here or was there at the conference in Edo State and any other conferences that he has delivered keynote address will know that Professor Ray Ozolua is a distinguished scholar and a scholar that knows his words. Today, this very important subtopic should be of great interest to all community pharmacists because in our environment, I will give you a very practical example. I was in the pharmacy one day. A patient rushed in, two of them with a caregiver rushed in. The guy was gasping for breath. And the first thing that came to my mind to say, should they just go to the, can I refer them to the hospital? But the parents there said, pharmacists, do what you can. I looked at the patient. It was clear symptoms of asthmatic attack. I immediately picked Ventolin on the shelf, opened it, gave them, gave about 2 puffs, and within just 5 minutes or 2 minutes, the patient was smiling at me, and everybody was happy. That was an emergency. And so many other little things like that, like first aid or somebody having an accident, and so many other things like that. So this topic, I will want us to sit down and look at it. If you cannot provide basic first aid to your community, honestly, you will have no business staying within that community. So on that note, I would like us to put give Professor Ray Ozolua a resounding applause for him to come up and deliver this wonderful sub-theme. Prof.
Thank you, Robert. Good afternoon, distinguished colleagues. As you've been told, the title of my presentation is Workplace and Community Emergencies, Improving Pharmacist Knowledge for Better Roads. My name, you know, I'm part of you, and I've been part of you for a long while. I'm an ACPN, honorary ACPN member in Edo State. At least I have your abada. And except that I'm not permitted to pretend over any premises.
but I hope that comes. And by the way, in the course of the presentation, they say academic pharmacists, academics. Those of us in the academia that we are practitioners, that has always been an issue in dispute. And I'm of the opinion that we actually do not practice. And the madam that sat next to me, I said to her that we are Pharisees. And if you know who Pharisees are, they teach what they do not preach. So consider me today teaching what I may not preach. I may not, yeah. So what do we have? Right? By way of protocol, greetings to everybody, including members of the National ESCO and other persons who are here present, seniors, ancient, the younger ones, the modern ones. Some of them, my former students, they are seated here. And I thank everyone for the opportunity. To me, it's an honor anytime I'm called to talk to pharmacists. It's always a privilege. I'm glad to be so invited. Now, what is our aim in this presentation? Can we read this together? What are we here to do? To improve the knowledge capacity of community pharmacists, CPs, that is, in handling what? Common emergencies. The chairman in his opening remark made something clear. You see, if you cannot perform certain roles, nobody will regard you. You are worthless before the community. That's the truth of the matter. So whatever name you want to call yourself, whatever titles you hold, professor, FPSN, F this, F that, if you cannot perform certain roles in the community, you are practically worthless. May we not be worthless. Then, what are the objectives? The first one is to understand the types and nature of workplace and community emergencies. The spectrum of emergencies is very wide. So we're going to pick out some that I consider salient, not exhaustive, the ones I consider salient. Next is for us to understand the place of CPs in attending to these emergencies. And then the last objective, certainly not the least, is to improve the image of the community pharmacists and indeed all pharmacists. I want you to know something. Any pharmacist that does anything good, that does anything that is worthy of praise, is not only doing it for himself, he's doing it for every other pharmacist. And that's the truth of the matter. So when Dr. Albert Akali attended to that patient in the pharmacy, you, in a way, improved my own image in faraway Benin City. Because that's the impression people will now begin to have of the pharmacist. So let's keep that in mind. So if we have knowledge, the knowledge is not for us individually. The knowledge balloons the image of the pharmacist anywhere and everywhere. All right. So I would like to make this presentation by looking at nature of emergencies, some common emergencies, which is the kernel of the presentation, and then key component of emergency service delivery that the pharmacist will need to internalize. Then we'll look at certain conclusions and recommendations, and possibly there may be questions and few comments from members. All right. So what are emergencies? Well, these are not, that's not a word that is, you need to pick up the dictionary to look at. But sometimes, when certain things become academic, it becomes a completely different thing. I say to people, well, drink water. Just drink water. That's simple enough, isn't it? But when you make that drinking of water an academic exercise, you'll be amazed that books as big as that can be written on what? Drinking water. So what are emergencies? I have defined it like this. You may have your own definition, but it seems to me that what I have put here may have the key ingredients of what emergencies may be, should be. Emergencies are conditions that are sudden, usually unexpected, and require immediate interventions. I repeat again. Emergencies are conditions that are sudden, usually unexpected, and they often require immediate interventions. So, to the community pharmacists, this may involve the first bullet here, quick evacuation of staff from an imperiled workplace. Right. Assume that, his house is burning. You say, pharmacist, that house is burning. What do you do? All right. There ought to be institutional guidelines for some of these things. For example, by Nigerian standard, any house, if you are building a house and you have more than 3 floors, then there should be a lift. But we know that these rules are more often than not, obeyed in the breach. That's the truth of the matter. But that's not what we are here for. I wasn't given any guideline to prepare the lecture. But I imagine that we are not here looking at how, community, if there's an emergency in the community, thank God we have very few of them with us. That would have been, double jeopardy if, in spite of our poor state of affairs, we had natural calamities like hurricanes, tornadoes, and so on and so forth. So the natural calamities are few, and they are far apart. In Nigeria, we thank God for that. So as pharmacists in this audience, our core interest is this other bullet, which is to quickly attend to a patient that is brought to us, or when we find ourselves in an environment in which a patient is needing that quick intervention. That's the kernel of the presentation, right? So why emergency services? First, to preserve life, to prevent conditions from getting worse, and also to improve recovery. Some of the conditions may be self-limiting, but many others will require further medical attention. So, nature of Nigerian workplace. We'll look at the community, we'll look at the workplace, because the title is Workplace and Community. Well, you can define the Nigerian workplace as comprising of all sorts. You and I know that manufacturing companies are few, very few, and that's why we are developing. It sounds derogatory. It's a euphemistic way, anyway, to say that we are down there. They don't want us to be discouraged. They say to us, we are developing. But for those who are fairly advanced here, or those who are senior to me, like my big sister, Pharmacist Odili, you cast your mind back. There was a time in Nigeria, there was Michelin in Nigeria, right? There was Dunlop. Go to Ikeja, you see industries, Benin City, Textile Mill, and so on and so forth. Where have they all disappeared to? So are we making progress? But they don't want us to lose heart. So they tell us, give us that euphemistic decoration, say they are developing nations. And Nigeria happens to be one. The pharma industry is there. That's our constituency. We are stakeholders in that arena. Secondary manufacturing, that's what our colleagues in the industry do. They import virtually everything, except perhaps water, used in making the drugs. Paracetamol powder is imported. Name it, everything is imported. And all of us here, while we sat in pharmaceutical chemistry lectures, you remember those reactions, synthesis. By the time we were in final year, many of us could synthesize many drugs, at least on paper. Gadamer reaction, there's Adas reaction, name them. We knew all of those things. Some of us were looking forward to developing new molecules, right? But they never saw the light of day. So Nigeria is a developing nation. And so we won't spend so much time on the kind of workplace emergency you expect in a developed nation, where synthesis, manufacturing, big-time manufacturing is happening on a daily basis. That's not for us. There are a few manufacturing industries, all right? But we expect those few manufacturing industries to have standards. But like I said, these standards, if they are available, are often obeyed in the breach. For example, the hotel where many of us are, that's the one here. What happened? Yesterday, the lift failed many times. If you pressed 4, it could take you to 12 first. And that kind of thing before coming down to 1. And then you may have to now make up for, say, okay, 1 is not far from 4. So let me finish it up by climbing the staircase. So that's what you get. Many of the manufacturing houses may not have smoke detectors, let alone fire extinguishers. That is Nigeria for you. Then we have a second category, small and medium scale industries, sawmills, bakeries, water packaging, factories, and so on and so forth, small scale industries. Well, these are areas in which many of us, or many Nigeria seems to be thriving. Then, of course, the last bullet there about mechanics, panel beater, carpenters, and so on and so forth. Why am I categorizing this kind of workplace? The simple reason is that the nature of workplace would define the kind of emergency that you are expecting to see in the pharmacy. All right. Now, well, we know our community. We've already looked at the workplace. Let's look at the community. We lack basic infrastructure. That's true, right? Abuja looks beautiful, but I can tell you, you leave some of the streets and go into some of the crevices and nooks and crannies, you will find that Abuja will not be as beautiful as it seems to us here. And also no good roads, no good means of transportation. You just have to travel. Thank God many of us here, God has elevated us. We're not quite in that bracket. But you have to travel, interstate travel. Then you know what we're talking about. For about 6-7 years, I was going to University of Ilorin as an external examiner. Each time I did that journey, my heart was always in my mouth. Why so? Because I had no choice in the matter. First, some 8 hours of journey. All right, so whether you can go from Benin through Ekiti, Ondo Ekiti, or Benin, Ondo, Oshun. Somehow you get to Kwara. 8 hours. The roads are in very bad shape. And on one occasion, I remember engaging the driver. I say, "Oh, God, this your tire looks like it's as smooth as my palm." The man said, "Okay, you are not traveling with us today. For daring to say that, you will not travel with us." I said, "What's the man?" He said, "If you talk again, I will beat you." Now be the witch when will they get for road? Say, with this tire, I don't think I can travel up to 5 times. Nothing happen. Make I tell you something. If you buy new tire today, go bust today. Waiting make you to say this one go bust. Because you get bad head, you're not going to enter this motor today. So that's the kind of thing we're talking about. If there were standards, and if we were obeying these standards, of course, people somewhere should be able to stop the man and say, "Look, these tires are not good enough for the road." But I'm always saying to you that you have, more often than not, you don't have choice in the matter. So you enter these vehicles. I've traveled Nigeria. Thank God, I've traveled. Whether from Kano, through Gwazo, through Talata Mafara, to Sokoto, to Kebbi, to all of those areas, consistency in roads and poor transportation. I remember some of those journeys from Kano to that direction, they will pack us like sardine. You have no choice. And you can't afford to pay for so many places. It's just to give you a picture. Electricity, very epileptic. And so many of us are local governments unto ourselves. Right? No potable water, good sanitation and hygiene, not there. Schools, of course, you know the story. ASU is on strike, and that's the longest strike session that ASU have had in Nigeria. You know, health facilities are poor, very poor. May you not be admitted. When you are admitted, you know where you are. You know, we take things for granted. Every day we wake up, we complain, "God, I don't have this, I don't have that." But momentarily, you don't just say thank you to God, you know, for the life that you have, for the good health that you so much take for granted. Because if your health was poor and you went out there, then you know indeed that, look, you are one of the lucky Nigerians to have good health. Many of the teaching hospitals, the story is completely different, all right? So let's look at this second bullet. With, inadequate, can you project that? Okay, is it there? Yeah. Inadequate number of health personnel. Please, as much as possible, diminish my showing on screen. I'm much more interested in people seeing what I'm passing across, all right? Inadequate number of health personnel, pharmacists, doctors, nurses. These are far below the World Health Organization recommendation. I don't think my people from Pharmacists Council, they are not there. Last time I did a public lecture and we had to look at this, I think the ratio was about 1 pharmacist to, is it 20,000 or 40,000? I can't quite remember. All right? Okay, all pharmacists in Nigeria in the register from the very first 00001 to the last inductee, I don't think there were more than 30,000. For a population of 200 million, you can see the disparity. So pharmacists are not there. Same thing with doctors, nurses. The reason why I'm highlighting this is you see the role that you have to play. Oftentimes, doctors are angry. You say, oh, pharmacists are overstepping their bounds. The same way, sadly, pharmacists are angry, when some other lower cadres of the healthcare are performing roles that they assume should be for pharmacists alone. Ladies and gentlemen, let me posit that these are things you have nothing to do about. All right? Instead of quarreling, let us begin to think of how we adjust, all right, to play our role dominantly and more significantly. I think that that's the way we should be looking at things. Remember, the doctor feels hot when you go into clinical practice. That's very conservative doctor. The same way many of us here are so conservative, they don't want to hear that patent medicine dealers have anything to do with drugs. And somebody said somewhere, somebody stood here a while ago to say that in his own village or her own village, who are the people doing these jobs? Patent medicine dealers. When we were young and in primary school, who were the people attending to us, treating us for malaria and all of this? These are patent medicine dealers. They may not have been doing things properly. Thank God that the number of health workers is improving. The point I'm making is that let us learn to situate ourselves, all right, and do well what we should do, rather than complain eternally, enduringly, about some other person making incursion into our profession. And let me say this. You never will hear doctors make too much of capital issues about, don't they know that chews are there? Don't they know that nurses are there? Go to some places, nurses are performing, doing appendectomy. They know. When matters come to a head, you will know who the doctor is. If you choose to die and go to the quack, that's up to you. So that's the way I think that we should begin to, reinvent ourselves, not complaining every now and then, particularly when we have no alternative. A survey was done, and we found that only, how many? 200 and something local governments had pharmacies. What are Nigerian pharmacists saying about the remainder? They should go and die. Please keep in mind, where there is no pharmacist, the people will make one for themselves. So the way we're talking about emergencies now, I can imagine some of the terms very shortly we'll be looking at. Some conservative doctors will be imagining, say, what's the business of a pharmacist? This. Well, that person is living in the past. Particularly in an area, a place like Nigeria, where we are, where the number of health professionals is so much in short supply, the number is in short supply, you have no choice in it. The nurse will perform certain jobs of the pharmacist will perform certain jobs of the doctor will also perform some of the jobs of the pharmacist. The sooner we realize this, the better for everyone. Of course, we know there is rampant lawlessness, greed, corruption everywhere. And then there is absence of plan for natural calamities. God has been on our side, and these natural calamities are few, except the ones that are self-imposed. And now look at I have two rings there, two cycles, right? You have the community pharmacy. That's the outer one, isn't it? And then you have the workplace, the community, and then you have the workplace. Now, I just want you to notice that the workplace is a subset of the community. Many workplaces, where are the workplaces, where are they located? They are located within the community, isn't it? One workplace, two, second, third, 3, 5 workplaces, 10 workplaces are all within the community. And that's why the smaller ring is the workplace, the larger cycle is the community. And can we put it this way? That all community pharmacists are workplace pharmacists. But not all workplace pharmacists are community pharmacists. Have I passed the message? Have I passed the message? All community pharmacists are workplace pharmacists. But not all workplace pharmacists are community pharmacists. The point here is this. You as a community pharmacist, you have to be ready like the Boy Scout to be called upon by anyone for any condition. By anyone for any condition. Just keep that in mind. Right. Now, what do we expect from the community pharmacist? He has to be available. SFH paid for a job I did, I think some 3 years ago. And what was our finding? In carrying out certain surveys, I remember the registrar called me and said, Prof, can you help us evaluate how many community pharmacists are present in their pharmacies from 8 a.m. to 4 p.m., thereabout. I think it was just about 30%. 30% of pharmacists were available between 8 and 4 p.m. Now, the question is this. You see, some of us just think that wearing the toga, pharmacist, that's all that there should be. No. People are watching. If they come to your pharmacy, you are not there. The person who is attending to them is not better than the person in the patent medicine dealer. How then can you argue that people should not go to the patent medicine dealer to source their drug? You are not there to advise on the drug. And so, about 2 months ago, I had need for co-amoxiclav. This was not within the time that PCN asked me to go check. So I went into the pharmacy, right? And that's supposed to be a highbrow area, Ogbowo, close to the university. I met the man, matured man, but later on I discovered that he was the proprietor. So first I asked for the pharmacist, as you would expect me to. Oh, he said, well, the pharmacist just strolled out, it's not immediately available. What do you want? I said, sorry, I want co-amoxiclav. He said they didn't have. And that was shocking to me, the kind of caliber, that status of a pharmacy. You don't have co-amoxiclav. I said, okay, show me where you have your antibiotics. Sensing that he not being a pharmacist, show me where you have your antibiotics. And he took me there. Behold, Augmentin. Behold, this other one. The difference is that he didn't know that the generic name for Augmentin is what? Co-amoxiclav. I didn't want to tie him to any particular brand, which was why I asked for co-amoxiclav. This is the kind of thing we do to ourselves. We need to be professional. It's not enough for us to match, I'm a pharmacist, I'm a pharmacist, only pharmacists should do this, only pharmacists should do that. The question is, you are not there. And the person who is there is not better than the person who is in the other place. So how are you going to tell anyone not to go to this other person to get the drug, particularly using the tool of price? These other guys know that your own will be, if you put 30% markup, they have nothing to, they make their own 15%. So I'm encouraging all of us to try to be available. If you are not available, then you cannot render emergency services. If you're not available, then you cannot render this family planning and all the things that will be, the novel things that the ACPN is introducing in collaboration with the Federal Ministry of Health, all of this will fall flat on their face. So we have to be available. Let us have that as an attribute. Then we have to be knowledgeable. We have to be knowledgeable. And that knowledge has to come through continuous, and I have used the word here, omnivorous type of reading pertaining to health issues. It has to be continuous. Oga Larry said earlier that he is a lifelong learner. I am as well. And every one of us should be. Learn every day. Particularly, we should have appetite for things to do with health and drugs. Once the discussion is in direction of drugs, the pharmacist ought to be automatically interested in it. So we should read wide, read deep to be able to have knowledge to dispense. Knowledge gives respect. That is one thing we must know. You see, by the time somebody comes to your place and you say, you cannot, you say, sorry, I don't think I can help. Next time he comes again, of course you're going to lose that client. If the patent medicine dealer is the more audacious person and can render the service, the emergency service, next time they'll go to the patent medicine dealer, nobody will remember that you are there, in spite of the degree that you say you have. So knowledge is power. Be confident and in control. Many pharmacists they don't have confidence in themselves. No confidence whatsoever. I'll tell you, talking about this emergency, flying in from Benin on one of the last few years back. And in that flight, senators, House of Rep members, because a new government had been inaugurated in Edo State. So they were returning back to Abuja. And then right there at the airport, one very handsomely dressed, one gentleman, the man, he convulsed and fell down, behold, epileptic attack. Of course, people had formed a circle around him, Wise men were, I went there, net behind him. I gave my bag to the MD of Supreme Chemist. That's one big pharmacy in Benin. Gave him my bag, and I squatted beside him. And then some of the procedures I will describe shortly. I went to work, so let's put it simply. But in that flight, there were medical doctors, by the way. Of course, when I started to attend to him, you know what? Wise men were counseling. Fools were also giving pieces of advice, Hey, don't let saliva touch you. Okay? Not let all of that. But, thank God, he surfaced. Because it didn't happen immediately afterwards, I could tell that this was not the condition you referred to as status epilepticus. So calmed him down, dressed him, and the rep from Benin, gentleman, offered his car. It turned out that the man, handsome man, lecturer from University of Abuja in Gwagwalada. So the rep made his car available, and the following day it became an issue in the National Assembly. But keep this in mind. When I was done, some persons came to me, and that included the medical doctor. Said, well, that was quite courageous of you that she read medicine. That's a lady now. That she read medicine, and that's the medical doctor, that, well, maybe she lacked confidence. Where she lacked confidence, I had the confidence. But this is something that will interest you. Somebody came to me and said, you must be a very good doctor. I said, no, I'm not a doctor, I'm a pharmacist. But you know what? For many of us sitting here, you know what? It will be convenient for us to say yes. Or you keep quiet. You call it, so the honor goes where? The direction of medicine. I don't want that. I want the honor to come to pharmacy. Oh, I told the honorable member of the Senate, say, I'm a pharmacist. I said, well, they were thumbing up for me. Knowledge gives respect. Knowledge gives respect. Of course, some of them got to know that I'm of the University of Benin and so on and so on. But many of us lack confidence. Lack confidence. What Pharmacist Akali did, many will not. And part of my recommendation when we are done today will be that there are certain things I expect us to do. For example, how many of us here can give bolus IV injection? Forget about the legality or illegality. Remember, discretion is the better part of valor. Forget about legality or illegality. The doctor that wants to criticize you, if the mother was brought to you, and because you were able to give IV push, IV bolus injection, the mother was saved, that will seal his mouth permanently for life in the way he antagonizes pharmacists. True or false? So we have got to be confident. That's the point I am making. If we don't have confidence, then we are not there. We have to be ready. I said so earlier. Like the Boy Scout, no excuse for not preparing for emergency. And two things, we have got to possess the skill, and we also have got to keep the materials, make the materials available. And we'll talk about those materials very shortly. Then now, some common emergencies. Right? Are we following? Are you with me? You know how these things are. I haven't sat down for so long. See all this talk again. We are here. But this is a practical session. And that's why I prepared the slides this way. I didn't like it, want a situation where I would come and read as if talking to, no. This is something fairly practical. So what are the accident-related emergencies that we are likely to find? Remember that the workplace is a microcosm of the community. So what are the likely things? Cuts and punctures, these are likely, right? Eye injuries are likely. Objects may be impaled on an individual, very likely. Fractures are not uncommon. Burns, life-threatening. Fume inhalation, they are available. Exposure to corrosive chemicals. You hear that, those things still happen. I read them every now and then, though. But I just wonder why. A jealous husband beating the wife with an acid. And it also happens the other way around. I don't get it. But they happen. And when it happens, who are they likely to call first? No, who are they likely to call first? The pharmacist, the community pharmacist. Because you are the health provider. Then there are some that are not accident-related. This one you may call medical emergencies. I'm careful not to use that word medical emergency because the ones that are accident-related, aren't they medical-related? Are they not medical emergencies too? They are. But you may have some authorities who want to separate the two. And the ones that are accident-related, they say, the ones that are non-accident-related, they say those ones are medical emergencies. But they are all of both sides are medical emergencies. So allergies, cardiovascular conditions, fainting, angina, myocardial infarction, hypoglycemia, asthma, epilepsy, all of these are possible. Ladies and gentlemen, need I emphasize again that knowledge is what? Power. And when we have this knowledge, it is not only for us, to make money, it's also knowledge that will balloon our image eventually. And we see some of them that back home, after this conference, we may have to sit our children down and teach them certain things. Why? Because we may be the one in that condition, so they know what to do. So this is not confined to the pharmacist alone, right? So severe allergic condition, that's the one I want us to start with. Anaphylaxis. Anaphylaxis. I don't know how many pharmacists here have had experience with anaphylaxis. Anyone? If you are an old pharmacist, you must have at least one occasion. And if you are not, the younger pharmacists, please keep in mind, while you were in school, would have taught you that some drugs are prone to, they tend to trigger anaphylaxis. Have we forgotten procaine penicillin? Procaine penicillin. What of iron destran? Very much so, isn't it? That was the drug they gave to one pharmacy student at Benin University, Okada, close to Benin. The pharmacy student collapsed. Anaphylaxis. Mind you, in anaphylaxis, that's why I spoke about confidence. Of course, you panic. Why would you panic? Except that you panicking does not solve the problem, does not address the issue. You are trying to help in a condition and then the person collapses. How are you ever going to explain that to anybody? And remember, our enemies are not in short supply. So doctors are waiting. What are they likely to say? Say, now you send yourself message. You were sick, so you decided to go to a pharmacy. See what we're talking about? So we'll be thoroughly scandalized. You keep your cool. Anaphylaxis can happen. There are certain drugs, as pharmacists, we need to know. I just mentioned two, but it's not limited to those two. Procaine penicillin, thank God again, people are not, except in the north, people don't use procaine penicillin that much these days. We know for any injection for that matter, particularly the ones that are prone, what do you normally do? Small push, isn't it? You're going to give intramuscular, you do a small push. If there is a wheel around that injection, then you just stop. No need to pour everything into the individual. Because you do, then the person collapses. So the incidence is there, all right? There are other symptoms, asthmatic attack, fall, cardiovascular shock, all right? Hypovolemic shock, very possible. Coma can result when there is anaphylaxis. So what to do? We just lay down the patient or sit him or her up. Then if there are asthmatic features, we will look at asthma. You handle that one separately. and then start a CPR. What is the full for CPR? Cardiopulmonary resuscitation. Can we say that again? Cardiopulmonary resuscitation. If there is any one thing you go home with today, it is the need for CPR, need to do CPR, learning to do CPR, going home and teaching your children to do common CPR. Why? Our lives is in the hand of God. Supposing you collapse at home, that's not impossible. Your 13-year-old girl should be able to know something to do, and that could make all the difference. You know, I'll put there a rush to the hospital. You wonder why I will be emphatic on you rushing to the hospital. Remember, discretion is the better part of valor. In an anaphylactic shock, you do certain things, CPR. Soon as the person resuscitates, please don't waste time. You don't have oxygen. Do you have oxygen in your facility? Do you keep oxygen cylinders? You don't have oxygen. You don't have some of these things. You don't have other health workers that will assist you as such. So you just be all by yourself. See, don't get into trouble. What should you do? Move the person to a health facility as soon as possible. I had a very bad experience. I'll tell you. What happened? I owned a pharmacy, community pharmacy, long ago. And then the young man who worked with me then, he's a senior lecturer now in the university. You know what? The man had always come to us for certain services. This day he walked into the pharmacy and he said he needed his blood pressure to be checked. And I told the younger pharmacist to do that. Why I attended to some other things. While the blood pressure was being taken, the man collapsed. Out of panic, they came to call me and said, "Sir, the man has collapsed. The man had collapsed." I went in there. Well, the point of prayer. If I tell you I didn't pray, that would not be true. I prayed, I went to work, the CPRO we spoke about, and so on and so forth. Then the man, he came up. He was now coming to. As soon as he could get up and could be on his feet, what did I have to do? You can be sure. I led him gently out of the pharmacy so that the next collapse will not be inside the pharmacy. It will be outside. Of course, you know the legal implication. Fainting inside the pharmacy or dying inside the pharmacy is not the same thing as dying outside the pharmacy. So I let him out, and then we started talking from there. See, we must learn to play safe, right? Anaphylaxis is a serious matter. And so if you do the best you can, then please send away. Now, cuts, punctures, stab wounds are possible. Now, that stab wounds, the stab aspect of the stab wound, I'm not too sure I want us to be involved. You know why? Because there are legal components to this. Doctors don't just treat gunshot wounds these days, treat, you'll be in trouble. So the same also applies to stab wounds. You have to be very convinced that, look, this one won't put you into trouble before you intervene. It will not be worth your while if you choose to intervene. So when there are cuts, what do? We should clean from inside, outside. That simple thing, many of us do not know. Conventionally, what are we likely to do? We swap. We swap from outside, inside the cut. Whereas the proper thing to do is to what? Swap from inside, outside. Why would you need to swap from inside, outside? Inside, outside, you don't bring bacteria, dirt into the wound. Outside, inside, you are scooping bacteria, all right? Particularly opportunistic ones, you are scooping into the wound area. That is not done. So you swap from the center outward, all right? Avoid harsh cleansing solutions these days. Now, if there's an amputation, what do? There's an amputation. Amputation doesn't have to be with the limbs, the leg, can be with the fingers. Remember, we identified sawmill as a workplace around us. Assume that the person's finger is chopped off, and they called you. All you just simply do, wrap the finger that's cut out, wrap it in a cotton swab, wet cotton swab, which you can soak in normal saline, and then arrest the bleeding, and then send away. Again, it makes sense for you to do so. Why? I don't know how many of us here are skilled in how to suture, right? Now, even if you were skilled, you still have to be very careful. Why? If the wound fails, the something fails, they'll come back for you. Nigerians are not, we are largely ungrateful. They will forget that you tried to help in the situation. What they now say is that, look, now you make my papa not get finger. Now you make my papa not get finger. So you have to be very careful about that. Let's look at this other one, bleeding. Once somebody has lost more than, in your reckoning, more than about a liter of blood, please, if you can, send the person away, right? Because the person can go into shock, right? Breathing, we know the common, let me not waste time with bleeding because we know what to do. You press hard on the surface, you do all you can to arrest bleeding. You may have to cut an ampule of adrenaline, all right? And soak your cutting wool with it and place that ampule of adrenaline, all right, over the wound to arrest the bleeding. Of course, you know why adrenaline will be useful. And then send the person away if it will require suturing. Send the person away. If there's a head injury and then you find that a flap has been made from the head, usually flaps come with head injuries. You know why? The skull is very hard. The skull is very hard. As a consequence of my being kidnapped, when I was kidnapped, and many of you knew when, and I had subdural hematoma, they had to do what they call borehole surgery to take out the blood clot from my head. You know, it was not going to be easy. Borehole, you know what borehole is? The skull is very hard. That's the way God made it. And God is a master planner. The skull, that's the brain, is the powerhouse, isn't it? So it's preserved. Minus your helmet, there is a helmet. So the brain is preserved in that skull. Hard. So when things assault the head, what happens? Flaps are made. You know, the skin exfoliates, gets cut off. Please put it back. Just put it back. Good thing again is that usually those flaps, they stick, they come back. From experience, you know this now. However hard the cut had been, the head, that place will cover eventually. Will cover eventually. So let's keep that in mind regarding head injuries. Nose bleeding, you know, some of those things could have arisen from dryness of the dry weather, people picking their nose, sometimes from high blood pressure. So assume somebody comes into your pharmacy, nose bleeding. One of the things I expect that you should do would be to take the person's blood pressure and see whether it's something hitting the roofs, because that may just be the reason why that is the case. And if the blood pressure is hitting the roofs, please do what you have to do, all right? But as an immediate step, what will you have to do? You clamp, use your index finger, your thumb, to clamp the nostrils, all right? Hold it for some time while the person tilts the head back, and then that could arrest the bleeding. But let's be careful. Again, there are some you may not need to bother yourself with. We say we want to render emergency services for relevance, for so many reasons, but we don't want to render emergency services to get into trouble or to scandalize our profession. So when you see a clear injury, somebody with, the nose is cut into two, what do you want to do about it? Yeah, you clean, adrenaline, in cotton swab, wrap around the person, and please send the person away in order not to get into trouble. Send the person away, right? That's what I want to advise there. Let's look at this other one, impaled objects. We're talking about a situation in which an object is embedded in the person's body. Well, some are so easy, like the nail. You can pull out the nail, right? Why? The nail has a smooth end, isn't it? So you can easily pull out the nail. But some objects are not that smooth. Okay, so they got in there in an attempt. Let's take an arrow, for example, an arrow that's stuck into an individual. Attempting to pull out the arrow, you do more damage. So that will require some bit of surgery, all right? And they have to carefully remove that object. So if in your assessment, this object is not what you should pull out, leave it. All you just need to do is use a cotton or bandage to, localize that object and then send the person away to the hospital. Again, in order not to get into trouble. Eye injuries are things that can come to the pharmacy as well. Do not attempt to remove foreign body on pupil or that's embedded in the sclera. Something, you can see that something has gone, is pierced into the eye. Don't bother to remove it. Not worth it. Because in removing it, you do more harm than good. So the best thing is, again, to do certain things, cover the eye with a clean white pad, as I've stated here, the bandage, and then bandage both eyes and send to the hospital. Now, the common ones we see, you say, oh, something don't enter in eye. You don't agree come out. We hear that one quite often. We can help in the community pharmacy. We can help. Simple way, right? I've been listed here. You can lift the eyelid, use wet the a cotton bulb with normal saline, and try use to pick the thing from the eye. You can do that. You can also ask the person to, a bowl of water to open the eyes, all right? And then you just shake that, and the thing will get off from the eye. But the thing to take away here, if there's an embedded object in the sclera, my dear, leave and send the person away. Remember, discretion is what? The better part of valor. We always keep that in mind. Because sprains, these ones can happen anywhere. Somebody can miss a step on the staircase or have sprain and so on and so forth. Swelling and pain, these are symptoms. Rest the limb, ice compression. We know how to do all of that. Make ice compression to reduce inflammation, elevate the limb. Then please apply analgesics. In this presentation, you will be seeing some of the areas in which I put question marks, particularly where drugs should be recommended. I do that for some reasons. At some point, I'll discuss about how we can make money from these emergency services, because that's very, very important. So the discretion eventually will be yours, whether you should give drugs. You see, people, well, okay, we'll get there. Let me keep the gunpowder dry. We'll get there. All right. So fractures. How many of us know what to do if we were called to attend to fractures? Splint. Yes? There are medical splints. There are splints designed, but the fact of the matter is that splint can actually be improvised. You can get a wood or plank somewhere, or a stick. The important thing is to immobilize that broken limb, okay? Elevate it, arrest bleeding if there's an open wound, then move to the hospital. Of course, as a pharmacist, just as I know too, that you don't want to start dealing with fractures. Much as you can. See, there's no big deal about handling fractures, but it just doesn't make sense for you to be involved. Any two bones, particularly when this fracture is simple fracture, the one doctors will refer to, orthopedics will call simple fracture. In other words, the bone just broke, like that, you can see. Immobilize that bone, put the two ends together. In 3 months or so, they will grow into each other. It will be fused. That's what these tradomedicalists do, and then people tend to applaud them. There's nothing fantastic about joining bones together. But when the fracture is of the compound type, you now have the thing broken into pieces. That's a different matter. All right? You have more broken components. That's a different matter. It makes sense for you to seek an expert. Because, you see, in the hospital, they will put some physics into the picture. You don't want the person who has had a broken limb, tibiofibula, for example. When you are done with the person, will not be walking like that. What have you done? Will be walking like that. The bones have grown. If it's just mere growth, you want the bones to be, it's done. But that's not right. In the hospital, they will try to do the alignment. Make the thing as normal as possible. Just like you will have with your car being dented on the road, okay? The panel beater will do what we have to do. But the part of the matter is that the car will not be the same again. All right? It will never be the same again. So you give analgesics before you send the person away. All right, bonds. This one can happen in the workplace, can happen at home, you know. I always tell pretty ladies who don't want to take God seriously, and they tend to take, they tend to be much more conscious about their beauty. They say, well, thank God for you. One gas fire accident and that your face will burn like that. You'll now be fit for the zoo. Then you now appreciate the place of God. You know why I say that? Many women, and that may include my wife, reason for going late to church is because the head tie has to be labalaba style, satellite dish, you know, one shape or the other. So sometimes I ask, what is the name of this particular style now? You know, so we spend time. Yes, okay, ladies have to be elegant. That's why we are men, and our life will not be the same if they don't look the way they look, you know. But the truth of the matter, bonds can happen, and they do happen. They are usually put in degrees, and I'm sure many of us would have heard of first-degree bond, second-degree bonds, and third-degree bonds, all of that. So I'll put some pictures there. They are not too good to the eyes, but that's what they are. Talk about first-degree bond. Only the top layer of the skin is affected. You just see that, right? First-degree bond. Second-degree bond up to the dermis. Then third-degree bonds, you know, deeper layer or recesses of the skin. And that's what you see. So that third-degree bond is much more serious, more, that's again first-degree bonds. If it happens, what if somebody comes to the pharmacy and say, oh, he has had a bond, what do you do? Could be a scarred. So what do you do? All right? Sometimes you just, first and foremost, because it's going to hurt, just put the affected parts in running water, cold water, and then drain the thing for some time, cover with clean gloves, analgesics. You see, I put a question mark there, leaving the discretion for you. You need your money. If you just render these services and people walk away, in fact, to ask you a question, how are you going to evaluate some of the services anyway for people to pay? Say, go pay cashier. For what you did, go pay cashier 5,000 naira. He say, make I put my hand for water, I put them. He say, make I go pay 5,000. They can't make it out. It doesn't make sense. So you have to, as a pharmacist, find a way to get some, there has to be some money coming to you. So what harm will an analgesic do? But they actually do need it, don't they? They will need an analgesic. Will vitamins do any harm? Then you put some of these things and then the person pays, and so at least money comes to you from your effort. All right. Second-degree bonds, you see, blisters we present. You know, there are procedures there. Raise the bond limb. Then remember that blister. Sometimes the blister may have to be burst. But you know why? If you don't, that blister is going to cause it's going to be a source of pain, right? We know it now. Very serious source of pain. So we may have to burst that that blister. Then, of course, that may create an open wound, isn't it? Analgesic, antibiotics, all of this may become relevant. Okay. Then, third-degree burn. That looks unsightly, isn't it? Very, very ugly. But that's third-degree burn. Now, see something about third-degree burn. There's usually not much of pain in third-degree burns. You know why? Because the nerve endings have all been exfoliated, they've been destroyed. So no pain sensation as such. Ugly as it seems, not much of pain sensation, you know. But this is the type you need to rush to the hospital for many reasons. You know why? Because it has gone into the deeper recesses of the skin. Serum will be, you don't want the person to go into septicemia. That's a different matter entirely. You don't want to be involved in those kind of things. Would you? The answer is no. Again, we will emphasize some things at some point. Discretion being the better part of valor, as I have said earlier. So it may not be worth your while to get to be involved in managing third-degree bonds. Okay, so I've put there you should just refer after you have given your very basic knowledge or assistance. Food poisoning. All right. Now, be careful. One thing I know that mistake pharmacists make, which they ought not to make, they talk when they ought not to talk, and then they don't talk when they ought to talk. I'll tell you how. In the last national conference at the Lorry, I was there on the auspices of Clayton Health Access Initiative to make a particular presentation. I remember telling my colleagues, one of the problems with us is that we don't even speak the language of the profession. We are ordinary. Nobody will take you seriously if you are always presenting yourself as what? Ordinary. You ought to muscularize your appearance, muscularize your delivery. In other words, speak technically. Pharmacists don't speak technically. Let me tell you something. Some of us have better gift of the gab than lawyers. You know, in our days, unlike what they do now, the best in the sciences were almost always the best in the arts as well. So things fall apart, we read. Shakespearean books, all of that we read. We can still remember the quotations from Shakespearean books. When the lawyer finds that you are overwhelming him in the argument, he resorts to what we call linguistic immutants and puts something, speak a Latin expression. And that will disarm you. True or false? That's the way they tend to make themselves, and so you keep quiet. What of priests? Many of them don't know the Bible as much as you. Beg my pardon. But what do they do? When you see the priests all come together, they begin to do like that, in reverence, making the rest of people look ordinary. They even put a bar there that this is holy of holies. You don't cross. But what do you find with the pharmacist? Your dressing is not different from that of the tailor next door. That's not good enough. A doctor comes into the place. He's asking for an analgesic. You've forgotten your chemistry, or at least your pharmacology, something. And I asked them in the lorry, what would be wrong in you asking, sorry, doctor, you are here. Sorry, do you have any analgesic in mind? Engaging the doctor in a conversation. Do you have any analgesic in mind? He says, well, I wanted to buy piroxicam and all of that. Oh, say, well, you seem to any preference for anoxicam? Have you thought of a propionic acid derivative? The next, when you now say, will it propionic acid derivative? You say, oh, pharmacist, what is the difference? I say, well, you see, propionic acid derivatives are more gastro-friendly than the oxycams. And that's, you understand? Then you say, okay, what do you suggest? Let me ask you, at the end of the day, who is prescribing? You are the one prescribing. But sadly, many of us don't talk muscularly. That's the problem with us. We are so ordinary, so lax. And that's why we are taken for granted. And I urge us all, appear well, speak well, and then put some technicality. See, let it be the trouble of the person. You can help the person. After you've used the technical term, say, okay, well, I know you won't understand, but this is what I mean, this is what I mean. You cannot afford to be like the patent medicine dealer, and then you expect the public to regard you as such. It doesn't work that way. My senior brother said something like that a while ago. So we must begin to change our orientation. And I'm glad that we have begun with some of the deliverables in this conference. So why I said this is this. You say, I remember I said to you, we often speak when we ought not to speak. They bring the person into the pharmacy and all of that. I say, oh, this is food poisoning. Food poisoning. These guys don't understand the meaning of food poisoning. You may not be able to render any assistance. Even if you render the assistance and then help, you know what they go with? Pharmacists say they poison ammo. Pharmacist talk him, he say they poison him. Then the trouble will be on the wife or somebody. Say pharmacist talk, say they poison him. He say na food, they poison in food, say na food poison. Whereas to you and I, food poison doesn't mean that the person has been poisoned deliberately. All right? Usually caused by bacterial, viral, parasitic toxins. We know so. There are various symptoms depending, and I urge us again to read. If we're going to be picking them one by one, we will not finish this lecture. Go back again, look at those food poisoning, salmonella kind of poisoning, botulinum poisoning, all of them, they have their characteristics. Let's go back, look at them, and then that's the knowledge we are talking about. So I want us to know something. Some of them may present with nausea and vomiting. Nausea and vomiting, alongside diarrhea. My dear, if you have that kind of presentation, unless there is no health facility, no hospital around there, please send the person away. Because there's need for IV fluid replacement. I'm not too sure, as a pharmacist, you want to set up an IV line in your pharmacy. That may be overstretching it. So that's the reason why you have to send the person away, all right? But we all know that these days, we don't treat diarrhea situation in children using antibiotics. We know the answer, isn't it? What do we rather do? ORS. And now you talk about low osmolar ORS. Please, with what? With what? With zinc sulfate. All of that we need to know. All right. Now, let's come to our own. The one that you are very likely to come, somebody will call you from Abuja, call you from anywhere. They call me, even from this Abuja. He say, Prof, the person he swallow this thing. What do we go do now? Sometimes more tablets than should have been taken. All right? So what do we do? You will find that many of our colleagues, if not all of our colleagues here, nobody has something for induction of vomiting. If you have, you may kindly raise your hand up. There is something called ipecac. Tincture of ipecacuanha. Those days in pharmacognosy, the sound always amused us. Ipecacuanha. But that's what is recommended for the induction of vomiting. Tincture of ipecac. And I ask this question not only here, everywhere I go, the same thing. And for hospital pharmacists, I've challenged them. The day something goes wrong, again, you are not so much in control in the hospital. They say they didn't find. You know what some of these our doctors do? When troubles come like that, they go check their books, say, what to use? Ipecac. They will write ipecac, 15 mils, and then take this prescription to the pharmacy. And if something ugly happens, then the CMD climbs down from inside horse. See, I've told you. And by the way, the CMD could have been my classmate, and then the head of pharmacy is the classmate of Madame there. In other words, gap in terms of age and everything. See, I've told you, what do you do in this pharmacy? What do you do? And I issue a query to the HOD pharmacy, and everybody will panic. CMD has issued query. So let us be mindful of certain things. See, I will emphasize this. If we want to be relevant as pharmacists, it is not, I thought somebody mentioned it. You don't expect money from every aspect. But there are some persons who will come on account of the services you render. You make up, you even make the money. The money you've not made in the past 3, 4, 5 patients, you make all in one and perhaps more. And that's the truth of the matter. So it's not, why will I stock ipecac? Who will come and buy ipecac? My dear, one bottle of ipecac, one bottle, will not do you any harm. If it expires, it expires. You replace it. That's how these things are. You don't lose anything. All right? Then there's something. I'll put the doses here. I usually don't like putting doses when I'm even teaching in class pharmacology because I think through experiential exposure, people get to know doses of drugs. So I don't The days of, is it posology, Egbon? Posology. Posology, you know, those days. In our time, we didn't do posology. In the old order, they did posology. The dose, the color of the tablet, they will ask you in exam, but not anymore. Chemical absorption. How many of us have activated charcoal? Oh, thank God. The bulk of us have activated charcoal. All right? That's another way, because this one absorbs poisons. But look at a rider. There's a rider. Keep in mind, it will not bind metal, cyanide, acid, alkali, not. And then keep that one in mind. Charcoal poison ratio, 10:1. So you have an idea. If they say to you a too close amount of drug, then you can tell how much of activated charcoal to give. All right? It doesn't do harm to anybody, activated charcoal. But let us have all of these things. Need I say that even those of us who are not in community practice, we can have these things at home now. Because people can come to you, they knock. You say, a professor of pharmacy. They don't, there's a difference to them, say professor of pharmacy, not professor of pharmacology. So everything about pharmacy you ought to know. They say, what does he say? He swallow poison. He swallow poison, no. He swallow poison. Then you are there, you just look like lame dog, nothing. They say, okay, what you go do now? You don't give him water drink. I say, okay. I say, what kind of professor be this? I think they're saying a professor of pharmacy. You know? So let's learn some of that. Purgation is another way by which we can take out the poison from our system quickly. Right? The purgatives are usually harmless. The only purgative I know so well now, purgative Epsom salt. That's magnesium sulfate. This is still available. Epsom salt. Epsom salt. Give Epsom salt. That will result in massive stooling. All of this to try to get the poison away from the body as quickly as possible. Now, that man is asking a question. Can you read it from where you are? What's his question? Any sense in giving palm oil? Is it not true that everyone we may have heard? Something must have been said to you, isn't it? They say, you're not giving palm oil drink. I'm speaking pidgin English because that's the way we transact business day to day in Nigeria, largely, particularly Edo Delta. So everybody talks about palm oil. Well, we have evaluated this palm oil business over time. There's some sense in it. Most of the poisons that will be absorbed, this we say a basic requirement for drug, for anything to be absorbed into the body is that it has to be lipid soluble, isn't it? It has to be lipid soluble. The more lipid soluble the thing is, the faster it crosses the cell membrane and it's absorbed. So take palm oil, then the poison can be partitioned into the oily phase. And because the quantity of palm oil is much, that itself can become an emollient, can even result in purgation. All right? And so some or a large quantity of the poison can be lost in that regard. I hope it makes some sense. Okay, so palm oil can be useful. Our people, they use palm oil without knowing the science behind it. They use palm oil over time, and it has helped substantially. Not in all cases, but it does help. Okay. Then chemical inactivation, vinegar or lemon juice for alkali, antacids for acids. I put something there. I say this inactivation may be injurious. Why? There can be heat of reaction. What they call is it enthalpy? Enthalpy. Heat of reaction. So the person has taken an acidic something. You want to give mismark. So of course the reaction will happen there. That may result in the generation of heat internally. Depending on how much heat is generated, that may destroy some cells. Bathe surfaces copiously with water. Right? We also know that milk is given sometimes, isn't it? Yeah. Then again, question. Will you give analgesics? Will you give antibiotics? Will you give vitamins? Think of how to get your money back. Hypoglycemia. one of the doctors who came, one of the persons who came with His Excellency yesterday was my classmate in secondary school. And so we're together in my room after we left here, very senior doctor in Ondo State, and described a situation in which he suffered hypoglycemia. What was the cause of his hypoglycemia? As a doctor, it was not because he didn't have money to buy food to chop, not likely. His own case, you can predict. Why? His own doctor placed him on an oral hypoglycemic agent. His own doctor gave a dose of a drug, recommended a dose of a drug, an oral hypoglycemic agent. Too much. And that's how my friend went into hypoglycemia. All right? So this should be expected. The insulin that person is using, person may take too much of it, may even take the proper dose, but has not eaten. And so that results in hypoglycemia. And then there are signs, tremor, confusion, all of that we present. See, everybody knows when somebody is a diabetic, you avoid putting the person on a beta blocker. Beta blocker will mask these presentations for hypoglycemia. And so the person can go from hypoglycemia, will go quietly to death without any warning sign. But in the absence of beta blockers, all these signs can manifest. And then, simple solution. It's not a big deal. Anything sugary comes handy. Coke. Name it. Let the person begin to gulp. If you want to make your money, don't ask for Coke. Carry the glucose in the shelf and put in. Because I'm always thinking of, that's why I'm a lecturer. I've never been good thinking about money. But in recent times, when ASU had not been paid, salaries had not been paid, I've started thinking about money. So pick a glucose from the shelf and then pour into the thing and give the person to drink and see whether the person will surface. Almost always, the person surfaces. But if the person goes into unconsciousness, coma, what do? Please refer. It should never be said that the person died in your facility. It doesn't help. The converse now, the other side of it, hyperglycemia, okay? Undiagnosed diabetes. Those who have not taken, they don't take their drugs, okay? And then there are symptoms. I suppose these slides will be available to everyone, isn't it? And that will make us faster, all right? You can smell the fruity acetone smell from the breath of the individual, all right? If you put your nostrils close to the person's mouth and you smell the sweet smell coming from, then you can tell that this is hyperglycemia. And then due to the acetone in the breath. So diabetic ketoacidosis is a medical emergency. Please do well to refer. Okay. Electric shock. Again, this is within the community. Victims may fall down, have powerful muscle contraction, fractures, seizures. If called to the scene, what do? Ensure source is switched off. Do not attempt to remove the victim without ensuring switch off from source. That's common knowledge. If access cannot be gained to the source, disconnect using the wood. Do CPRO in the absence of breathing. Give supportive care based on symptoms, and then refer if there are fractures or those other things. Now, seizures. All right? Seizure can occur from various sources. Hypoglycemia we mentioned earlier. Use of certain drugs can, in fact, substance abuse can result in seizure and what have you. So in grand mal, which is what that lecturer experienced at the airport, all right, ensure safe environment, place something soft under the head, open the airways. That was the one I did. Open the airway if breathing is labored. Open the airways, all right? Thank God the person was not producing mucus copiously. Then advise hospital visit if it is the first time. First time is convulsion. Happens again and again and again, then what do we diagnose? Epilepsy. All right. So if febrile convulsion, women, you know so well, what do? Tepid sponge. Huh? then you are told not to cover the baby with oil. In both cases, consider IV diazepam. IV diazepam. Maybe due to difficulty in breathing. By the way, that IV diazepam, I wish that you check the dose for yourself, dose for children, all right? It may be helpful. Somebody is down there, projecting like that. Everybody is panicking. Just give IV diazepam. I will talk about that shortly. I seek your permission to just speak. Just give me a few minutes. I'll be back.
Okay. Thank you very much, Professor Ray. I'm sure we have been highly informed about how to manage emergency in our workplace. Like I said earlier, in your practice area as a community pharmacist, you're the healthcare provider within that environment. And you must be seen to be competent. You must know what to do when a situation arises. To basically, there's hardly any need to summarize what he has said. But I would like to just mention one or two things that he has said, because we're going to have two presentations. The slides for this presentation will be forwarded to all delegates to this conference. But I know that Prof started by, first of all, letting us know the aim of his lecture, and the aim, we recited it together, to improve the knowledge capacity of community pharmacists in handling common emergencies. I'm sure we all have that one. That is the aim of his his lecture. He went ahead to give us the objectives, and then went straight to the nature of emergencies, what are definition of what emergencies are, nature of Nigerian workplaces that can lead to emergency situations. The case I mentioned, I spoke about earlier, was a patient from a site. So they were working on renovation, and the dust around there triggered the asthmatic attack, and they had to rush to my pharmacy. Then the nature of our community, all these ones can also lead to emergencies. Community and workplace. He told us that workplace is situated within a community, so we must sit up. Community pharmacies in emergency situations must be available, must be knowledgeable, must be confident. In fact, confidence is key. Even when you are making referral, if you are not confident of what you are saying, if you are panicking making referral, people will not be sure what to do next time they have an emergency. You must be ready. You must be knowledgeable to be ready. Thank you. Prof is back.
Thank you. You can guess what I went to do. Can anyone guess? It's simply to obey the call of nature. It was an emergency. I needed to empty the bladder. And we know medically, you don't keep this thing for too long. It may not be helpful to you. And the excuse will be that I was talking to my colleagues. And remember, if the bladder is full, it may also affect my comprehension, my delivery. So I had to quickly go do that. Thank you so much. I appreciate my sincere apology. All right. Okay, now, we were done with this, isn't it? Okay. No. Difficulty in breathing, all right? Assess the airway, right? Breathing and circulation. There's what we call ABC of life. ABC of life. We have to keep this in our minds. A is what? The airway. Making sure the airway is clear. B is what? Breathing. Making sure that the person is able to breathe. Then the third is what? Ensuring circulation. That's what referred to as ABC of life. And then to interest you that nowadays, again, they are introducing a component D. D there is defibrillation. Defibrillation. For those that may have sudden cardiac problem, cardiac arrhythmias, you can use the defibrillator, right? But for most persons, ABC. It wouldn't be out of place if you have a defibrillator, right? Some perhaps, these are things that individuals even now keep for themselves, all right? Assume that you have cardiac problem, you can keep one at home, and then teach people how to connect to stimulate the heart when if there is need. Nasal decongestant, you have to evaluate whether that will be necessary. Assume the person is not able to breathe. Sometimes these things can come very embarrassing way. The senator is going to make a talk tomorrow, and then today his nostrils are, whether from sinusitis or rhinitis, whatever, congested. He now opens his mouth like a dog everywhere, very uncomfortable. So you may consider using nasal decongestant. You may have to question asthma. Okay, I'm being served a yellow card. All right. How many minutes? Okay. Oh, dear. All right. I had the wrong impression that I was the only lecture. So lay the person, when there's no breathing, lay the person on his back and with head slightly tilted backward. Breathe into the person's mouth. This is the essence of CPR, cardiopulmonary resuscitation. Cardio, we know that has to do with the heart, isn't it? All right? Pulmonary, that has to do with the airway, isn't it? All right? So you lay the person on back, slightly head tilted slightly backward, then breathe into the person's mouth and repeat the process while emergency services are being expected. See, it's no big deal. You see what that lady is doing? He's trying to, see, who can tell the position of the heart? We all know, isn't it? Left side, isn't it? Left side. If you put your hand below your breast, then you are likely to feel your beat. That one is what you refer to as apex beat. Apex beat. So if you tell your wife that you are my apex beat, she will grin from molar to molar. Even if you don't mean it. The way to mean it is to increase the money you give to her, not by saying it. Okay, you massage the heart. You massage the heart. But the point I want to make is this. All of us, assume an emergency situation presents, and then the person is not breathing, is passed out. My dear, even if you don't waste your time doing that, which is helpful, see, blow. After all, if he's dead now. Do you understand? Blow to the heart, big like that. You'll be surprised. The heart will pick. Some of these things in pharmacology lab, while we dissect, we do work with rats all the time. You give an anesthetic and the rat is passing out. The rat that you bought for so much. Experiment that you have been working on for the past months. This rat want to die and you go finish the job. The point is massage helps. All right? Blow. It shouldn't. Do whatever you can. Do whatever you can. At that moment, this person is not breathing, do something. You'll be surprised. I've tried this and it has worked. My auntie was almost passing out and all of that. I engaged her, did that. She surfaced. Started breathing. I told you of the man who they brought into the pharmacy, isn't it? And he surfaced. These things work. My dear, no panic. They say the person available. You say, oh, he's passed out. He's not breathing anymore. Do something. Massage the heart. If you don't want to waste time massaging the heart, I say do what? Blow. Apply blow to the place. If the person is dead, he's dead. So your blow, you will not wake up and say, why did you give me that kind of blow? If he did that, then he was pretending. He was pretending. All right? Then breathe into the mouth. Yes. If you have your handkerchief, this is not the time to be talking about, say, hey, say, I want to put, I be somebody's wife. How I want to put my mouth for another man's mouth. No. We are talking about life. You can use your handkerchief to clean the edge where saliva, you know what I mean? Huh? Blow your breath into the person's mouth and you'll just find that things will become okay. Not to do something is what is bad. We must always try to do something. That's what I'm emphasizing. All right? These are processes in cardiopulmonary resuscitation. Shock often happens from hemorrhage, that's hypovolemia. You take the vital signs, if need be, and I ask the question, would you need to give hydrocortisone? Keep something in mind. Corticosteroids are life-saving entities. In the hospital sometimes, when they are out of their wits, in other words, not knowing what to do anymore, you know what some of the doctors do, the experienced one, they give a shot of hydrocort. For whatever purpose, if the person is not going to live well, so you just try, give hydrocort. And more often than not, the person gets up and begins to, to breathe again. Heart attack. This one is very important. Heart attack. It can be minor. The minor one is what referred to as angina. So what do you do? Remove the clothes, particularly if the man is, you know that fella song, even when you are sweating, you want to be like Oyibo man and you knot your tie to the neck. The whole environment, please remove the tie and all of that. Then keep the victim, or the patient rather, would have been a better word, keep the patient still. Do not give stimulants. You know what stimulants will do? They will agitate the heart now. This is not when you want the heart to, Now, that one is highlighted. That's aspirin. How many milligram? 300 milligram. I serve in the essential medicine list of the Federal Ministry of Health and the standard treatment guidelines too. I'm in that committee. And then one of the most revered clinical pharmacologists in Nigeria, Professor Ambrose Issa, my mentor, he was arguing that we should remove aspirin from the primary healthcare list. And you can tell why. Because of fear of gastro-ulceration and all of that. No, remove aspirin. No, then one doctor, one professor from University of Uthman Danfodio University, Sokoto, he spoke to us and said, look, leave that aspirin there. Aspirin. So if you ask me, all of us ought to have aspirin at home. Aspirin has become a fantastic drug. I'll tell you, for many reasons, become a fantastic drug. They say it reduces tendency for colon cancer. Aside from the traditional roles you've always known for aspirin, of course, as a thromboembolic drug, that low dose aspirin, many things that have been associated with it. But 300 milligram aspirin, when somebody is complaining of chest pain, ladies and gentlemen, regardless of the source of the chest pain, don't waste your time. It's not routine. It's not as if the chest pain started yesterday. I hope you're following me. That suddenly the person is having chest pain. What do? Give the person 300 milligram aspirin immediately. 300 milligram aspirin immediately. That will avert possible MI, myocardial infarction. This is something that the world has come to terms with. And so when that cardiologist told us, we kept our mouth shut. Knowledge is power, isn't it? Superior argument. And that's how aspirin is in the primary healthcare list, in the essential medicine list. It's there. So you and I ought to have that in mind too. The man suddenly is having complaints, say, oh, having pain here. Please, aspirin, 300 milligram. All right? Give to the person, and it saves a lot of trouble. It may be a case of minor heart attack, the one you call angina. How many of us have nitroglycerin, or also called glyceride trinitrate? Ajia Omar, you have. Good. Many of us have. You keep that. 4 milligram, 0.4 milligram, sublingual, isn't it? Sometimes the way you see drugs, If I wasn't a pharmacologist, if we were not pharmacists, we consider them as miracle entities. You give like this, you just see the wonder almost immediately. Nitroglycerin sublingual, right? Then, of course, rush the person to the hospital. Don't keep for long. Well, this one, let's not waste time. Some other persons, they may rush somebody into the place, say, oh, he has, something went into the throat. Something went into the throat. Throat. Ask them what throat is, they can't tell. Chances are that something has actually gone into the windpipe, right? The bronchotracheal region. That's where something that ought not to get in there, gets in there. And the way God has made it is that Anything foreign that gets into the place triggers reaction, bronchospasm, right? You cough, something will happen to try to force the thing out violently and will not always be successful. So choking is not unusual. And many of us choke. Pepper soup, choke. While eating, you are talking, choke. Talking for too long, choke. So choke can come from any quarter. And then some persons can be sensitive to bronchospasm. You know, that small thing that you look like that keeps on persisting, and the person is really distressed. All right? So there's something called Hemming's maneuver. Hemming's maneuver. I think it's there. You see what that person is doing? Where has the person wrapped the hands? Above the stomach, isn't it? And then you hold the person like that. But that can be done by somebody who is bigger, taller, isn't it? If you are a woman and your husband is briefer, how are you going to do how are you going to do that one, Hemming's maneuver? That's not possible. Is it possible? The what? You climb the staircase. That's right. Okay, you are smart. You see, it's always good to take lessons from senior brothers. He's been in the business for too long. You know, so you climb the staircase, you can drag out there, and then that enables you to do that. But there's an alternative to it, and that's that you put the person across the arm of a chair. All right? Across, the person can lean over a chair, and then you give blows at the back, and that tends to help. Named after Dr. Hemming, an American physician who was said to have evolved this procedure, this maneuver. That's why it's called Hemming maneuver, right? So quickly, time is fast spent. Snake bite. We are getting into seasons of snakes now, okay? We all know how to deal with snake bites, but all I want to just emphasize here, all right? You want to suck the point of envenomation. Don't use your but what people do is to put a cellophane, all right, and use that as a basis for sucking. You know why? There may be tear in your mouth, all right, from which the venom can easily penetrate. And besides, nitroglycerin is sublingual, isn't it? Drugs can actually be absorbed through the buccal cavity. So why don't you think that the venom may also get into you in that process? So don't use your raw mouth. Say they say make we suck, now they suck. This is not one thing you should suck. You understand? So you cut, you can express with the hand. These days, before you go pursuing the snake, see how the snake be. The head wide, no, the head be like triangle. The head be, scientists have ways of wanting to describe poisonous snakes. I don't think that's relevant. There are about 4,000 species of snakes. Only 10% are poisonous. But ladies and gentlemen, all snakes deserve respect. We know so, isn't it? I don't know whether you want to go and begin to look at a snake. Say, no, he has a round head, so it's not likely to be poisonous. He has one single roll of anal scale. Have you seen the anus of a snake before? Let you know to know whether it is one roll or two rolls. What's your business with that? If it's a snake, please treat as such. But one thing we should do as pharmacists, let us stock polyvalent antivenins, or they also call antivenoms. If you don't have in your pharmacy, please do well. One won't be out of place. I've told you some of these things is not, we do them because we are professionals, not necessarily because of the money we are going to make out of them. Just one ampule may be very important, polyvalent. And sometimes let your colleagues know that you have some of these things. So they call from teaching hospital. They say, oh, they don't have in the hospital. They say, go to social pharma. Time for you to make your money. Because if you tell them, if you bought it for 5,000, you now tell them it's 20,000 that night, they will pay. That's the truth. So let us learn to stock some of these things. But assume that you are the only person around, the only health worker in the place. And then the question is, what do you do? There are procedures. Attempt to get out the venom. The presentation of the symptoms will depend on the species of the snake. All right? Some will cause bleeding, others will cause coagulopathies, and so on and so forth. Analgesics, but don't give opioid analgesic. You know why? Because opioid analgesic may cause cardiorespiratory depression, and that's not what you want. That may actually worsen the symptomatology of the poisoning. Antibiotics, because as the snake beats you or beats the individual, may have also introduced tetanus or some other things. So you need antibiotic cover as well. We're almost done. Now, this is an aspect I thought that we need to look at. Why so? Because this is our consistency. It's our consistency. Aspirin, I've already spoken about that, isn't it? Why would we need to keep aspirin? Because we can use it to check impending myocardial ischemic condition, like myocardial infarction. We need to keep aspirin, even at home. I have in my house, right? So for you, you find that you are having, by the way, many of us don't go to do our routine checks. We are doctors to other people. We know how to remove, specs from other people's eyes. Locks in our own eyes we leave. It's not peculiar to pharmacists, though. The same thing goes for doctors. One of the consultants, professors in our teaching hospital, he didn't know he was hypertensive until one of the residents came and said, "Chief, let me take your blood pressure," because he was doing his residency, all right, as part of his project. Check the blood pressure. Thing was there. He said, "Okay, maybe we should," following the check, they gave a week interval. It was still up there. That's how that doctor is on a three molecular therapy regimen for treatment of his hypertension. So it will do us well. Every year, I do, and I recommend that we all do. Once you are more than 40, the younger ones, they can play with time. But for the majority of us, particularly men, because of so many things we get ourselves involved in and the worries of life, it makes sense for you to go do your test at least once a year, know the lipid profile, and so on and so forth. So aspirin is there. We keep aspirin handy. Epinephrine, that's what World Health Organization says we should, all of us should be calling it. Otherwise, by the British system of naming, that's adrenaline, isn't it? So stock, may be useful for allergies, right? Discretion is still the better part of valor. You need epinephrine. Like I said, you can arrest bleeding by cutting an ampule, soaking cotton wool, and using it to cover, and that helps. Nitroglycerin or glyceryl trinitrate. Many of us say we have. We should keep this. Somebody may have impending angina, and just one tablet will make the difference. All right? Prednisolone, hydrocortisone for severe allergies. Don't panic. You may have to give this. Diazepam for convulsion. Salbutamol aerosol, acute asthmatic attack. That's what Dr. Akali did. Furosemide, Enuria. Now, this one that's almost no urine. Sometimes I went to urinate a while ago. Okay? There are some persons, to urinate has become a problem. Funny word. These things are dirty, but when they don't come, no trouble. So the man tells you that, you don't want to see a man who has suffering from enuria. Of course, the body will change now. All right? You see the person begin to balloon as if you are blowing a balloon. Swell. All right? Isothermia, all those features will begin to present. You don't want that. Before you send the person to the hospital, depending on where you are located, it's possible that a hospital may be some 2 hours away, or you may have to give furosemide either as tablet or as injection. That's why it's listed there. N-acetylcysteine, paracetamol is the common anti-analgesic that is available. We know so. Metamizole or dipyrone, that's Anagin, was discontinued by Mrs. Our senior colleague Dora Kunyili, when it was taken off from our essential medicine list. All right. So the real thing, I hear some persons still stock them anyway, particularly patent medicine dealers, they still do stock them, but that's illegal. So, it's available. Fake one. Yeah, fake. But it is available. The ordinary man in the street may not even know the difference. All right? So, paracetamol is there. It's available as syrup. It's available as tablet. It's available. They come in. Paracetamol comes in so many names. That's the point I'm making. And so, does it not make sense for us to have an antidote against paracetamol poisoning? Again, ask our colleagues in the hospital whether they have N-acetylcysteine. They would say they don't. Again, the embarrassment comes to the profession. One day, when the child of a very important person in society suffers from paracetamol poisoning. My friend Shinon, they make this paracetamol that is very sweet, isn't it? And when you sweeten paracetamol like that, know something. The child may go gulp the thing innocently. And then paracetamol poisoning will happen. And that's why you need to have that N-acetylcysteine. The same thing goes for this ferroxamine, ion preparation. And we stock them. Ferrous products, either as ferric or as sulfate, you know, Ranferon, is Cameron still there? Cameron, Ranferon, Orepta, Jawaron, name it, they're out there. These are all ion preparation. The common denominator for all of them is that they are all sweet. They all have sweet taste, isn't it? You have different sweeteners, right? So when they are that sweet, the tendency for children to help themselves with it is very high. And so you can talk about ion poisoning. And ion poisoning is even it's very dangerous indeed. Paracetamol is dangerous, there's no question about it, right? But ion poisoning is something more dramatic. So this ferroxamine is something. Ipecac we've already mentioned, isn't it? Many of us, or most of us, don't have it. Good to induce vomiting using Ipecac. Activated charcoal, most of us have this, and we should use. Now, quickly, we are rounding up. Triple A's in emergency. This is the child of my brain. In other words, you are not likely to find this in any book. All right? I have brought this up. Triple A's in emergencies. All right? So, can you come with me? The first A is what? The first A is what? So, when somebody comes, they bring somebody before you in your community pharmacy. First thing to do is what? Assess. It is that assessment that quickly, in split of seconds, ask yourself whether this is doable, whether you should touch or not touch. Quickly. No time for you to begin to dilly-dally, to consult. Should I not? Decide quickly. Assessment. Next is what? Analysis. Analyze quickly in your mind. And that analysis will be something like, what will be the outcome? Is this still likely to result in fatality? If it results in fatality, who am I dealing with? Keep in mind, discretion is the better part of what? Valor. The poor person you say you are helping, will come around. In fact, that's when they remember they have a brother in the U.S. They say, oh, my mother died, was given a drug from a pharmacy. That's unacceptable. That's malpractice. And then the lawyers are waiting. They will file charges against you. And that will not be helpful. Time will fail us to talk about situations in which pharmacists trying to help ran into trouble. One fellow, old man, Oga Lere Bale will know this man, but I won't call his name because we're in the public domain. This man, if I met him before I went into the pharmacy school, I mean, the last time I visited him, the way the pharmacy appeared, I would not have read pharmacy. It's as bad as that. What was the situation? The days of chloroquine, sir. He was about closing for that evening when they brought a baby to him. In Benin City, they brought a baby, sick baby, to him. It was almost locking the pharmacy for the day. They say trouble doesn't blow whistle. And so he took the baby in. You know what we used to do? You first bring the temperature down with Anagin, isn't it? Madam, was that not the process? Bring the temperature down before you give chloroquine. And then you even give pyridine, chlorphenamine, and all of that. Those were the gamut of drugs that were used then. But because he was hurrying to go and he thought he was helping the baby and the mother, gave jab of chloroquine injection, Anagin, and promethazine. By morning, baby was dead. My dear colleagues, senior and junior. But for the fact that this man had reached a certain level in the society, before he got his neck off the charge of manslaughter, it was something else. He was Knight of the Catholic Church, Fellow of the Pharmaceutical Society, this one, that one, that one. So he was a man of, people knew him. That's how we was able to, we could wriggle him out of trouble. When I visited him, and that's when all these troubles were over, you could count the number of drugs in his shelves in the fingers of the two hands. That's to tell you the man had been brought low. Do I need to tell you again that discretion is the better part of valor? It might have been very helpful if he had told the people, sorry. Or you give an oral medication, you understand? And then let the person go. So you analyze quickly what will be the outcome of all of these actions. Then the third one is the action itself. You need to quickly take action. All right? And then it follows like that. It's in that order. So the triple A's: assessment, analysis, action. In what? Split of a second. Quickly. The shortest possible time. Decide whether you want to be involved or not. Now we're almost rounding up. Few minutes. So what do we have? ACPN should develop guidelines which should contain the following. Who to contact in case of emergency. Right? I hope the chairman is there listening. Right? A committee can be set up. Don't wait for PCN to do this for you. Don't wait for PSN to do so. Don't wait for Federal Ministry of Health to do so. You can start the process. Let them begin to, dot the I's, cross the T's. Because you are the one involved, take action. Initiate it. Expectation from pharmacy staff should be there. Who does what? Call it standard operating procedure, if you like, SOPs. All of these things have to be developed. All right? Conditions that staff should stay away from. In other words, whether you are there, is an intern pharmacist, all of this, make certain rules and say, for this category, for this kind of patient, please don't touch. Make it a rule. Don't touch for this category of patient. So they know that they are not supposed to touch. All right? Insurance for pharmacy staff. That's very, very important. Because you can't be doing emergency. Keep in mind, yes, you are a health worker and all of that. See, if you know the number of doctors, one reason why doctors don't even feel like practicing in the private these days is because of possible litigation. The old man comes into the clinic. Many of them wish they read pharmacy, I tell you, because of the trouble involved in practicing medicine. An old man comes to the clinic. An old man of 90 years that's already having one leg in the grave comes into the clinic and in the process dies. I witnessed one, my friend, the professor. He has a private clinic, big private practice in Benin. I was there to visit him. You needed to see the show. Somebody had died in the clinic. And the people came to carry the corpse away. And then the matron said, sorry, you are owing this hospital 140,000 naira. I say, what? What did you say? One for what? Did I hear you clearly? So they say, carry that corpse. Let's see who will stop you. The matron tried to, to resist. They picked her by the hand, those bouncers. Used her to stone the wall. Everywhere went dead. That's how they carried the corpse out of the place. So you can see how embarrassing it can be. We want to be involved in emergency, but not to hurt ourselves. Insurance for pharmacy staff, consider that. Methods of keeping records. This has been said again and again. I need just to add that I was part of the consultants that worked for SFH. All those findings are true, embarrassingly true. Pharmacists don't keep records. They don't. The survey we did was nationwide. Pharmacists don't keep records. I don't even understand what is wrong. Why don't you keep records? Suppose somebody comes around and accuses you of this is what you did, this is what. Can you not say, look, no, on that day, was it not 12th of September? No, you came to that. This was how you came in. This was the condition. This was what we wrote down. People can see that you took record. You just go blindly and then you give injection. You do this, you do that. I don't understand. How are we different from those persons who are poorly trained? My elder brother has said so much about that. I don't want to flog it some more. We must change our attitude. We have to develop a referral form. In the Federal Ministry of Health, this is being done for patent and proprietary medicine vendors, how to fit into the national concept. We also have to have a referral form. The Benin ACPN, they did something in collaboration with the doctors, have a referral form, you can complete, and then the patient goes with it. You have your own copy, so you can say this was the extent. I remember you people did that in Benin, right? Okay, need for training. Chairman, ACPN, you may have to call experts. Find time, call experts. I'm also thinking of asking PCN to do this, asking SFH or some other agencies so that the cost can be less on you guys. You need training on cardiopulmonary resuscitation. We've said so, how to massage the heart, how to do this. You see, there's a difference between, reading how to drive a car, we all know, and then carrying the key and driving. There's a difference, isn't it? You say you do this, you pedal down, you start the ignition. Go and try and see whether. The same way, read how to fly a plane. Maybe by the time you are airborne, you will forget the button to press to come down. And then that will be it. So, injection administration. I've highlighted this one in red. Why in red? Because that has been point of antagonism by our adversary, sadly the doctors. They don't even want to hear that we are giving injection. Some of us, we are working. The truth of the matter is that, it is beyond them. It is beyond them. Number of health workers in Nigeria far from the World Health Organization recommendation that we already have said, isn't it? So whether you like it or not, you as a pharmacist, you will be performing doctor's role every once in a while. My argument on this injection thing is this, and I tell the doctors, by the grace of God, in where I am, respect is not in short supply for me. Thank God for that. So when I speak, my voice carries reasonable weight where I am in Benin. Right? I asked them, the military in Nigeria, in some other places comprises of 4. In Nigeria comprises of 3, namely Army, Navy, Air Force, isn't it? In America, you can talk about the Marines, aside from all of this. Everybody, I don't know, some of our colleagues are from the military, they have military background. Everybody, once you are recruited into the military, you are taught to use a rifle. You are not an infantry, you may be a pharmacist, but you will learn to use a rifle. And you'll be taught the very basics. That's the way we should be looking at injection. So nobody should be looking at injection as something, it's only for doctors. No! Every soldier, everybody in the military knows how to, because in an emergency situation, and it happens, is it General Pukbola, one of those commanders in the ECOMOG, during the headquarters was besieged by the Charles Taylor's forces. Cooks, everybody, rifle, take. That's the way they were able to repel the attack by Charles Taylor's men. So you cannot be a soldier and say, I'm not an infantry. That's the way they want us to begin to behave. You say, I'm a pharmacist. If you are a pharmacist, you cannot give intramuscular injection. Chew, can give intramuscular injection. Ladies and gentlemen, who will be respected? DJ Chew. We know how dramatic injections can be. You give somebody injection. Asthmatic patient came into the pharmacy. I was there. The woman, just like you tried to describe, the woman was distressed. You know what? She came with her aminophylline. Came with a syringe, as if she was ready. She had bought all those things at home in case she was distressed. You could see her eyes were almost, where is the pharmacist? Oh, I'm dying. Oh, so who will help me? So you expect me, my dear colleagues, pharmacists, to say, Madam, I'm a pharmacist. Oh. My own is to advise you on drugs. And then send her away. I went to work, gave her the bolus IV. like I said, you see how dramatic these things are. As you push the aminophylline into the vein, you see, oh, God bless you. Oh, pharmacist, thank you. The airways are broadening, they are relaxing. They are, you see the manifestation. But the question will be, did I continue treating her? The answer is no. I had done what was expected of me to do. So this is what, Egbon, we will have to be talking along this line with the registrar, with the Federal Ministry of Health, so that our colleagues, doctors, will begin to see these things for what they are. That you are able to give IV injection, you can give subcutaneous injection, you can give bolus IV. That shouldn't make you, every soldier doesn't carry a rifle, but when matters come to it, the average soldier knows what to do with a rifle. That's the point you are making. It's not your business on day-to-day basis to be giving injection. But if the need arises, if it is compelling to do, you will do it. And life will be saved. That's the point we are making. How many of us actually know how to use inhalers? All we know is that we can, hey, madam, you want ventilator inhaler? Take. How many of us actually know how to use the inhaler? Thank you, ma'am. Many of us don't know. We need to learn all this. You give injection. You are, okay, all right. That's the US training. Then I put something there again, basic what? Suturing. Just like I made the analogy with the rifle. That's how suturing should be. Well, I don't know, there are certain kinds of suturing. I do a lot of suturing in my laboratory. You know, we do surgery. We want to induce hypertension in a rat. There's a way you go. You remove one kidney, you tie the other kidney up, give sodium chloride, the blood pressure will shoot up like that. What we call figure 8 hypertension. So we do all of that. So basic suturing cannot be something too much for a pharmacist. But here, see, let's put it this way. The good doctor is a doctor that knows his limits. The good pharmacist is also the pharmacist that knows where to draw the line. If you push too beyond this, people will ask questions. Even in teaching hospital, they ask questions. This thing should have been referred to UCH. Why did you have to keep the patient? There are certain things that are needed in the emergency box of life first aid box. They are all listed here, right? We will not waste time on that. Okay? Money. Can we read that one together? Making money from what? How will you render services and nothing is coming back to you? Money needs to be made. I thought somebody stood here. That guy from Dr. Morikunle. Huh? Yeah, okay, he has. I so much love the way the man, as he spoke, in many respects, I felt like he was in my mind representing who a pharmacist should be. All aspects of pharmacy, the man was available in his community practice. So why would we need money to think of how to make money? The pharmacy needs to grow. Bills have to be paid. S there for bills. Bills have to be paid. Services not paid for are often not valued or taken seriously. True or false? People don't pay. You have a legal matter, you visit your lawyer friend, you will find that they have a way of taking the money from you. Okay? Next, other professionals get paid for rendering services. So why not pharmacists? And then professions are often respected based on how rich they are. God forbid that you tell your daughter, you want to say, daughter, have you thought of pharmacy? Say, Daddy, pharmacy. Pharmacy. When we live in miserable, abject poverty, pharmacy. Even your wife will go behind and say, when you hear farm, don't put the mercy. So money is important. There's no question about it. And look at that. What's that man saying? Can we read it together? Money begets respect. That's internally true. If I was a billionaire, even Akere Dolu yesterday, His Excellency, he will leave his seat, he will look for me and come and greet me. You doubt that? That's the reality. So money begets respect. Professions will be respected on account of how much money the people see around. You don't want to be in the church, say they are doing harvest. Pharmacists, how much are you donating? Say 50,000 naira. Then they call another head professional to make donation. He says he's giving 800,000 naira. Pharmacist, 50,000 naira. The other professional, in all this, his children are even many, he has more children than you. So what will be your excuse? So we must think of how to make money. I'm a lecturer, or if I knew how to make money, I would not be a lecturer. So I want to implore all of us, urge us, to think out how we build money component into these emergency services that we want to render. That is very, very important. That's what I'm saying. All right? We need to keep notebook for the emergency services we render. Again, talks about records, which Egbon highlighted. No. Certain things are painful about pharmacy. We have to change our attitude, I tell you. We change our attitude. We're not different from ordinary persons, lay people we criticize. We're not different from them. That's not fair. Full name and address of the person who has suffered the injury or the illness. We need to take date, time, place of attention. Put everything there. What happened after the first aid service was rendered? Nature of service that was given to the person. Name and address of the person who handled the incident. All of this have to be noted, because you never can tell. Well, ladies and gentlemen, we now are at the end of it all. I've spoken for a very long time, and that's because I have taken my time. I think that these are practical things that we need to go away with. And when we get to this point, I usually request, with profound respect to seniors here and juniors alike, can we be upstanding? Can we be upstanding? Well, we've spoken for so long, but these are the things I want us to go home with. What's the salient thing? What's the first thing? Madam, sorry, Oga. Can you show let's see this. See this. Like, where is it there? Can we read that first one together? They are varied. It can come in any form. What is the next one? We should be careful. We cannot afford to be playing Portia's Pilate. Say, they call you to, somebody has asthmatic attack. You say, asthma, You say, well, I'm a pharmacist. You say, look for doctor. Look for doctor. They go and call a J2. And the J2 will attend to the person. And the person will be relieved. And you want to keep your respect, your dignity intact. Does that make sense? It does not make sense. So we have to keep thinking. All right? That third one is what? Good emergency services can save lives and enhance what? Emotional bank account of the community pharmacist. Emotional bank account of the community pharmacist. How many of us have read Stephen, I know Egbon would have read that, Stephen Covey's book on, you have read the book. How many of us have read the book? Good. You need to read the book. There is something called emotional bank account. What will make the society to be given to you? What will make the president of the Federal Republic to when you present something to him, the thing will go through like that. When you have an event, what will make people come around you in your neighborhood? Say, that pharmacist. They say, that man, they do the thing. That's what we refer to as emotional bank account. And I can tell you, if you are able to source this emotional bank account, you can't tell. I did my inaugural lecture sometime. My lecturer. Before I knew it, drug companies had taken the bill off my hand. By the time I reckoned what was described as one of the most successful, if not the most successful, some 3 million naira had been expended on that inaugural lecture. Left for me, it will not be more than 200,000 naira. because I be lecturer now. But 3 million, and I can tell you of the 3 million, not a dime came from my pocket. That is what referred to as what? Emotional bank account. So when I leave you now, I go back to my hotel room. I spend maybe 2 hours writing recommendation letter. Okay, you know what we're talking? That's our job now. We write recommendation letter for former students. That is buying into emotional bank account. Some of them I may never see again, but it doesn't matter. I'll write that. And someday they see me in the US in a conference. Before I know it, I'm going back to Nigeria with $10,000. That is what? Emotional bank account. And the pharmacist should learn to get this for himself or for herself. Then, by way of recommendation, there is no silver bullet. No, deal with cases as they present, no silver bullet. What I mean is that, look, you don't say, oh, if I do this, that's the solution. The evaluation is based on the individual, the circumstances and everything. Remember the triple A's: assessment, analysis, action. Quickly, no silver bullet. Nothing like, okay, oh, why did you not give, if you gave adrenaline, the person would have been okay. Why did you bother send the person away? That was your decision. It was not a thing for adrenaline. You sent the person away. Based on the triple A's in your judgment, very quickly. No silver bullet. Nothing like give adrenaline and the person will be well. Give hydrocortisone, the person will be okay. Nothing like that. Triple A's. Evaluate for yourself. Next one, say good emergency services require what? Training and retraining. And that's why I was asking my friend, my very good friend, the ACPN chairman, can we not have a situation of training, just like SFH is doing over family planning and all of that? What would be wrong in having a training session for community pharmacists? Simple suturing. I don't see anyone who will oppose that. Processes for giving injection, all right? IM, IV, subcutaneous. These ones are modest and simple ones. And, of course, when you are being trained, you also be told areas you should not go to. That's why training is important. And then, what is this last thing that I've been repeating over and over again? Can we read it together? Discretion is what? Is the better part of valor. Decide the extent of involvement in emergencies. We have done pretty well with time, so permit me to thank the chairman of ACPN and his ESCO. We have been friends, and so he just called me and said, Prof, can you come and talk to us? That's less than 2 weeks ago. I said, okay, it's all right. What do you want? He said, without guidelines, so. Prof, we mark with marking scheme. No guideline. He said, what is the topic? He gave the topic. No guideline. I said, okay, I will think of it and I'll do something. Thank God for making today possible. Now, I have taken some slides, and it has to be acknowledged. For us in academics, there's something called self-plagiarism. I don't want to be accused of it. So I've taken some slides from previous lecture delivered to the students of the West African Postgraduate College of Pharmacists, and the Secretary General is here. My apologies, sir. All right? Then, of course, in the internet, I have used some pictures. You saw that for yourself, pictures from the internet. Then the last word there, that's the motto of my secondary school. We must put God. God is a key factor in all the equations. So, ad majorem gloriam Dei, everything to the greater glory of God. So, I just want to say thank you for the opportunity. God bless you. Thank you. Chairman.
It's okay. Please, we're at the West African Postgraduate College. He's here with us. Please, let's give him a round of applause. Professor N.N. Wanang.
So thank you very much for your patience. Very quickly, we'll take just 2 company presentations in quick succession. I'll be calling up on Tandem Pharmaceuticals for their presentation.
Announcement, please. Please take note of this announcement. This number of states have issues with the neck, and they have been given instruction to go and resolve their issues. Please take note of this this information. Very important. Kano State, Plateau State, Kwara State, Ebonyi State. You have up to this evening to resolve your issues. But if you don't do that, the NEC has passed a resolution that your delegates will not participate in tomorrow's election. I hope I'm clear. Kwara State, Kano State, Ebonyi, and Plateau State, you have been requested to do the needful. If you fail to do it before the close of today, sorry, you may not bother to come for election tomorrow. Thank you very much.
Please, what that means is if your chairman is not here and you are a delegate from any of those states, please get in touch with them. Let them do the needful so that you can participate fully in the AGM tomorrow.
Good afternoon, distinguished ladies and gentlemen. My name is Ngulube Paul. I'm a pharmacist and I represent Vital Biotics. Today I'll be speaking on osteocare. Osteocare is one of the ranges of Vital Biotics product. It's a comprehensive healthcare product that has been formulated by experts. And it is known as the UK #1 supplement when it comes to bone health. So osteocare is the UK's #1 bone supplement, and it is regarded as the ultimate calcium therapy. How do we justify osteocare as the ultimate calcium therapy? By scientifically highlighting its rationality and concept. We as human beings need calcium on a daily basis and also on a lifelong basis. For kids who are 1 year old, they need a minimum of 800 milligrams of calcium on a daily basis, while for adults, they need double of the dose, about 1,500 milligrams of calcium. Hello, men of honor. Please, I will need your attention just for a few minutes on osteocare. But daily intake from dietary sources is far below the recommended daily allowance for most of the world. This major reason is because of the low consumption of milk and milk products. Milk and milk products account for 75% of the total body calcium requirement. If milk is avoided, you actually cannot get the daily requirement of calcium by obtaining it from other dietary sources such as soya, fish, leafy vegetables, or fruit. For calcium to have its full effectiveness and utilization, it has to be accompanied or with magnesium. Magnesium helps in the absorption, utilization, and homeostasis of calcium. Calcium and magnesium play an important role when it comes to the cardiovascular health because calcium, the physiology of calcium, when in the heart, it helps in the contractility of the heart muscles, while magnesium helps to relax the heart. So they both compete with each other, and there has to be a balance between both. A high magnesium and calcium ratio helps to prevent a number of cardiovascular diseases, ranging from cardiac arrhythmia, hypertension, and atherosclerosis. Absorption and metabolism of calcium and magnesium are mutually dependent, and the balanced supply is of optimal importance. And so being, magnesium and calcium have to be administered together. 2/3 of the body's total magnesium is stored in the bones. So calcium cannot work alone without administering with magnesium. So VitalBiotic Osteocare is the only calcium formula to have always contained a balanced calcium and magnesium plus vitamin D3 and other cofactors. Magnesium deficiency can result in reduced parathyroid hormone and its synthesis. Parathyroid hormone is secreted by the parathyroid gland, which is responsible for the calcium concentration, for the serum concentration of calcium in the blood. Deficiency of magnesium will result in reduced calcium reabsorption in the kidney and also reduce the production of bone-friendly vitamin D3. And finally, it will also reduce the release of calcium from the bone. Consequence of magnesium deficiency will result in persistent hypocalcemia, that is low blood calcium. And this is persistent even if there is, even if you administer with vitamin D3 and calcium. For normalcy or normal calcemia to occur, there has to be an optimum supply of the magnesium, which will help in the utilization and absorption of the calcium. So without magnesium, calcium and vitamin D3 would not be significant or will not have any effect. Magnesium deficiency is actually a modern-day problem. About greater than 75% of the population worldwide have magnesium deficiency. And this deficiency is not something that is that is very, very significant. It's something that takes over time before it begins to manifest. And also, it is interesting to know that deficiency of magnesium can also cause migraines, because because the presence of magnesium will trigger the release of gamma-aminobutyric acid, which is an essential hormone which helps to cause calmness and also help to relieve the effect of migraine. Vitamin D3 also is a very important vitamin, which is a fat-soluble vitamin which you cannot take away in the absorption and metabolism of calcium. So vitamin D3 plays a significant role in it. Vitamin D3 can be synthesized in the skin from exposure to UVB rays. UVB rays is a ray that you obtain from the sun, which helps in the synthesis of cholecalciferol, which is derived from 7-dehydrocholecalciferol, which is the inactive form. And also, this UVB ray can be obtained from 9 a.m. in the morning to 3 p.m. As we are all sitting down here, it is quite evident that we most often will not have the adequate amount of vitamin D3 because most of the time we are always indoor. And to be out between the hours of 9 a.m. to 3 p.m., the sun is scorching. So not everyone will be able to stay outside to receive adequate exposure to sunlight in order to synthesize UVB rays, in order to synthesize the cholecalciferol. Sunlight alone is not often sufficient to produce the required vitamin D3. Low levels of active vitamin D3 increases magnesium requirements. Magnesium deficiency also reduces the synthesis of the active vitamin D3, also known as cholecalciferol. Zinc is a very, very important nutrient which plays an important role in the entire body. We need zinc for reproductive health. We need zinc as an antioxidant and also an immune booster, and also it plays a very significant role when it comes to proper utilization of calcium together with magnesium and vitamin D3. So Osteocare is the best calcium supplement your money can buy. It is the #1 bone health formula in the UK and in so many other countries. It has been scientifically developed on the basis of the very latest research. It's a heart-friendly formula balanced with magnesium. Like I said, magnesium and calcium are very important when it comes to cardiovascular health, as calcium helps in contractility of the heart, while magnesium, acting to compete with the effect of calcium, helps to relax the heart. 100% ROD of calcium combined with cofactors including zinc, magnesium, and vitamin D3 are all fortified in Osteocare. Men and women have different requirements for calcium, especially aging, especially the geriatrics. People from 60 years and above require higher amount of calcium, but for the women is an exceptional case because of the effect of menopause. Because once a woman is at menopause, her calcium requirement goes up because the bones become very thin and they need calcium. If not, it could lead to the very popular bone defect or bone disease known as osteoporosis. And some of the reasons why the older women experience bone loss easily are: 1, the bone mineral content tends to be lower in women than in men. Their dietary intake may decrease with age due to the physiological changes of their digestive system. And certainly, for some certain women, when they grow old, they may not be able to feed on certain particular diets because of their health conditions. So they'll be lacking in calcium. The rate of bone loss, like I said, accelerates with menopause. So there is an increased need for increasing the level of calcium. Some of the active ingredients in Osteocare include calcium carbonate. We chose calcium carbonate because calcium carbonate can dissolve better in acidic environments, so it should be taken with food. So once you take, when you're taking your Osteocare, you have to take it with food or after food for better absorption of the calcium. Some of the home messages: the overall calcium consumption tends to be lower than in recommended intake. That's the consumption of calcium we take on a regular basis cannot make up for the recommended intake due to certain issues such as food devaluation. The calcium we get from foods like grains, leafy vegetables, and other forms of fruit, due to certain effect of storing the food, the minerals and other important micro and macro elements present are reduced due to the method used in storing the food, such as the preservatives used. This could reduce the content of the calcium and other important minerals present. Okay. So some of the indications for Osteocare include: during the first 20 years of age, this helps for full or peak bone mass, to improve the bone mass. For pregnancy, this helps to maintain pregnancy as well as to prevent the risk and complications that are associated with pregnancy. Breastfeeding and breastfeeding. For breastfeeding, due to the low vitamin D in our body, and as well as the low concentration of calcium, pregnant mother need elevated amount of calcium in order to increase the secretion of the calcium in their breast milk, and as well as to protect their bone when they begin to age. Also, the use of Osteocare will help prevent or serve or serves as an additional therapy in the treatment of osteoporosis. And it is recommended that women who are gotten to the point of menopause and also above the age of 60 should increase their calcium intake. So Osteocare provides that essential and comprehensive formula needed to give the desired result. So, but this is in no way excluding the men. Though as men we have bigger bone mass compared to women, but as we begin to age, these bones begin to break down, and it breaks down faster before it can build up back, before the bone can rebuild itself. Sorry. So some of the other indications include premenstrual syndrome, hypertension, and heart disease, recurrent kidney stones, colon cancer, and diabetic osteopenia. Calcium, magnesium, zinc, and vitamin D also play an important role for strong bones and teeth, which are needed by kids. Vitamin D helps to maintain calcium levels in the blood. Vitamin D helps to absorb and utilize calcium and phosphorus. Calcium and vitamin D support the growth of bones in children. Osteocare, like I said, is UK's #1 supplement and also has been recommended by experts such as doctors, pharmacists all over the world. And it has been chosen as the #1 or the drug of choice when it comes to bone health, bone supplement. So as pharmacists, as men of honor, I urge us to consider this Osteocare. I know some of us are very aware of it, but it's a brand to be recognized with because it has been tested and trusted by the highest authority to have shown to be efficacious when it comes to the management of bone diseases. So our stands are outside, so you can visit our stands to patronize our products at the Vital Biotics stand where you can get our Osteocare. And once you buy some of our products, like our Osteocare, you get some freebies. Thank you very much. Sorry, and finally, it is marketed by Nectar Pharmaceutical. These are some of our corporate lines that you can reach us on. Thank you. Any questions, please?
Thank you so much. We all know our time is fast spent, but we are rounding things up. There were two questions that we had the other time during Prof. Ray's presentation. Prof quickly want to do some justice to it. Few minutes, sir.
Thank you. I hope I still remember clearly. Former President Okwo, yes. Is Oga still around? Oga is there. And then the revered senior colleague next to him, they raised the point, and it pains me that while developing the slides, I didn't include that. We're all aware of the cases of sniper, suicide attempts, all of those things. They are commonplace these days, isn't it? I'm very sorry I didn't think about this while I was developing the slides. One of the things we ought to highlight. So, very briefly, sniper is an organophosphate. It's supposed to be an insecticide, right? An organophosphate. But please keep in mind that these organophosphates are what you also have in chemical warheads. So when you talk about chemical weaponry, most of the time organophosphates, TPP and what have you, they began with Hitler those days. Of course, the British scientists had to look for antidotes, okay, something called pralidoxime, or Tupam, to nullify the organophosphates that the Germans built into their chemical warheads. So, sir, if there is an acute intoxication, suicidal attempt using sniper, usually the presentation will be hyper responsiveness. There are reasons for this. Action potentials will be generated, spontaneously. A single touch will result in multiple responses. Okay? So what to do? The person can also go into convulsion. So what to do? Diazepam. Diazepam. Why? Because diazepam, the way it works, it potentiates inhibitory processes. That's why it gets people to sleep. So consider diazepam. And it's very, very important that I said it earlier, training on how to do IV administration of diazepam. Oga Uche, you at work, at play, and on bed, you are with a medical doctor. So one would expect that you know how to give IV diazepam. If madam is not telling you, not wanting to perfect your hand, of course, I know you know what to do. You don't want to send her back to her people. The point I'm making is that it is very, very important for us to know how to do some of this IV administration. All right? IV diazepam, all right, will help in situation of that hyper-responsiveness that comes with intoxication with a sniper. All right? Then you can do, if the person has not, if it has not been too long that the person ingested that sniper. How many of us know something called cholestyramine? Kesran. Kesran sequestrates, chelates. So that it chelates, seizes the thing from being absorbed, and then the thing can be excreted. And that's the solution to sniper intoxication. This is very important so that nobody say, oh, the person has taken a sniper. By the way, we lost somebody in the faculty. The young lady took sniper in pharmaceutical chemistry. Well, she had suicidal tendency. This lockdown. The husband traveled, and so nobody to play with, nobody to talk to, and no baby yet. So she had always had that suicidal tendency. So if school was open, maybe going to school, we'll be interacting with people. Now, how do you find a lady who already is known to have suicidal tendency, lock herself in day and night and so on and so forth? I think what triggered it is she went to the clinic and then missed what they call amenorrhea, no pregnancy, no messes. So to her, that means that, okay, everything, what am I living for? And so she took sniper. All right? So let us not get panicky over some of these things. We can do something. Please, assume you don't know how to administer IV. You know what you can do? You can give by mouth, provided that the person can swallow. You can grind the diazepam tablet. Rather than make one tablet, you can make it as much as 5. You know why? You want the higher the concentration in the GIT, the faster the thing is absorbed. That's what you want to aim at. The consequence will be that the person will sleep and sleep for too long. Then you would have achieved your aim. So that you are not able to give IV diazepam is not a reason why you should not do something. You can crush the diazepam tablet, many tablets, and then put it into the person's mouth. Something good will come out of it. Then, when I was through, some senior colleagues came to me and spoke about how they intervene, scorpion stings, and I think that scorpions, then somebody mentioned something about snake bite. Use a particular lady, I don't know where madam is now, spoke about using potassium permanganate for snake bite. Who has that experience? I don't know. See, let us be careful. There's something we do in science. Remember, not all snakes, only about 10% I say that are poisonous, all right? That somebody was bitten by a snake, then you give potassium permanganate. Even if you had given ordinary water, the person would have lived anyway. You now associate it with potassium permanganate. It will not be scientific. So my question to madam was, how many such cases have you experienced? If you have experienced 1, 2, 3, 4, then we can come to terms with it and say, look, potassium permanganate is likely to be an antidote for snake bite. But a one-off situation, no, science doesn't work that way. The person may have lived, if ordinary water or anything, olive oil or anything was given to the person, the person would have lived all the same. But yeah, let me conclude this. Then somebody spoke about scorpion stings, that you use chloroquine, all right? Just give what you call intralesional chloroquine around the point of envenomation with the scorpion sting, chloroquine injection just around that spot, and then the person gets relieved. Well, there's some scientific explanation to that. That's because chloroquine has some local anesthetic activity, some analgesic local anesthetic activity that's established scientifically for chloroquine. So that may be the basis upon which this could be an antidote for scorpion stings. Granted that it's not reported in literature like this. Now, giving somebody like me that kind of information, that means Professor Wanang is still around. We can go back to our laboratories, maybe put one final year project student on this or an MSc student and say, look, let's find out whether it really is the case and how efficacious it is compared to using lignocaine, which is a local anesthetic as well, and it's also recommended for treatment of scorpion stings. But please forgive me. You know, a lecture such as this, where do we begin? Where do we end? I had used my discretion to pick certain conditions I considered suitable for us to discuss as emergency conditions. But that does not mean that I exhausted every possible emergency situation. I hope that is understood. Augustine has something to say. Thank you very much once again.
Thank you, Prof. I was wanting to say that I used to think phenobarbital is better in the management of convulsion than diazepam. That was just...
Okay, well, we're entering into pharmacology class now. August's impression is that that he used to think, good that he used to think, that phenobarb is better than diazepam for management of convulsion. Good that your knowledge or your impression is in the past. Phenobarbital is no longer so recommended for many reasons, right? First, the most superficial, is that barbiturates, phenobarbital, hastens the metabolism of many drugs. You still remember this? Barbiturates are enzyme inducers, though they facilitate the metabolism of many drugs co-administered with them. One. Second point is that the abuse potential, abuse liability, dependence liability of phenobarbital is far, far higher than that of diazepam. You get it? And then thirdly, the safety margin of diazepam wider than that of phenobarbital. Are you following? So, in any case, diazepam is more convenient in terms of use. So these are reasons why, particularly that abuse potential. Even people like you who would have wished to use phenobarbital, you are not likely to find phenobarb as such again on account of this abuse potential. I hope that answers the question. God bless.
Thank you, Chairman. Thank you very much, Prof. We'll listen to the last presentation quickly, please.
Thank you very much. Stephen, fine. Good afternoon, everyone. I know it's a well-spent day, and in the next 10 minutes, I want to tell you how we can unlock the untapped potentials. All right. Do I have a slide changer? All right. Thank you. I'll be talking about unlocking untapped potentials in community pharmacy practice in Nigeria. My name is Adekola Ojola, Managing Director, Mega Healthcare Distribution Centers PLC, based in Lagos. I'll tell you about what we do, and I'll tell you how it will benefit you as a community pharmacist. So very briefly, this is my introduction, and we'll talk about how to register on the platform, okay? Okay, so it's well known, it's no news that the patient to pharmacist ratio for Nigeria is very, very low. That's 1 to 50,000. In Ghana, it's even better. And across the world, we have one of the poorest. So what that means is, because the pharmacy is the first point of call in any community, there is a very, very big void. And you agree with me that nature abhors vacuum. So if we are not there to provide pharmaceutical services, some other people will be providing it. So with this wide gap, we will need to look at how we can fix this gap, how we can close this gap. And what that will mean is probably we would need to have maybe 10 times more pharmacy schools than we have right now. Or probably we have to churn out, 100 more pharmacies in the next couple of years, more than we have now. But we all know that is not possible. So how do we close this gap? Very easy. Whatever we can do, technology can help us to do better. So we talk about the sparse number of pharmacies we have in Nigeria, manned by pharmacists. And so the question is, how can we, with the little number of pharmacies we have in Nigeria, how can we reach more patients that need our services? And we begin to look at it in the context of technology. We'll be able to see that if we, as pharmacists, are able to manage our inventory in what we call a just-in-time manner. Just-in-time is the opposite of just-in-case. So many pharmacies order products not knowing what will happen tomorrow or what will happen next week. So if I want to order, I'll just order everything I think I need without trying to find out exactly what I need on a daily basis, which is the standard globally. So with just-in-time inventory management, what it means is that you can actually have savings from stock. And the assumption generally is that when I have a lot of stock, I have a lot of assets. That's not probably the reality, because if anything happens to that stock, it becomes a liability to me. If it expires, I need to look for the reps. I need to look for how to disburse the stock in a very short time. And you and I will admit to the fact that we lose a lot of money because we do not have means of quickly exchanging this stock when they are close to expiry. So the solution indeed is how to keep the minimum stock per time. And when we keep the minimum stock, we'll be able to free up our resources so that we can even use these resources for, expansion of our stores. So the whole idea is that if every pharmacist in Nigeria is able to own like 10 retail chains, what would that happen? If you multiply that by 6,000, we have 60,000 pharmacies, okay? If we have 60,000 pharmacies, there will be no room for other people who are not pharmacists to control the drug chain in Nigeria. So what we're introducing is a just-in-time arrangement, and technology can help us to do that, because technology has helped, the transportation arena. Most of us came to this auditorium via Uber today. Why? Because you check your phone, you're able to look at where you are, where you're going, and there's a driver available, and it takes you there. If technology can help us to do things like this, I'm sure every one of us here has attended a Zoom meeting in the last 1 or 2 weeks, or even yesterday, or even today. So if technology is helping us to stream this kind of meeting to every part of Nigeria and every part of the world, why not in pharma distribution? And so that's the whole idea of Mega Medex. So it's very, very clear that for us to tap into the untapped potentials as pharmacists, we need to use technology to drive distribution. So what are we talking about? Here in Nigeria, we've been able to use technology to reduce counterfeiting of medicines from 40% in 2001 to 16% in 2015. That is a very, very great task that NAFDAC has been able to do. And what that means is that with the use of phones, you can actually check whether a product is, valid or not. So what else can we use technology to do? In the United States, where we have some best practices across the world, they've been able to use technology to know how much stock do I need on a daily basis. I punch in that amount of stock. I look for the manufacturer that manufactures that drugs. I put in what I want, and by tomorrow morning, I get exactly what I want. If I need another one tomorrow, I'll punch it into the system. This is exactly what we are driving with Mega Medex. So Mega Medex is a one-stop solution, and it's a just-in-time solution for pharmacies in Nigeria. And it's a platform where suppliers come and display their products, and pharmacists come and view what is available, and they order in a just-in-time arrangement. We are licensed to do this. We are a PCN licensed mega distribution center, and the PCN advocates that every pharmacy, every hospital, every kind of drug distribution channel takes their drugs from drug distribution, mega distribution centers, and that's exactly what we have. So we are licensed to do this, and just like I said, we're a one-stop resource for pharma needs, and our vision is to ensure that every pharmacist is well equipped to be able to develop and grow into wherever you want to grow into, okay? And so this is what the platform looks like. You view the platform, you look at what you want, you look at the manufacturer that distributes the product, or the supplier or the distributor. You click on it, and you are able to make a selection of your products. Even after comparing prices, you pay the supplier, and we are able to pay the supplier in 7 days. So it makes the distribution chain very, very easy. What does this mean to you? It means convenience to you. You don't need to leave your pharmacy to be looking for product. It's a well-known fact that many pharmacies don't spend enough time with the patient. If we spend more time with the patient, we'll be able to utilize everything Prof has told us today. We'll be able to improve community pharmacy practice, and we'll actually want the patient will want to visit us again and again, because they know we'll always add value to them. But when we don't spend enough time in our shops, in our pharmacy practices, we are not able to deliver that value which will make them to look for us again and again. So you are going to cut travel time, because in the comfort of your pharmacy, you are able to order what you want. Another one is speed. I just told you we are able to supply you. For people in Lagos, we do in the maximum of 48 hours, you get what you want. If you're outside of Lagos, we have an arrangement of between 3 to 5 days, so you get your products. You're able to grow faster because you have insight. So whatever purchase you are making at the back end, you can go back there and you can view the trends. Okay, you can know, all right, I've ordered so much of, augmentin. Why don't I do this, for this other product, or which product really moves in my pharmacy? So you have the data to help you with planning. And also you are able to save your energy, because on one platform you're able to see everything you need, and you're able to order for more. And more so, you are able to use the credit on the facility. There's a credit facility on the platform, what we call the Mega Wallet. You go in there, you don't use your own money, you use the money on the platform, and you replenish it on a monthly basis. So what this means to you is convenience, it means speed to you, and it means that this is the way to go. So what do I want from you? I want you to sign up to the Mega Medex platform. We have our reps moving around, and we have our stand right there at the back. Please just go on and register on Mega Medex. All you need to do is to fill the registration form and submit. So thank you very, very much. That's the end of my presentation. I did it in 10 minutes, so I think I deserve a round of applause. Thank you. Thank you, Prof. Thank you. So please, the forms are going around. Just pick it and fill it, or meet us at the stand. So we meet tomorrow again, and I'll tell you about our other things we offer as Mega Medex. Thank you.
Thank you so much. We want to appreciate every one of us that has started with us. So we quickly want to remind us that the gala night will be taking place this evening. It should start anything 6 o'clock at M&M Event Center. M&M Event Center is rightly beside Nikon Luxury Hotel here. It promises to be very, very entertaining. Please, come in the best attires you brought for the conference. The FCT chapter of ACPN will be hosting you live. And I can't just wait for the event to start. Thank you so much. We really appreciate your patience, your time for today's section, first and second plenary session. We hope you have been fully imparted. So we quickly call on Farm Otote to help us with the closing prayer for today. Thank you so much.
Thank you.
The hall is empty. Shall we rise and pray, please? In the name of the Father, and of the Son, and of the Holy Spirit, amen. Father, we thank you for bringing us to the end of this session successfully. We have come in search of knowledge. We thank you for our colleagues who have been able to impact this knowledge on us. We pray that as we live here, we may be like the fertile soil. Let this knowledge germinate so that we may use it for the betterment of mankind. We ask for journey mercies at the end of this conference for our colleagues who will be traveling back to their various stations. And as we go in and out of our conference venue, we ask for your guidance, for journey mercies, and for protection. We thank you all this in Jesus' name. In the name of the Father, and of the Son, and of the Holy Spirit.
Thank you. See you at Gala Night.